The meeting is being live Got it.
Hello, everyone. I am Dr. Rashesh Diwan, the organizing chairperson for Isacon 2021. I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiologists and the organizing team of Isacon 2021. We all know we have passed through a very difficult phase in the life, and now gradually we are trying to overcome the situation. Many of us suffered the pandemic, and of course, many of us also worked for the pandemic for the community, and we were praised all over the country and all over the world. It was a great learning time for all of us. However, we missed the last year completely for the academics. But now we are beginning, and we are beginning with a very mega academic fiesta under the banner of Indian Society of Anesthesiologists. This is the biggest ever hybrid conference happening for the next 5 days. I am sure you will enjoy the most. We have made a humble attempt to accommodate as many presentations as possible. And in view of the overwhelming response for the presentations, we extended the conference on the pre-CME day. This is the today. We are starting today at 8 o'clock, and we have plenty of e-papers accommodated for one day. Once again, I thank you all for the participation in Isacon 2021 and wish you good luck. Stay safe. Long live ISA.
हाँ एक स्लिप है वो मैं बस अपना सामान उसमें से कुछ ले रहा था
अरे हेमंत माइक ऑफ कर यार कर दे
Hello.
Yes, sir.
Hello, yes.
Yes, sir.
So, welcome to the first session. My video actually, can you see me? I was trying to start my video. Can you hear me?
Yes, sir. I can hear you. First, we can show the CV of chairperson.
Okay. So, I am the chairperson.
Yes, I wish you.
Hello.
Yes, sir.
Yes, somebody has to take over, right?
Yes, sir.
I'm the chairperson. So who's the moderator?
Sir, the moderator is not coming yet, sir.
Okay, you skip the slide, then we'll just move ahead. I don't have a list of the participants.
So we can move to the video.
Yeah.
Okay, sir. Thank you.
Myself, Dr. Mitchell Kedaria, second year resident. My e-paper title was a comparison of the caudal epidural dexmedetomidine with the tramadol as an adjunct to ropivacaine 0.25% for the post-operative analgesia in the children undergo intra-umbilical surgery. Introduction, the concept of the pain has been defined as explained from the many dimensions. Caudal anesthesia is a commonly used regional anesthesia technique in the pediatric patient, useful in the providing peri-operative and post-operative analgesia as the sacral anatomy better visualized, and the spinal cord at lower end L3 than the adult. So chance of the dural puncture and cord injury is the less. with the caudal approach than the epidural. In the material and method, there are 60 pediatric patient inclusion criteria. Group RD is a tramadol, group RD is a dexmedetomidine. A is a grade 1 and 2, age 2 to 8 year, exclusion criteria. Children with a congenital anomaly, mental retardation, neuromuscular spinal disease, sacral anomaly, coagulation abnormality, allergic to drug and infection to the site. In material and method, general anesthesia given, the technique of the under full aseptic precaution, the sacral cone was palpated and the sacral hiatus was identified. 22 gauge hypodermic needle was inserted in the midline in the between the
Excuse
two
me,
sacral
please go a little
through
slow.
the sacral hiatus and the angle of the 45 with the skin and directly cranial penetrated to the sacrooccular membrane via loss of resistance technique. After the negative aspiration for the blood and says ingestion of opioid 0.25 1 ml per kg maximum, total 20 ml with the injection tramadol 2 mg per kg in the or injection dexmedetomidine in 1 microgram per kg in 1 ml. The volume was given according to random allocation, group RD and group RD respectively. In observation and the result, there are the flash score and the modifier Ramsey score. Flash score, the duration of analgesia, which is time from administration of the caudal injection of the drug, time when the first dose rescue analgesia, paracetamol suppository 15 mg per kg was the required, is a statistically significant between two group. Modifier Ramsey in the immediate post-operative period, patient of the group RD has a significantly sedation up to the 4 hours compared to the group RD, which means that RD group of the children sleep easily and are arousable. Discussion post-operative analysis, the addition of the tramadol additive, ropivacaine, caudal block, prolonged duration of the post-operative analgesia with the minimum side effect. In our study, post-operative sedation assessment by the modified Ramsey sedation score, we found that dexmedetomidine is a better adjuvant single shot caudal anesthesia in the term of the better quantity of the sleep, prolonged duration of the arousal sedation in a CL post-operative period in group RD. Post-operative sedation score was significantly higher in the group RD compared to the group RD. In our hemodynamic parameter was comparable, both group V, which are not statistically significant. There is no motor block observed in the both group of the our study. Post-operative complication in the group RD, 2 patients complain of the nausea and vomiting, but not related. Conclusion, thus we concluded addition of dexmedetomidine 1 microgram per kg with the ropivacaine in the caudal block significantly prolonged duration post-operative analgesia as compared to the tramadol 2 mg per kg for the children undergoing infraumbilical surgery, reduce the post-operative analgesia requirement first 24 hours with the better quality of the sleep in the immediate post-operative period.
Okay, so can you hear me?
Yes, sir.
Yes, sir.
Yeah, you went very fast. Actually, you went very.
Actually, sir, it's pre-recorded. We received.
Okay, it was pre-recorded. Okay.
Yes, sir.
All right. No, I just wanted to. Is he available for question answer? Has he logged in? Dr.
Yes,
Mishra,
sir.
are you there?
Yeah. Yes, sir. Yes, sir.
So you, for induction, you use thiopentol sodium. Is that right?
Yes, sir.
Okay. Any justification for using thiopentol sodium in small children? You could have gone inhalation and induction with. Is this the way you normally do it in your institution where you work?
Yes, sir. Normally, in both children and adult, we use thiopentol in the induction.
Okay. So what?
Sir, could you please put your video on, please?
Wait,
No, I'm trying to put my video on, but I'm unable to do so because.
Yes, sir.
Yeah. Now, can you see me? I was not able to do it earlier.
Yes, sir. We can see.
Okay. So I just wanted to know what percentage of pentothal did you use?
Sir, 35 in adult, in pediatric, age below, weight below 15 kg, there are 10 mg per kg, or greater than 15 kg weight, there are 20 mg per kg use.
No, thiopentol sodium, pentothal sodium. And what percentage did you use?
1%, sir.
1.25% actually. So,
Okay, sir.
okay. So you used that, and otherwise you had two groups. tramadol and dexmedetomidine, and you found dexmedetomidine to be better than tramadol in
Yes, sir.
post-op pain relief. Okay, so what was your sample size?
Sample size is in each group 60 children.
In age group 16 children. So you could have also gone in for, IV induction is a little, this thing for children, inhalational induction is much better. And we have actually, done such studies. And inhalation is always preferable in young children. So which inhalational agent did you use for maintenance?
Sir, for maintenance in children, we use sevoflurane, sir.
It's only for maintenance. You don't use it for induction.
No, sir, in maintenance and induction, both we use sevoflurane.
Okay, so why in this particular study did you use thiopenton?
Sorry, sir.
I said, why in the present study thiopenton was used?
Sir, thiopenton, we do not use propofol because of the propofol is a higher effect on BP, and thiopenton in children already there are BP are lower side.
Okay, so we'll go on to the next participant.
Oh,
Thank
thank
you.
you, sir. Thank you, sir.
We'll go on to the next participant.
Guided erector spinae block. On the title of my study is effect of C-arm guided erector spinae block on reducing opioid requirement for intraoperative and postoperative analgesia in patients undergoing lumbar vertebral discectomies under general anesthesia, a prospective observational study. Background: lumbar discectomies are associated with moderate to severe postoperative pain causing morbidity, delayed recovery, and increased opioid consumption. Currently, opioids being the first-line option for patients suffering from severe postoperative pain after major spinal surgeries. Adverse events are associated with high opioid consumption postoperatively, which are well documented, ranging from severe nausea all the way up to circulatory depression. The posterior rami provide a sensory innervation to the paraspinal muscles, soft tissue, and skin at the level at which they emerge. This is of particular relevance in spinal surgery because these structures must be incised and retracted in order to gain appropriate surgical exposure. Cadaveric and MRI studies suggest that ESBP can reach the posterior rami of the spinal nerves in addition to the anterior spinal nerve rami to the paravertebral and the epidural spaces. Additionally, the ESBP appears to be relatively simple to perform and is associated with few adverse events. Patient recruitment information is as follows with inclusion criteria, exclusion criteria, and post-inclusion exclusion criteria. Method of the study: statistical analysis was done based on previous published studies with a total sample size of 50, with 25 in control group and 25 in erector spinae block group, which is the intervention. Sleeve flow chart: identifying patients who were scheduled to undergo lumbar spinal surgeries and then getting informed consent and then enrolling them into the study on the day of surgery by dividing them into control group or erector spinae block group. Control group receiving standard analgesia and no erector spinae block, whereas the ESP group received standard analgesia along with erector spinae block. Assessment was done intraoperatively, also postoperatively via pain scoring, which using the visual analog scale. All the patients enrolled in the study were administered general anesthesia using standard anesthesia technique. After which we move on to performing the erector spinae block. C-arm guided erector spinae block was performed just before the surgical incision. It was done bilaterally at the level of instrumentation and decompression. After the patient was placed in prone position and sterile isolation was achieved, transverse process was determined by C-arm. With a 20 gauge needle, the tip of the transverse process was reached, and erector spinae block was administered by injecting 0.25% of bupivacaine, 20 ml on each side, along with 2 milligrams of dexamethasone into the deep surface of the erector spinae muscle and the transverse processes of the lumbar vertebrae. Anesthesia was maintained, and heart rate, systolic blood pressures, diastolic blood pressures, mean arterial pressures, saturations, and MAP were monitored throughout the surgery. No analysis were given during the surgery unless needed. At the end of the procedure, patient was extubated when he or she met the extubation criteria. Patient was asked to scale the severity of pain based on visual analog scale scoring. VAS scoring was done immediately post-operatively, and then every 15 minutes in the first hour, and then 4th hourly till 24 hours. Patient was given rescue analgesia in the form of injection fentanyl 0.5 micrograms per kg only when the VAS score was 4 or greater than 4, and the total amount of fentanyl consumed was documented. Results: intraoperative hemodynamics in terms of heart rate, systolic pressures, diastolic pressures, and mean arterial pressures were more stable in the erector spinae group compared to the control group, with p-values being less than 0.05. The dosages of fentanyl used in the operations were significantly lower than that in the control group, with p-values being less than 0.001. As for the pain score values, according to the visual analog scale at 1, 4, 18, and 24 hours after the surgery, were significantly lower in the erector spinae group in comparison to the control group at all given times, with p-values being less than 0.001. The VASCOR values from immediate post-operative period to 24 hours were lower, were on the lower side in the erector spinae group compared to the control group, with p-values being less than, with p-values being equal to 0.023. Regarding overall rescue opioid requirements in the immediate post-operative period up to 24 hours after the surgery, the control group revealed opioid consumption higher than the erector spinae group, or 26.7% compared with 6.2%, with p-values being 0.048. Conclusion of the study is the three-arm guided erector spinae block effectively provides adequate analgesia and therefore reduces the opioid requirement for pain relief both intraoperatively and in the first 24 hours after the surgery. Reference literature was as follows. Thank you. The title of my study is Effect of three-arm guided.
Hello. Hello. Can you hear me? Hello. Can you hear me?
Yes, sir. I think the person is not logged in.
He's not logged in. Okay.
Maybe.
Overall, it was a nice presentation. And I just had, question for him that what did he use for background analgesia in the control group? But that's all. If he's not there, that's okay. We'll move on to the next participant then.
Okay, sir.
Good evening, everyone. Myself, Dr. Motiram Gindha, PG student of third year, Jawaharlal Nehru Medical College, Ajmer. My topic is a study to assess the effectiveness of intrauterine lignogen in addition to paracervical block for pain relief during dilatation and curettage. Introduction. The dilatation and curettage are two most common procedures done in daycare gynecological practice. This is associated with pain score from 4 to 7 in VAS score. This decreases patients' acceptability and compliance. So, goal of our study is to compare the effectiveness of intrauterine lignogen 2% with paracervical block for pain relief during dilatation and curettage. The developing countries like India, all such procedures cannot be performed in OTs because lack of resources and infrastructure in remote area. Hence, it is expected that intrauterine anesthesia which may reach the nerve more effectively and provide more global anesthesia, especially in conjugation with paracervical block. In my study, inclusion criteria is of age group 20 to 60 years, physical status ASA grading class 1 to 3, and duration of procedure is 30 minutes. In exclusion criteria, cerebrovascular disorder, previous surgery to cervix, pelvic radiotherapy, and previous history of any allergic reaction to drugs. Material and methods. All patients are divided into categories, group F and group N. All patients would receive injection glycopyrrolate 4 microgram per kg IV and injection ondansetron 80 microgram per kg and injection midazolam 20 microgram per kg before paracervical block. During paracervical block, 10 ml of 2% lignogen was injected through a 23 gauge disposable syringe at 4 and 0 o'clock position of cervicovaginal junction at approximately 1 centimeter depth, caution prior aspiration to avoid intravenous injections. Distillation of either 5 ml of 2% lignocaine and or 5 ml of normal saline into uterus was done using pediatric Foley's catheter. Catheter was left into the place for 2 minutes before withdrawing to limit the backflow and allow contact time for anesthetic drug to act. Pain was analyzed at 3 steps at the time of curate, immediate post-procedure, and 30 minutes after the procedures. Visual analog scores having mild pain 1 to 3, moderate pain 4 to 6, and more than 7 is severe pain. I observed that P value is significant at the time of curate and immediate post procedure and 30 minutes after the procedure in group F, that is pain score of P value 2.3 and 0.9 and 0.03 is lower as compared to group N. Conclusion: the present study concluded that use of intrauterine 2% lignocaine in combination with paracervical probe for pain relief during dilatation and curettage leads to lower VOS score with minimum and hemodynamic changes and causes no further complications. References was taken from a study of Asima Ajitab's effectiveness of intrauterine lignocaine in addition to paracervical flow for pain relief in 2016. And second reference was taken for Ratnacharya and effectiveness of intrauterine anesthesia for pain relief during fractional curettage. Thanks.
Okay, thank you for the nice presentation. So we can move on to the next participant now. Is this Dr. Has he logged in?
Presentation topic is levobuprofen versus ropivacaine with fentanyl as an adjuvant for patient control epidural labor analgesia, a comparative study. Lumbar epidural analgesia is a gold standard technique for the pain control in obstetrics. The primary objective was a total dose requirement of levobuprofen and ropivacaine. This is interventional randomized double-blind study was conducted on a Department of Anesthesiology and Critical Care and Department of Obstetrics and Gynecology at PTGNM Medical College and Dr. Bhimrao Ambedkar Memorial Hospital, Raipur. The final sample size was 70. Parchment with ASA physical status 2 with cervical dilation 3 to 5 cm, nulliparous parchment at terms with single-term pregnancy and vertex presentation who requested labor analgesia were included in this study. Exclusion criteria was any contraindication to the nitroxyl block, patient refusal or uncooperative patient, coagulopathy, history of allergy to study drugs, skin infection in lumbar region, patient who had received parenteral opioid less than 2 hours earlier, parchment with obstetric complications. 70 nulliparous parchment were allocated into 2 groups. Group L parchment received 0.1% levobuprofen with 2 microgram per ml fentanyl, and group R parchment received 0.1% ropivacaine with 2 microgram per ml fentanyl. Result of demographic profile were comparable with respect to age, weight, height, and BMI. Hemodynamic variables like pulse rate, mean blood pressure, oxygen saturation, respiratory rate was comparable between both the groups. Level of sensory block was achieved was comparable. Maximum since patient received achieved T10 level in both the groups, that is 40% patient in levobuprofen group and 40% patient in ropivacaine group. The total dose of local anesthetic consumed was significantly higher in group R than in group L. Total number of PC demand boluses were significantly higher in group R than in group L. None of the parchment in either group received rescue analgesia. Pre-block visual analog score was more than 18 both the groups. 60% parchment in group L and 65.7% parchment in group R had normal vaginal delivery. Excellent pain relief was seen in 34.3% parchment in group L and 37.1% parchment in group R. Hypotension was seen in one patient receiving levobuprofen, while 3 patients receiving ropivacaine. Nausea and vomiting was experienced by one patient in each group. None of the parchment experienced shivering, pruritus, and motor blockage. Mean Apgar score at 1 and 5 minutes was more than 8 in both the groups, and no adverse fetal outcome was observed. The total dose of local anesthetic consumed was significantly higher in group R than in group L because ropivacaine is 19% less potent than levobuprofen. Result of Lee et al. Were similar to our study. It could be due to the potency and duration of action of levobuprofen is higher than ropivacaine. Result of Attinger et al. Contradicted our study as higher concentration of ropivacaine was used. Total number of PC demand boluses was significantly higher in group R than in group L. Result of Kumar et al. Was similar to our study. Use of PC and similar to concentration could account for the similar result. Result of Chetani et al. Was different from our study as they had used background infusion of study drugs at the rate of 4 ml per hour in both the groups. None of the parchment in either group required rescue analgesia. Result of Das et al. Was similar to our study. Use of step down concentration could be the likely reason. Extent of sensory block. Result of Das et al. Was similar to our study. Use of step down concentration could be the likely reason. Result of Podi et al. Was not similar to our study as initial loading dose of 15 ml was used in this study compared to the 10 ml used in our study, which may have led to the more syphilis spread and higher block level. Result of Anadari et al. Was similar to our study as incidence of side effects are lower in levobuprofen and ropivacaine. In many comparative studies, it's not apparent at such a low doses. Limitations of a study. We have not studied the efficacy of these two drugs in high-risk parchment with ASA physical stages 3 and 4. We did not calculate the duration of each stage of labor, hence we cannot conclude on the possible effect of this drug on each stage of labor. Equal concentration of local anesthetics were used instead of equipotent concentration. Equipotent concentration of both levobuprofen and ropivacaine can be used to better differentiate between the efficacy of both the drugs. Patient satisfaction level was not correlated with ambulation due to the lack of patient compliance. Effect of ambulation on mode of delivery can be studied in future studies. Been concluded that combining levobuprofen with fentanyl is superior than ropivacaine with fentanyl when used for the labor analgesia using PCA pump. Thank you.
Okay, so what's your name, Dr. Niharika?
Mrinalini. Good morning, sir.
Good morning.
Good morning, sir. Good morning, sir. Mrinalini.
Nilanini. So may I know at what stage in the of labor did you initiate your?
Hello. Yes, sir.
At what stage did you initiate your study? What stage of labor?
Sorry,
How much
sir.
was the cervical dilatation? What was the
cervical dilation was 3 to 4 centimeters.
3 to 4. And the station?
Station is 0, sir.
Station was 0. And for how many hours after that, all of them were primary gravitas or mixed bag?
Hello.
They were all primaries. And you found...
Hello.
Yeah, I can hear you. So your study went on for how long? 8 to 10 hours?
Sir, maximum studies on 5 to 6 hours. Ended in 6 hours.
Ended in 6 hours?
Yes, sir.
But stage 2, it says you last for, what is the duration of stage 1? And duration of stage 2 and duration of stage 3 in primary gravitas. Can you tell me?
Yes, sir.
The different durations of different stages of labor in primary gravitas.
First stage of labor, sir.
Yeah. First stage of labor starts when?
So when 4 centimeter dilation, cervical 4 centimeter.
No. How do you define first stage of labor?
First stage of labor, sir, defined from the cervical dilation is 4 centimeter.
No.
It is divided into acceleration phase, phase of maximum slope, and deceleration slope.
No. First stage of labor is the onset of painful uterine contractions to full cervical dilatation.
Yes.
Okay? So that is the first stage of labor. So, okay, we can go on to the next participant. Thank you.
Thank you.
Next participant, please.
Hello everyone, my name is Dr. Mukesh Shivran and my topic for e-paper presentation is the comparison between preload versus co-load for low-dose spinal anesthesia for elective cesarean section. Now the spinal anesthesia is frequently used in the cesarean section because it is a rapid, safe, simple and reliable technique of anesthesia for parturients. Traditional preload with crystalloid fluid is used to prevent hypotension in spinal anesthesia, but the efficacy has been questioned. This is due to the rapid distribution of administered fluid in the extravascular space. Therefore, it is logical to think that the timing of infusion may be the main key to prevent hypotension because the volume expanding effect is maximal at the time of administration of fluid. Primary objective of the study is to compare the effectiveness of the preloading and co-loading with crystalloid in prevention of spinal anesthesia-induced maternal hypotension during elective cesarean section. And the secondary objective is to compare the incidence of nausea and vomiting and requirement of vasopressors. Now, the study design is the hospital-based randomized controlled comparative study design, and the sample size was determined by the power analysis based on the pilot data, and it was found that a minimum of 28 parturients per group was required. So for study purpose, we took 30 parturients in each group. A total of 60 ASA grade 2 parturients scheduled for cesarean delivery under spinal anesthesia were divided equally into two groups, that is the group P and group C. Eligibility criteria. Now the inclusion criteria we have taken with patients with ASA grade 2, patient with gestation age more than 37 weeks, patient willing to give written and informed consent. Now the technique we used, that a venous access was taken with 18 gauge cannula, and ranitidine 50 milligram and metoclopramide 10 milligram intravenously was given. Standard monitoring was done. The preload group received infusion of a 15 ml per kg of the ringer-lactate solution over 20 minutes, while the co-load group received the same amount of fluid but after the spinal anesthesia. Now the spinal anesthesia was given with 0.5% hyperbaric bupivacaine 10 milligram with the help of 25 gauge Quincke spinal needle, and the parturients were then immediately placed in the supine position with a 15-degree left lateral tilt. Also, to treat the maternal hypotension, we used mefentramin 6 milligram IV SOS, and hypotension and the incidence of nausea and vomiting and Apgar score were recorded at 1 minute and 2 and 5 minutes after delivery to assess the fetal outcome. The incidence of hypotension and nausea were evaluated with chi-square test, and the ratio scale data were analyzed and compared by student t-test. Now, to conclude the summary, the incidence of the hypotension was significantly lower in the co-load group compared to the preload group. That is, more parturients in the preload group needed treatment with mefentramin. The incidence of nausea was also greater in the preload group. Now, to discuss, we all know that the American Society of Anesthesiologists clinical practice guideline recommend that although the fluid preloading reduces the frequency of maternal hypotension, initiation of spinal anesthesia should not be related to administer fixed volume of intravenous fluid. So a judicious combination of fluid loading and vasopressor therapy appears the most logical method of achieving the objective. So in conclusion, an equivalent volume of crystalloid administered rapidly immediately after the performance of spinal anesthesia for elective cesarean section is associated with a lower incidence of hypotension and less requirement of vasopressor than a conventional preload. The technique of co-loading did not appear to disadvantage the neonate. Now these are the references. Thank you.
So, what's your name? Dr. Mukesh Shivran, right?
Yes, sir. Good morning, sir.
Good morning. So you basically found, that if you give fluids after spinal, you found better results.
Yes, sir. With co-loading. Yes, sir.
With co-loading.
Yes.
So it has been well established. This is, anything else you got to add to your that you found? What was the incidence of nausea? Any observation section like, um, uh, did you only look at pain or did you look at other, factors as side effects?
Yes, sir. Sir, actually, main focus was on the hypotension. Other than the hypotension, I look for the nausea vomiting incidence also.
Okay.
And how many times I have to use the vasopressors to treat the hypotension. So it is seen that this
No, but you
use
didn't
of
define.
methamphetamine.
You didn't define hypotension, that you gave your dose of vasopressor. At what level of systolic blood pressure did you actually give your vasopressor?
Yes, sir. I have taken two criteria, sir, for this. Actually, what is the initial blood pressure of the patient? If it goes down below 20% of the initial one, mean arterial pressure, I will use that. And if the systolic blood pressure falls below 100, I will again use that. Any one of the criteria fulfills, I will use methamphetamine.
Below 100? No, that should not have been the cutoff point. Below 100, it will happen in many patients. It does happen transiently and then it comes up again.
Yes. It's systolic, sir. Systolic.
Systolic, yeah, below 100. Below 100 is fine. We, actually in my practice, we, tend to be more this thing. And we use vasopressors at a much lower this thing, because transient hypertension is known to take place and then it reverts back on itself. Did you have any incidents of overloading and during removal of placenta after that? Did any of your patients experience overloading in any of the categories?
Sir, not the overloading, but many times I have seen that the sudden patient 2 to 3 times have gone to the shock after delivery of the baby.
Gone into shock.
Yes, sudden hypotension, and we have to do the CPR, and we have to start the noradrenaline also.
Okay. So what do you think would be the reason for that?
Sir, most probable cause is embolism.
In 3
after
patients?
Delivery of the baby. It's not sir, because it's a hypotension was not there before after giving the spinal anesthesia, but after delivery of the much later sudden hypotension occurs and patient goes to the shock.
Okay. All right. Thank you. We can go on to the next patient, participant.
Thank you so much, sir. कैसा रहा?
अरे शानदार। अब मेरा क्या होगा? मैं
देवगन
तो जाता ही नहीं है।
देवगन
लीव कर दो इसको तो। हो गया आप मेरे को बैठना तो है।
Good morning, I am Dr. Mukesh Kumar from Narayan Medical College, Sasaram, Jammu. My e-paper presenting topic is the effect of dextromethorphan and midazolam combined spinal anesthesia in patient undergoing major lower limb surgery. Now, introduction. Combined spinal epidural anesthesia is widely used for major lower limb surgery because it can onset efficacy and minimal toxicity of spinal anesthesia and extends the analgesia into the post-operative period. These advantages make combined spinal epidural anesthesia useful for surgical anesthesia and post-operative pain control in major lower limb surgery. Now, material and methods. The study was approved by the institutional board of our hospital. All parties provided written informed consent. The study included 50 consecutive patients with the American Society of Anesthesiology and physical status 1 to 3 age and 85 years old. Now, a study design. Group D have 25 patients receive a loading dose of 1 microgram per kg of intravenous dextromethorphan via an infusion pump over 10 minutes, followed by maintenance dose of 0.1 to 0.5 microgram per kg per hour, and group M receive a loading dose of 0.05 mg per kg of intravenous midazolam and a maintenance dose of 0.03 to 0.06 mg per kg per hour. Now outcome measurement. The primary outcome was the degree of degradation level of sensory block immediately after CS anesthesia. The level of maximum sensory block was assessed with the patient in the supine position by using pinprick with a 5 to 8 inch needle. The maximum sensory level was checked every 2 minutes until the highest level has stabilized for 4 consecutive tests. Now, sample size estimation. We have reviewed several studies to know sensory prolongation of test median after combined spinal epidural anesthesia, and there was no study of how sensory levels are maintained. We after surgery at the PSC, there was a study that measured the regression time of the sensory level. A statistical analysis was performed using PASW statistics for Windows and Macintosh version 18. Result 50 patients were enrolled in the study. 1 patient grew by epidural catheter within the first 24 hours of the surgery and was excluded from the study. The remaining 49 patients completed the study. With respect to demography data, no difference. Discussing this double blind comparative study exploring the potential benefit of the intervention procedural sedation during major lower limb surgery. Now, conflict of interest, no potential conflict of interest relevant to this article was reported. हो गया स्टॉप हो गया
हाँ स्टॉप कर दिया
Yeah. So your study basically, you were speaking very slowly, basically, so I couldn't hear much of it. Your audio wasn't clear also, and even the slide quality wasn't very good. So we can move on to the next participant now.
Dr. Ashish.
Yeah, yes.
Give me a minute first.
Yeah, sure.
Who is the next chairperson with you?
She hasn't turned up, I think. She is Dr. Ghai, but she.
Okay. I'll just talk to her. Anyway, thank you so much, Ashish, for taking care of the session. This is Dr. Rashesh Diwan, the organizing chairperson from Isacon 2021. And on behalf of the Governing Council and the organizing team, I welcome you all on this session. And let me tell you, this is the biggest ever hybrid conference happening in the world. And thanks to COVID pandemic, we had to turn into hybrid. But because of the, I would say, blessings in disguise, that because of the electronic platform, we have now 2100 plus abstracts and these many presenters from postgraduate fleet, which they missed out last year because of we could not do the conference. So in a way, it's a win-win situation for all of us. And the scientific content for another 4 days is also almost double than any of the Isacon which has happened in last 10 years. So there are some lacunae, there's some conflicts with the electronic platform, but I'm sure you all will enjoy the next 4 days. And I thank the chairperson, Dr. Ashish Chetty, and coordinator, and all the participants who are in this session. Thank you so much for joining.
Thank you so much. Thank you so much.
You can carry on.
Yeah, sure. So we'll move on to the next participant now. We'll move on to the next participant.
Yes, sir, we can.
Good morning, everyone. Myself, Dr. Namrata Kapadia, second year resident, BJ Medical College, Ahmedabad. My topic for presentation is evaluation of the analgesic effect of caudal dexamethasone combined with bupivacaine in pediatric genitourinary surgeries under guidance of Dr. Bharat Maheshwari, Assistant Professor, BJ Medical College, Ahmedabad. Caudal epidural block is one of the most common regional technique in pediatric anesthesia. Caudal block is safe and reliable technique, easy to perform, and has been found very effective in children, especially in infraumbilical surgery. Prolongation of analgesia has been achieved by addition of various adjuvants such as opioid, ketamine, neostigmine, midazolam. Bupivacaine acts mainly by blockage of voltage-gated sodium channel in axonal membrane. It may also cause presynaptic inhibition of calcium channel. Dexamethasone might have local anesthetic effect on nerve by direct membrane action. This randomized prospective interventional study of caudal dexamethasone as an adjuvant to bupivacaine in pediatric patient was done to compare intraoperative hemodynamic parameters, intraoperative concentration of inhalational agent required, perioperative and postoperative complications, comparison of duration of analgesia between two groups, assess the requirement of supplemental analgesics to assess the side effects. After obtaining approval from Institutional Ethical Committee, total 80 pediatric patients were randomly allocated into two groups, 40 patients in each group. BD group received 1 ml per kg of 0.25% bupivacaine with 0.1 milligram per kg of dexamethasone, and B group received 1 ml per kg of 0.25% bupivacaine. Inclusion criteria age between 6 months to 6 years, both the gender, SS status 1 and 2, elective surgery. Exclusion criteria SS status 3, 4, 5, emergency surgery, local infection, history of allergy, pre-existing neurological or spinal diseases. In operation theater, baseline vitals noted, patient was pre-medicated and then pre-oxygenation done with 100% oxygen. After the induction was done using inhalational method with 50% oxygen and 50% nitrous oxide with sevoflurane 2 to 7%. Airway was secured with either IGL or ET tube. After that, caudal epidural was performed with 22 gauge caudal epidural needle under complete aseptic precautions. In group B, 1 ml per kg of 0.25% bupivacaine given. In group BD, 1 ml per kg of 0.25% bupivacaine with 0.1 milligram per kg of dexamethasone given. During surgery, adequate analgesia was evaluated by hemodynamic parameters like change in heart rate, systolic blood pressure, and requirement of sevoflurane concentration. An increase in heart rate and systolic blood pressure within 15 to 20 minutes of a skin incision considered as failure of caudal anesthesia. This study involved the observation of analgesic efficacy of caudal bupivacaine alone and the caudal bupivacaine and dexamethasone in pediatric surgery. The end point of study was 24 hours after the completion of surgery, where the post-operative pain was evaluated by using FLAC score, face, leg, activity, cry, conservative. Maximum score of 10. At the 30-minute interval up to first 2 hours, 1 hour interval for next 3 hours, and then after every 2 hours. Whenever score was more than 4, rescue analgesia was given. Sedation score is 0, eye open spontaneously, 1 eye open in response to verbal command, 2 eye open in response to physical stimulation, and 3 unarousable. This graph shows post-operative pain score, which shows group BD has a less pain post-operative pain score compared to group B. This graph shows post-operative sedation score, which is almost similar in group BD and group B. Mean duration of analgesia. Mean duration of analgesia is more in group BD compared to group B. In conclusion, it was found that addition of dexamethasone to bupivacaine in caudal epidural significantly increased the duration of post-operative analgesia without much side effects. Thank you.
So, you used sevoflurane for your maintenance as well, right? Dr. Namrata, is it Dr. Namrata?
Yes, sir.
Yeah. Am I not clear?
Yes, sir, you are clear.
I said, your Namrata, your bandwidth is low. Your network is a little weak.
Hello, sir. Am I audible?
Yeah, but it's a little blurred. Anyway, we can move on to the next participant. I can't hear you well. We'll move on to the next participant. We'll move on to the next participant. I can't hear her.
Hello, sir.
Yeah, your network is bandwidth is low, and there's a lot of. So we'll move on to the.
I'm Dr. Namrata BM. My paper is titled Comparative Study of Effect of Buprenorphine and Fentanyl as Adjuvants to Bupivacaine for Postoperative Epidural Analgesia in Lower Limb Orthopedic Surgeries. Introduction. Pain is a complex multidimensional perception. Prevention and treatment of postoperative pain plays an important role in reducing patient morbidity. Epidural anesthesia is one of the most widely used techniques for postoperative pain relief after orthopedic surgeries. Bupivacaine is the most commonly used local anesthetic for epidural analgesia. Opioids, when used as adjuvants to local anesthetics, augment the onset and duration of analgesia. The aim of our study was to compare two opioids, buprenorphine and fentanyl, as adjuvants to bupivacaine for postoperative epidural analgesia in lower limb orthopedic surgeries with respect to onset and duration of action, hemodynamic changes, and side effects, if any. Methods. Institutional Ethical Committee clearance was taken. 60 patients of age group 20 to 60 years of either gender belonging to ASA 1 and 2 posted for lower limb orthopedic surgeries were included. Written informed consent was taken and surgery was performed under spinal anesthesia with epidural catheter in situ. Postoperatively, study drugs were given via epidural catheter when patient complained of pain and VA score was more than 5. Group B received 2 ml 0.5% bupivacaine with 150 microgram buprenorphine diluted with NS to 10 ml. Group F received 2 ml 0.5% bupivacaine with 50 microgram fentanyl diluted with NS to 10 ml. Pulse rate, systolic and diastolic blood pressure, VAS score, and side effects were monitored at regular intervals for the first 24 hours. Onset of an action is determined as administration of drug to when VAS score came down to less than 5, while duration of analgesia was taken as onset of action to when VAS score again rises to more than 5. All the observations were recorded in an MS Excel sheet and statistical analysis was performed using SPSS software. The results, baseline characteristics such as age, sex, weight, ASA grade were comparable between the groups. The onset of analgesia was faster in group F at 7.17 minutes, whereas in group B it was 15.33 minutes. The duration of analgesia was longer in group B with 13.36 hours, whereas in group F it was 3.73 hours. Side effects such as nausea and vomiting were seen more in group B, whereas pruritus was seen in group F. VA scores, pulse rate, diastolic and systolic blood pressure, respiratory rate was not significantly different between the two groups. Discussion. To relieve pain and all its physiological effects during and after surgery has been the main aim of every anesthesiologist. Bosra et al. In their study on clinical actions of fentanyl and buprenorphine compared the opioid receptor binding characteristics of fentanyl and buprenorphine. The receptor binding of fentanyl achieved rapid equilibrium and dissociated equally rapidly, whereas buprenorphine showed slow receptor association with high affinity to multiple sites. These findings offer an explanation for the faster onset of analgesia with fentanyl as compared to buprenorphine, which is similar to our findings. The longer duration of action and analgesic efficacy of epidural buprenorphine can be attributed to its high affinity for spinal receptors. This was substantiated by the findings of Koshi T et al., who studied epidural buprenorphine and morphine and found longer duration of action with buprenorphine similar to our study. Conclusion. Both fentanyl and buprenorphine are safe and effective opioids which can be used as adjuvants to epidural bupivacaine. Fentanyl is a better adjuvant owing to its faster onset of action and lesser incidence of side effects, while the duration of analgesia is more with buprenorphine as compared to fentanyl. These are my references. Thank you.
So, Dr. Namrata, can you hear me?
Hear you, sir.
Dr. Namrata, can you hear me?
Sir.
There's a lot of background noise.
Yes, sir. I'm in the OT actually, sir.
The OT actually. That's why there's a lot of background noise. Did you encounter any side effects of the use of buprenorphine?
Yes, sir. Nausea and vomiting was more with buprenorphine, sir.
Okay. So what was the extent of nausea and vomiting? Was it
Sir, actually,
tolerable?
Tolerable, sir.
Tolerable.
Yes,
and
sir.
the quality of analgesia was better with fentanyl?
Fentanyl, sir.
there's a lot of disturbance. I can barely hear. We'll move on to the next participant.
Thank you, sir.
Thank you. We'll move on to the next participant, please.
Good morning to all. My topic for paper presentation is effect of different volumes of normal saline for epidural volume expansion on spinal anesthesia in patients undergoing infraumbilical surgeries. The technique of combined spinal epidural anesthesia has become popular for patients undergoing elective infraumbilical surgeries where intraoperative prolonged and effective postoperative analgesia is required. The epidural volume expansion technique is a modification of CSE in which the level of sensory analgesia obtained by subarachnoid block is increased by saline administered through the epidural catheter. The most commonly extended explanation of EVE technique is a thecal compression due to volume effect on consequent epidural injection of fluid. And aim is to compare different volumes of normal saline, that is 0 ml, 10 ml, 15 ml of epidural volume expansion on spinal anesthesia with 10 mg of 0.5% hyperbaric bupivacaine for elective infraumbilical surgeries in adult patients. And objectives are to assess sensory and motor flow characteristics, to assess hemodynamic variations, and to assess first rescue analgesia time. And inclusion criteria are ASA grade 1 and 2, patients undergoing elective infraumbilical surgeries, patients within age group of 18 to 60 of equal sex. Exclusion criteria are patient refusal, patient in which spinal anesthesia is contraindicated, patients with compromised cardiovascular, respiratory, and central nervous system, obstetric anesthesia, patients, uncontrolled diabetes, coagulopathy, local skin infection, thyroid, and renal disease. Patients with BMI more than 30 kg per meter square, patients being administered epidural anesthesia, or patients being converted to GA. And sample size, the minimum sample size for the study is 117, and hence 120 patients were included in the study to avoid alpha error. The study population was randomly divided into 3 groups of 40 patients. Group 0 was given 10 mg of 0.5% hyperbaric bupivacaine intrathecally and will not receive any epidural volume expansion. Group 10 will receive 10 ml of 0.9% normal saline for epidural volume expansion. And group 15 will receive 15 ml of 0.9% normal saline for epidural volume expansion. Hemodynamic parameters such as heart rate, BP, mean arterial pressure, SpO2, and sensory motor block characteristics were recorded. And these are my results in a tabular form. Sensory block characteristics and motor block characteristics. These are side effects. Discussion. There was no statistically significant difference in the demographic data among the studied groups. Time to achieve maximum level of sensory block was observed to be longest in group 15 as compared to group 10, which was longer when compared to group 0. Time for two segment regression, time for complete sensory regression, and total duration of analgesia were longest in group 10 as compared to group 15, which was longer than group 0. No statistically significant difference among the groups were observed with respect to time of onset of motor block and maximum motor blockage. The total duration of motor blockage was longer in group 10 as compared to group 15 and group 0. Hemodynamic stability was better in group 0 and 10 when compared to group 15. Subarachnoid and epidural block can be performed as either a single shot or continuous technique, while a combination of both is practiced as the popular combined spinal epidural block. Epidural volume expansion is a modification of CSE technique where the level of sensory analgesia after subarachnoid block is increased by normal saline or local anesthetic administered through the epidural catheter. More recently, in clinical practice, EVE has come to imply the injection of normal saline only. Conclusion: epidural volume expansion has advantage over subarachnoid block alone. EV of 10 ml of saline with intrathecal of 0.5% bupivacaine is better when compared to EV of 15 ml of saline with regard to sensory and motor block characteristics while maintaining the hemodynamic stability. These are my references. Thank you.
Yeah, so Dr. Naveen. Yeah, so Dr. Naveen, can you hear me? Please unmute yourself. Please unmute.
Yeah, sorry. Good morning, sir. Good morning, sir.
Good morning. Yeah, you could. So what, in your opinion, could be the reason of 10 ml being more effective than 15? You found 10 ml to be the optimal, the most optimal, and 15 didn't work as well. So What, in your opinion, could be
Yes,
the
sir.
reason?
Because in 15 ml, level will go high. So in 15 ml, when we give 15 ml of NS, level will go high, sir. And in 10 ml, it won't go that much, sir.
No, that is okay. But observation wise, you looked at two segment regression, right?
Yes.
So the higher the better, no? Isn't that the case?
Yes, sir.
If you can achieve a higher level with the same dose, is that a better situation or a worse situation?
Sir, hemodynamically, in 10 ml patient will be will be more stable, sir. Instability will be more in 10 ml, sir.
Okay, so they were more stable that way. So you want to explain it that way. Any other side effects the patients had?
Yes.
Did they have any other side effects?
Sir, in 15 ml, hypotension was more, sir, compared to 0 ml or 10 ml, sir.
Okay. So you advocate that 10 ml should be, if at all we want to use, right?
Yes, sir.
Thank you. Thank you.
Thank you, sir.
We'll move on to the next participant.
Good evening. I'm presenting e-paper title, The Effect of Music on Intraoperative Anxiety Using STI-6 Score in Patients Undergoing Lower Limb Surgery Under Spinal Anesthesia, a Randomized Interventional Study. Principal author is Dr. Naveen Kumar Ligri. My conference registration number is PGV 1559. Introduction. Intraoperative anxiety is common in patients undergoing surgery under spinal anesthesia. Surgery and loud noises in operating room are anxiety-provoking. Pharmacological agents have side effects such as sedation, respiratory depression, and emetogenic action. Music, scientifically proven binaural beats are showing very good result to relieve intraoperative anxiety. A very less data is available on the effect of binaural beat music. Aim and objective. Aim to study the effect of music on intraoperative anxiety using a STI-6 score in patients undergoing lower limb surgery under spinal anesthesia. Primary objective is to determine the difference in change in anxiety score from baseline to the end of surgery in each group. Secondary objective to determine the difference in mean sedation score, hemodynamic variables, mean communication difficulty, and satisfaction score. Material method. Hospital-based randomization study conducted in SMS Medical College for the cases of lower limb surgery under spinal anesthesia. Randomization was done and using seal opaque envelope. 108 envelopes were created. Patient binding was not possible. Study groups. Each group contained 36 patients. Group A, headphone attached and music was played. Group B, headphone attached but no music was played. In Group C, the patient was subjected to ambient OT noise. Eligibility criteria: lower limb surgery, age 18 to 15 years, patient who have given written consent, ASA grade 1 and grade 2. Exclusion criteria, that is patient who have previously received spinal anesthesia and patient with hearing impairment and mentally unsound. Flowchart. Patient satisfying inclusion criteria was selected for the study, identified, EAC done, prilocaine was applied, 18 gauge cannula was secured, STI-6 score was recorded for anxiety, that is baseline and preoperative. Patient taken in OT and hemodynamic parameters were recorded. Patient in left lateral position under all aseptic precaution was given spinal anesthesia in L3 L4 space with bupivacaine heavy 0.5%, 2.5 ml to 3 ml. Patients will be placed to supine position after spinal block, and headphones with music attached in group A, headphones attached but no music was played in group B, no headphone was attached and no music was played in group C. Hemodynamic parameters was recorded in intraoperatively. Music was stopped at the end of surgery. Anxiety score, satisfaction score, communication difficulties, and Ramsey sedation score was noted. Outcome variables was mean anxiety score, mean hemodynamic parameters, mean satisfaction score, mean sedation score, mean communication difficulty. The statistical analysis result: STI6 score, VAS score, Ramsey sedation score, and systolic blood pressure. The p-value that we got was significant. Diastolic blood pressure result wasn't significant. Likert 5-point score at patient end was significant. Likert 5-point score at observer end wasn't significant. These are my results. These are my table. Group A, Group B, and Group C. This is my chart. Ramsey sedation score, the result was significant. Likert score, observer end, Likert score, patient end. Discussion. The main purpose of our study was to investigate the effect of music and noise cancellation on intraoperative anxiety in patients undergoing spinal anesthesia for low limb surgeries. STI6 score, the result of this study indicates that intraoperative anxiety in group A and group B has shown significant decrease from preoperative value, whereas the intraoperative anxiety in group C haven't shown any decrease in anxiety from the preoperative value. And the difference in mean STI6 score when compared between group A and group B was significant. Group A and group C was also significant, but when compared between group B and group C, it wasn't significant. There were many studies which support our result, that is D. Vivant in 2016, Wang in 2014, and Ben Turner in 2011. Conclusion: music and active noise cancellation in intraoperative anxiety in operative period was effective in reducing anxiety. Music and active noise cancellation headphone had significant influence on hemodynamic parameters, that is on systolic blood pressure, but had no effect on DBP, heart rate, and saturation. Music and active noise cancellation headphone group had significant increase in Ramsey sedation score. From our study, we concluded that a music and active noise cancellation headphone can reduce the anxiety of patient. Therefore, it is suggested that along with other remedial method in alleviating pain and anxiety, music therapy can be used by anesthesiologist, which at the same time is effective as well as without side effects, as it acts as distracting agents and help to refocus the attention from negative stimuli that causing stress to something that is pleasant. These are the parameters that I have used: STI6 score, Ramsey, Likert, VAS. These are my references. Thank you.
So actually, it was a nice study. What's your name again? Hello? Are you there? Hello? Hello? Is the speaker still there?
Sir, I think he is not logging.
He's not logged in. Look, I was just wondering what's happening. Okay, then we'll go on to the next participant.
Sure, sir.
We'll go on to the next participant. Yeah, you can start your presentation.
A comparative study of the effects of dexmedetomidine and magnesium sulfate on hemodynamics during laparoscopic surgeries, a randomized control study. In the current era, laparoscopic surgeries are increasingly done routinely, and general anesthesia is the preferred method of anesthesia for these. Laryngoscopy, tracheal intubation, and creation of pneumoperitoneum with carbon dioxide provokes marked sympathoadrenal response manifested as elevation of mean arterial pressure, systemic vascular resistance, and increased heart rate. These changes can be tolerated by healthy individuals, but is a risk factor in patients with pre-existing hypertension, ischemic cardiac disease, or increased intracranial or intraocular pressure. The present study was done to compare the effects of IV dexmedetomidine and magnesium sulfate on hemodynamic parameters during laryngoscopy, intubation, pneumoperitoneum in patients undergoing laparoscopic surgeries. Primary objective was to compare the effects of IV dexmedetomidine and magnesium sulfate on hemodynamic changes occurring during laryngoscopy, intubation, and pneumoperitoneum in laparoscopic surgeries, and secondary to assess any associated side effects. Ethical committee clearance and informed consent, standard monitoring. Study drug was injected to the respective allotted groups randomly based on computer-generated number. Group D, dexmedetomidine 1 microgram per kg. Group M, magnesium sulfate 50 mg per kg, and control group S, normal saline as bolus over 15 minutes. Systolic BP, diastolic BP, mean arterial pressure, and heart rate was monitored baseline after study drug 1, 3, 5 minutes after intubation and after the creation of pneumoperitoneum. Shapiro-Wick test was to analyze normality of continuous variables for each category. Chi-square test to analyze if there is any statistically significant association between gender and the groups. The statistical significance of differences among the groups, ANOVA, and Jackie's test was employed for post-hoc analysis. Coming to result, systolic BP, diastolic BP, and mean arterial pressure, statistically significant difference was found between the groups D, S, and group M and S at 1 minute after the intubation, 1, 3, 5 minutes after pneumoperitoneum, and no significant difference between group D and S. Heart rate, statistically significant difference was found between group D and S and group M and S at 1, 3, 5 minutes after the intubation and 1, 3, 5 minutes after pneumoperitoneum, and no significant difference between group D and M, and there was no adverse effect seen with any of the groups. So dexmedetomidine and magnesium sulfate both reduced the stress response to intubation and pneumoperitoneum. We found that both drugs were equally efficacious in reducing the adverse hemodynamic responses, statistically significant, that is P is less than 0.05, and there was no adverse effects noticed with both the groups. Suman Gupta, Mohammad Shahbaz, Shaukat, and Lakshmi Mahajan also did their studies and found the similar result as dexmed and magnesium sulfate reduced stress response equally during laryngoscopy, intubation, and pneumoperitoneum. Dexmedetomidine is a highly potent and alpha-2 adenoreceptor agonist that decreases the plasma catecholamine concentration and reduces the sympathetic response. Magnesium sulfate plays the role of calcium antagonist by competitively binding to membrane channels and transform the response to be response mediated by calcium, thus blocking the release of catecholamine store and decreasing the response to adrenergic stimulation. Concluding, IV dexmedetomidine and magnesium sulfate were equally efficacious to attenuate the hemodynamic stress response during laryngoscopy, endotracheal intubation, and pneumoperitoneum in laparoscopic surgeries, and there was no adverse effect seen in these patients.
So you found both these drugs to be equally efficacious. Hello? Is she there? Is this participant there or has she left?
अरे यार क्वेश्चन आंसर चालू થયા ને પેલી જતી રહી છોકરી.
I think she's gone. I think we'll move on to the next participant.
Sure, sir.
So who's the next participant?
Good morning. Today I am going to present my topic, that is radiofrequency treatment of idiopathic trigeminal neuralgia, conventional versus pulsed, a prospect control study. Idiopathic trigeminal neuralgia is a chronic pain disorder causing unilateral severe brief stabbing recurrent pain in the distribution of one or more branches of trigeminal nerve. There are many treatment modalities available, like in medical management, carbamazepine, minimally invasive treatment, glycerol rhizolysis, conventional radiofrequency, pulsed radiofrequency, and percutaneous balloon compression. And the surgical is microvascular decompression. Conventional radiofrequency destroys the unmyelinated and the poorly myelinated nociceptive fibers, while the pulse radiofrequency produces a neuromodulatory effect. Now the research question is whether PRF with new modalities is more effective than CRF for idiopathic trigeminal neuralgia. Our hypothesis is pulse radiofrequency with parameters is more effective than CRF. Objective of this study was to compare the efficacy of long duration fixed voltage PRF with CRF for the treatment of idiopathic trigeminal neuralgia and assessment of the side effect of the same. Reading the literature, Erdin et al. In 2007 said PRF is not effective method of treatment, while Chua et al. In 2012 said that it produces an excellent pain relief with PRF, and Fang et al. In 2015 said PRF is effective for the treatment of trigeminal neuralgia. So here we are comparing our study. The type of a study is prospective double-blinded randomized controlled trial. Inclusion criteria: age 18 to 80 years, patient with idiopathic trigeminal neuralgia, VAS greater than 8, BNI greater than 4, intolerable side effect, and the refusal criteria is refusal to known coagulopathy. Materials and method. Study was conducted in pain medicine unit of Department of Anesthesiology for 18 months. 27 patients were taken of idiopathic trigeminal neuralgia. Approval was done from the Institutional Ethics Committee. Registration from the CTRI was done. A total 12 patients in each group was taken and blinding was done, and randomization according to computer generated random number table was done. Procedure was conducted in a pain OT and a CM guided fluoroscopy with SFK needle, which is directed towards the foramen and to reach the Meckel's cave, and the cannula position was confirmed by AP and lateral view. CRF lesioning of 60, 65 and 70 degree for 60 seconds each was done, and PRF 50 volt for 600 seconds was done. These are the fluoroscopic view of foramen oval and submental vertex position and end-to-end radio frequency cannula position. The statistical analysis was done using Fisher-Extract chi-square test, and you can see the mean age, gender distribution, side involvement, and nerve root involvement for comparable. Pre-procedural BNI and was also comparable in both the group. Result was effective when reduction in VAS score greater than 50% and BNI less than 4 if the failure was done if BNI greater than 4 after 1 month. Effectiveness in terms of BNI. After 6 months, 83.33% patient of the CRF showed the pain relief, and 25% of PRF show pain relief. There is a significant p-value 0.012. In VAS, this is also the same. Efficacy was between the two groups was found statistically significant. CRF is more efficacious treatment modality than long duration fixed voltage PRF for the treatment of trigeminal neuralgia, though there was an early relapse in those patients where PRF treatment was considered successful initially. Mild self-limiting hypoesthesia was seen in the CRF group, while no side effect in the PRF group. The limitation of the study was short duration of the follow-up. Thank you.
So I think we'll go ahead now because she also is not there, I think. Dr. Naveen Kumar? Dr. Naveen Kumar?
Yes, sir. Yes, sir.
Please start your presentation. I think the other girl is not there. So you please start your presentation.
Okay, sir. Sir, is it working?
No, this Nihali Maya I can see. Who's she's the one who presented earlier?
No, sir, my presentation is due next.
Okay, sure. So, Dr.
Sir, Naveen Kumar is there, but I
I'm
cannot
not
start with video because host has stopped it.
Host has stopped your video.
Yes, sir.
Okay. I request the organizers to please, take over and
please.
start this video.
Actually, sir, Dr. Naveen presentation is already present. No?
Okay, so he doesn't need to share the screen. He just needs to be there, right?
If he wants to share, then
you want to share your screen or you?
Sir, I'm okay with anything.
Okay.
So go ahead. Go ahead.
You stay logged in and they'll play your presentation.
Yes, sir.
All right. Okay. We'll go ahead then.
Okay, sir.
Sir, actually, sir, Dr. Ashish Sethi, sir.
Yes.
Sir, नवीन जी की presentation पहले चल चुकी है, वो बाद में logged in हुए हैं. हम उनकी presentation दिखा चुके हैं.
कौन सी presentation थी वो?
The effect of music on intraoperative anxiety using style
Okay, you
success
logged
score.
in. That was a wonderful presentation.
Sir, ये late आए.
Thank you, sir.
अच्छा. Yeah, I like the
there was a connection problem, that's why.
There was a connection problem. Okay. So I just had a question for you that
yes, sir.
Did you, at what level do you think this acts? And is there a relationship with pain as well? Did you look at the pain thing, the post-operative pain as well?
No, sir, we haven't took anything.
The combination of the correlation between anxiety and post-operative pain. You could have added limb as well. So
okay, sir. Maybe, sir, next time I'll add pain in other studies. But anxiety was like relieved, and it showed sometimes it showed a very good result.
Okay, according to your scale.
Yes, sir. But I used a binaural beats for that, and delta frequency binaural beats.
Okay, sure.
Yes,
Thank
sir.
you. Thank you.
Okay, sir.
Go ahead. So we'll move on to the next participant then.
Thank you, sir. Hello.
A warm welcome to everyone present here. The topic of my today's study is on the efficacy of pre-oxygenation in supine versus 45-degree head-up position in non-obese patients undergoing elective oncosurgery, a comparative study. Pre-oxygenation is the administration of 100% oxygen to the conscious individual before induction of general anesthesia. Pre-oxygenation increases the oxygen reserve and duration of safe apnea time. Studies have shown safe apnea time is longer with pre-oxygenation in 20-degree head-up position. So we hypothesized that pre-oxygenation in 45-degree head-up position improves safe apnea time further, and we have compared it with supine. So our primary objective is to compare the efficacy of pre-oxygenation in terms of duration of safe apnea time in supine and 45-degree head-up position. Our secondary objective is to compare the hemodynamic variability. So by considering 80% power and 5% alpha level, the minimal required sample size to conduct the study was 48, and it was conducted at Kidwai Memorial Institute of Oncology, Bengaluru. So our inclusion criteria included patients aged between 18 to 50 years with ASA 1 and 2, BMI ranging from 18 to 25 kg per meter square, those requiring oral intubation, and non-smokers. We have excluded any case of anticipated difficult intubation. So coming to methodology, patients were randomly assigned to two groups, supine and 45-degree head-up position, that is group A and group B. Pre-oxygenation was started in the assigned position, and this position was maintained till patient was intubated, and in the same position, safe apnea time was recorded. So while doing pre-oxygenation, we have connected the patient to a face mask, and we have pre-oxygenated the patient with 100% oxygen with 8 liters for 3 minutes. Patient was allowed to take tidal volume breaths. After pre-medication, anesthesia was induced with propofol, and adequacy of mask ventilation was confirmed, and muzzle relaxant was given, and patient was ventilated for 90 seconds. Then patient was intubated with appropriate sized oral cuffed ET tube. Intubation time and capnogram tracing was noted. So then the endotracheal tube was then disconnected from the circuit to room air till peripheral oxygen saturation dropped to 95%. Safe apnea time in our study was defined from the time of cessation of ventilation until SpO2 declined to 95%. Patient was then reconnected to the circuit when SpO2 dropped to 95% and was ventilated with 100% oxygen. Our results, demographic details were all comparable. So in this table, we see that mean apnea time in group A was found to be 4.7 minutes, whereas in group B, it was found to be 9.03 minutes. In this graph, it is depicted that most of the patients in group A fell in the time category between 3 to 6 minutes, whereas group B patients fell in the category from 9 to 12 minutes. The difference between the two groups was found to be 4.25 minutes, which was significant with respect to p-value. Thus, our study depicts 45-degree head-up position is statistically and clinically more beneficial in providing more safe apnea time than in supine position. Dixon et al. Study also showed desaturation safety period was more in 25-degree head-up position than supine, thus making our hypothesis about posture influencing the efficacy of pre-oxygenation validated. Our limitations, a study arm of 25-degree head-up position could have been better, and serial ABG samples could have been taken to monitor the arterial oxygen tension. In conclusion, pre-oxygenation done in 45-degree head-up position significantly increases the safe apnea time than in supine. Thus, head-up position can be incorporated in routine clinical practice to increase safe apnea time. These are my references. Thank you.
So, the excellent presentation.
Thank you, sir.
Yeah. So, can you please tell me the, underlying reasons, for these findings that you had?
Okay, sir. So first is placing the patient in supine, like we do in routine, and we pre-oxygenated the patient. That will decrease the FRC. First, because the patient is lying supine.
So
and
FRC
second,
is the main. So
Yes,
FRC is the main reason why,
Yes, sir.
it works better this way.
Yes, sir.
Well, so you could have graded. You could have had more groups, 25 degrees, 45 degrees, and So to what extent is the optimal? To find out, what angle is the optimal angle that one should
Yes,
go
sir.
in for, right?
Actually, sir, we have an arm of 25 degrees, sir, but the sample size is not yet finished. So I've included only the two arms where I've done the study completely.
And are you a DNB candidate or MD or what?
MD candidate, sir.
Okay, good. Okay, all the best to you.
Thank you, sir.
Next participant, please. Next participant, please.
Sure, sir.
efficacy of soft block with that. Hello, this is Dr. Niharika Bariki. He is here to present to compare a study comparing the efficacy of soft block with that of adductor canal block in patient undergoing elective knee surgeries, a prospective randomized double-blind study. Knee surgeries are the most painful procedure. If not managed satisfactorily, lead to delayed mobilization and many other post-operative complications. So adequate post-operative analgesia is needed. Till now, many peripheral nerve blocks has been tried for the post-operative pain management of the knee surgeries. In our study, we are comparing efficacy of soft block with that of the adductor canal block for post-operative analgesia. Soft block is a novel single puncture technique to block sciatic operator and femoral nerve. Coming to the methods, this study is a randomized double-blind prospective interventional clinical trial. 60 patients of the ASA grade 1 and 2 were enrolled and divided into two groups, that is group S of soft block and group A of adductor canal block, with randomization done by using computer-generated random numbers. A detailed anesthetic checkup was done and informed written consent were obtained from the all patients. All patients received spinal anesthesia with 2.5 ml of 0.5% bupivacaine heavy. After successful completion of the surgery, group S patient received soft block and group A patient received adductor canal block under ultrasound guidance. Soft block was given using 45 ml of 0.2% bupivacaine with 8 mg dexamethasone, where femoral nerve blocked by 15 ml of drug, and operator nerve was blocked by 10 ml of the drug, and the sciatic nerve was blocked by 20 ml of the drug. An adductor canal block was done using 30 ml of 0.2% bupivacaine with 8 mg dexamethasone in adductor canal deep to the sartorius muscle. Details of the techniques are given below. Our parameters are recorded at 0, 6, 12, 24, and 36 hours post-operatively, and the pain assessment was done by visual analog scale, and time required for the first dose of rescue analgesia was recorded, and the patient satisfaction was assessed by using 4-point patient satisfaction scale, and time taken by the patient to start mobilization was noted, and adverse effects were recorded. Statistical analysis done by the software IBM SPSS version 25.0, and the p-value less than 0.05 was considered a statistically significant value. The results, coming to the results, difference in demographic data in both the group is clinically insignificant. VAS score at 12th hour is significant with p-value less than 0.001, and mean duration of analgesia is group A is 11.68 hours and group S is 14.62 hours, which has statistically significant difference. Mobilization is earlier in group S than group A, and difference is statistically significant. And satisfaction score was higher in group A than that of the group S, and this difference is also statistically significant. One case of hematoma is seen in both the group, and 2 cases of failed block was seen in group S, but the difference is statistically insignificant. Now, coming to the discussion, mean duration of analgesia was significantly longer in patients of soft block than that of the adductor canal block. These results is similar to that of Barham et al., which have compared the adductor canal block to the femoral nerve block, where the mean duration of analgesia of adductor canal block is 6.9 hours, and there are another studies done by Shockley et al., where the mean duration of first rescue analgesia of the soft block is 9.43 hours. VAS score was statistically significant at 12th hour in our study, and mobilization with soft block was earlier than that of the adductor canal block. But still today, there was no literature suggesting early mobilization in the soft block. So further studies for the soft block was required to have a better knowledge about it. Patients were significantly more satisfied who received soft block compared to the adductor canal block. Although there was adverse reaction is more in soft block, but difference is statistically insignificant. Our conclusion is soft block offers longer duration of analgesia, earlier mobilization, and better satisfaction without much significant adverse effects as compared to the adductor canal block in patient undergoing knee surgeries. These are my references. Thank you.
Is she there or she?
Yes, sir. Yes, sir. I'm here.
Yeah, yeah. So, which drug did you use for background analgesia? Did you use something for background analgesia?
The injection tramadol, 100 mg. I have used
for in all the patients.
Yes, sir, in all the patients.
And what did you use for rescue analgesia?
So rescue analgesia, I have used injection tramadol.
And background?
For the block, sir, you're asking for the block. So for the block, I have used injection ropivacaine.
No, that I know injects. Oh,
I have given the drug in a post-operative period where the spinal anesthesia effect was there.
It was still there, rescue
Yes.
analgesia. And you found this soft block to be better than adductor canal.
Yes, sir.
And the analgesia stayed for how many hours? Post.
For soft block, sir?
Yeah.
Yes, sir. For 11 hours, it stayed. Mean duration I have calculated. It's around 11 hours.
Okay. So you studied the requirement of tramadol. So after 11 hours, the patient demanded tramadol.
Yes, patient VAS score was more than 4. When the patient is feeling pain, that's why we have given as a rescue analgesia.
All right. So, all right. Thank you. We can go ahead to the next participant.
Thank you, sir.
My paper presentation is about the role of ultrasound measurement of inferior vena cava collapsibility index in avoiding spinal anesthesia-induced hypotension, a prospective randomized controlled study. Introduction: hypotension is one of the most common side effects of spinal anesthesia. Intraoperative hypotension has serious implications in patients' outcome. It can increase the risk of post-operative complications like myocardial injury, stroke, sepsis, and AKA. Pre-op volume status is one of the predictive variables for developing spinal-induced hypotension. IVC collapsibility index is effective in assessing fluid responsiveness. Aim of the study was to evaluate IVC collapsibility index guided volume optimization in averting spinal anesthesia-induced hypotension. The primary objective is reduction in the incidence of spinal anesthesia-induced hypotension following preoperative IVC collapsibility index guided volume optimization. Secondary objective is to establish that the requirement of vasopressors are lesser in IVC collapsibility index guided volume optimized group, and to establish correlation between IVC collapsibility index and pre-spinal IV fluid requirement. It's a prospective randomized control study. These are the inclusion-exclusion criteria, methods. After ethical committee approval, 80 patients satisfying the inclusion criteria selected, divided into 2 groups. Group A patients, IVC measurements are done using ultrasound, curvilinear probe, 2 to 5 megahertz, visualized in the longitudinal paramedian subxiphoid view. Last section of the vein, 0.5 to 3 centimeters from the right atrium, was selected for M mode. Maximum minimum diameters of IVC measured. IVC collapsibility index calculated with the following formula. Collapsibility index more than or equal to 36% are considered fluid responders and are given 500 ml of crystalloids over 15 minutes. Again, IVC diameter is reassessed. Another fluid bolus of 500 ml crystalloids are repeated until a non-fluid responder pattern is observed with IVC assessment. For group B patients, spinal anesthesia is performed without taking IVC measurements. Spinal anesthesia procedure was standardized for both the groups. Standard dose of 0.5% heavy bupivacaine with 25 mics fentanyl given. Target level of block is T6. Results. Incidence of hypotension was less in group A, 15% compared to control group B, 50%. Relative risk between the groups was 30%. Relative risk reduction in the incidence of hypotension following spinal anesthesia was 70%. Number of patients requiring first dose of vasopressors in group A was 15%, 6 out of 40. And here in the tabular column, you can see the results. Pre-spinal fluids and total IV fluids needed. And in the graph, you can see a correlation between the collapsibility index and pre-spinal IV fluids. More the index, more the fluids required. Discussion: generally, healthy patients can tolerate hypotension with minimal side effects, but patients with cardiovascular compromise may not tolerate it, and this may have a major impact on the outcome of patients. Recent studies show that there's an association between intraoperative hypotension and 30-day post-op mortality and cardiac complications in the post-op period. Hypovolemia is an important risk factor for hypotension following spinal anesthesia. Period. Volume status optimization with IVC-CI can avert spinal anesthesia-induced hypotension, and moreover, IVC collapsibility index is a non-invasive tool. It can be quickly learned and performed compared to other invasive monitoring techniques. Limitation: upward and downward movement of the diaphragm can be a hindrance for ultrasound measurement of IVC collapsibility index. To conclude, IVC collapsibility index guided volume optimization before spinal anesthesia can decrease the incidence of spinal anesthesia-induced hypotension as well as the need for vasopressors. These are my references. Thank you.
You were the one who like presented, right? What's your name?
Nivedita, sir.
Nivedita. So Nivedita, your study was good, but did you take into account the level of the block in the patients? Was it similar across both the groups?
Yes, sir. More or less, around
what level of
to
block did? Because the level of block is will be a confounding factor with hypotension, right?
Yes.
So the level of block has to be the same if you're using it for spinal. Otherwise, it's well established that collapsibility index is a good way to assess fluid responsiveness. That being said, I just am concerned with your particular study in which you talk about spinal hypotension, spinal anesthesia. So what about the level of the block and the surgeries? Which surgeries did you work on?
Mostly infraumbilical, sir. We targeted a level of block around T8.
Because level of the block is a factor, then blood loss is a factor. These
Yes,
are all confounding factors for hypertension.
Yes, sir.
So were they comparable in both the groups? Mention that.
The level of block was comparable, sir. We used the dose according to the patient's height to achieve a target level of T8 in all the patients in my study.
Okay, so you checked T8 in all the patients.
Yes, around T8. The level was around T8.
T8. And the surgeries?
Infraumbilical surgeries, sir. Or
Infraumbilical means what?
inguinal hernia, hydrocele, general surgery procedures, sir. Lower limb procedures also, sir. Orthopedic surgeries.
So orthopedic surgeries will tend to have more blood loss.
After blood.
So surgeries are uniform.
I compared the initial blood pressure monitoring after giving spinal anesthesia, sir, for till 15 minutes. So till that time, there would not be any significant blood loss in the surgery.
Okay. Okay. All right. Thank you. We'll go ahead to next candidate. Participant. Thank you. We'll go on to the next participant.
Comparison of duration of post. Good morning, one and all. My name is Dr. Nidhi Sharma. I am presenting my e-paper on the topic comparison of duration of postoperative analgesia after caudal block with or without intravenous dexamethasone in pediatric daycare inframumbilical surgeries under general anesthesia. As we know that pain in pediatric cases have been difficult to interpret and is often undertreated. Regional nerve blocks with adjuvants have long been used to manage the intraoperative and postoperative pain, and dexamethasone, it is a corticosteroid, that is the adjuvant that we have used, is anti-inflammatory and reduces the intensity of pain. However, the optimal dose to reduce the pain intensity is not yet defined. The aim was to study the effect of intravenous dexamethasone on duration of post-op analgesia when given along with intraoperative caudal block in pediatric daycare inframumbilical surgeries under GA. Objectives were to determine duration of post-op analgesia and assess the incidence of PONV, that is post-operative nausea and vomiting. Most studies that have been done in the past were in the dose of 0.5 mg per kg, which is a higher dose and has side effects. So we chose a lower dose, that is 0.2 mg per kg for inframumbilical procedures. The study was done in Department of Anesthesiology, ABVMS in Dr. RML Hospital, Delhi 1. It was a randomized comparative double-blinded study in which 60 patients of 2 to 7 years of age were taken of either sex, and they were all going in elective inframumbilical surgeries, ASA grade 1 and 2. Exclusion criteria were allergy, coagulopathy, bleeding disorder, local site infection, pre-existing neuromuscular disorders, congenital anomalies, and mental retardation. They were divided into two groups using computerized randomization using Rank-Between function. Methodology: written well-informed consents were taken from the guardian. Thorough pre-anesthetic checkup was done. NPO for 6 hours for solid, 2 hours for clear liquid was confirmed. In the operation theatre, baseline values of vitals was taken. Sevoflurane, oxygen, and nitrous oxide was started. IV cannula secured and ringer lactate started. Injection fentanyl, propofol, and becuronium were given. Procel LMA of appropriate size inserted. Patient was maintained on sevoflurane, oxygen, nitrous. Steady drug was given, diluted in 5 ml. Caudal block was given, and then surgery was allowed to start after 10 minutes. Intraoperatively, vitals noted every 15 minutes in first hour and 30 minutes in second hour of surgery. At the end of surgery, sevoflurane discontinues and reversal agent was given. When the child was awake, he was shifted to post-anesthetic care unit for observation. Flag scoring was done hourly, and when it was more than equal to 4, paracetamol was given in a dose of 15 mg per kg at the end of the study. Parental satisfaction was noted by Likert scale. Results: both the groups were comparable in terms of hemodynamics and demographic characteristics. And 7% of patients in both groups required rescue analgesia in 1 to 2 hours, 20% in 2 to 3 hours, and 73% in more than 3 hours in group D, while 33% between 2 to 3 hours and 60% beyond 3 hours in group S required rescue analgesia. Flag score was comparable at all points. More than 80% were related with quite satisfied with the analgesia that was given, as shown in the table. Discussion: Dongare and Karhadi, they conducted the study at dose of 0.1 mg per kg, and they concluded that it did not augment the effect of caudal analgesia. However, the study conducted by J.Y. Hong, Srinivasan, and Moni Sari at dose of 0.5 mg per kg, they concluded that it does prolong the duration of post-op analgesia. Limitations were that we did not do lab testing for hyperglycemia or adrenal suppression, and hunger and anxiety may have played a role in flag scoring. So we can conclude that no significant difference in duration of post-op analgesia was seen when the intravenous dexamethasone was given to patients in dose of 0.2 mg per kg along with caudal block with 0.75 ml per kg of 0.25% bupivacaine. These are the references that I have used. Thank you.
So, is she there? Are you there, or was it a recorded presentation? Hello? Is the participant there, or was it a recorded conversation?
Sir, it's recorded.
Recorded. So we'll move on to the next participant then.
Okay, sir.
Hello everybody, my name is Dr. Nidhi Dubey, PG third year from SGRR Medical College, Dehradun. My topic is paper presentation. The topic is ultrasound guided caudal versus ilioinguinal iliohypogastric nerve block for post-operative pain using 0.25% ropivacaine with clonidine in pediatric patient undergoing inguinal scrotal surgeries, a comparative study. Pediatric patients have poor pain control. Post-operative pain management is of utmost concern. Inguinal scrotal surgeries is one of the procedure in the children and is associated with significant post-operative pain. Regional anesthesia provide excellent post-operative analgesia and attenuation to stress response in children and infants. Over the past decade, many study has demonstrated that USG guidance can significantly improve the quality of nerve block in almost all type of regional anesthesia. Aims and objective to evaluate and compare the efficacy of ultrasound-guided caudal versus ilioinguinal nerve block for post-operative pain in pediatric population undergoing inguinal scrotal surgeries. To compare and study the post-operative pain and complication after caudal block and ilioinguinal iliohypogastric nerve block. Material and method. The proposed study was conducted in Department of Anesthesia and Intensive Care, SGRR, Dehradun, after obtaining hospital ethical committee permission and approved written informed consent from all the patient. A prospective randomized study was conducted in 40 pediatric patients undergoing inguinal scrotal surgeries under general anesthesia. Inclusion criteria was age 2 to 12 year, male, female, ASA grade 1 and 2, child weight 3 to 45 kg. Exclusion criteria: patient guardian refusal, weight less than 3 kg or more than 45, ASA grade 3 and 4, infection at the site of injection, and failure of the block, non-allergic to any drug. At the end of the surgery, children were randomly allotted in two groups by computer-generated random number table. It was a double-blinded study. Block was performed by an anesthesiologist, and post-operative assessment was done by an assistant who was non-aware of the type of block. Group 1 received caudal block, which was injection with injection bupivacaine 0.25%, 1 ml per kg, and injection clonidine 1 mic per kg using 23 gauge needle. Group 2 received ilioinguinal nerve block with injection 0.25% ropivacaine 1 ml per kg, and injection clonidine 1 mics per kg using 23 gauge needle. Total number of 40 patients in two group of 20 each. Both the block were performed using ultrasound guided technique. Post-operative pain assessment was done after 30 minutes, 1 hour, 2, 4, 6, 12, and 24 hours. Post-operative motor block, it was assessed by motor power scale. Pain assessment was done by modified Hanan-Allah pain scale. The patient with pain score more than 4 were given paracetamol suppository 20 mg per kg as a rescue analgesia. This is the modified Hanan-Allah pain scale. This is the motor power scale. Now talking about the result, there was 27 male and 30 female among the study population. This is the chart for modified Hanan-Allah pain scale. The modified Hanan-Allah pain scale at 30 hour, 1 hour, 2 hour, 4 hour, 6, 8, 12, 24 was compared between two groups using the unpaired t-test. The modified the 30 minute, 1 hour, 2 hour was significantly more among group 2 as compared to group 1. This is the motor power scale. There was no any significant difference using the unpaired t-test. SpO2, again there was no any significant difference in mean SpO2 at baseline, post-induction, intraoperative or post-operative in both the group. Pulse rate, again there was no any significant difference by using the unpaired t-test. Systolic BP, again no significant difference intra-op, post-op or baseline. Diastolic BP, again no significant difference. Mean arterial, again no significant difference. So the conclusion is the current study demonstrated that caudal epidural block was more effective than ilioinguinal iliohypogastric nerve block among children undergoing unilateral inguinal scrotal surgeries. Caudal block carried the advantage of faster onset of action along longer duration of post-operative analgesia with no recorded complications. Thank you. These are the references.
हेलो सर।
Yes, yes. Yeah.
सर वो जो है लास्ट वाली प्रेजेंटेशन जो थी निधि शर्मा वो आ गई है, उनसे Q&A कर सकते हैं आप।
Acha, acha. Is she there? Okay. She started a little late. Okay. So after caudal epidural, did you find any? Okay. What was the induction agent that you used?
Hello?
Yeah, you used caudal for the post-op pain, right?
No, sir. It was given in the beginning of the surgery, and the patient was induced with inhalational agent, and
Like what?
IV cannula was
Inhalation agent?
sevoflurane, sir. Oxygen,
Sevoflurane.
sevoflurane plus nitrous, yes, sir. And
Okay.
after that, IV cannula was secured, and then drugs were given.
Okay. I want to know from you.
Yes, sir.
Do you think? Are you aware of any condition whereby with sevoflurane in children that happens post-operatively?
So sevoflurane in children.
Do you use sevoflurane in the concentrations of?
So 1 to 2%.
Huh?
1 to 2% of sevoflurane, sir.
1 to 2% of sevoflurane. So did you come across any case of and how old were these children and what were the surgeries?
So they were 2 to 7 years of age, and they were all inframumbilical surgery.
Inframumbilical. So did you come across any case of post-operative agitation?
Yes, sir. It was.
Have you heard of such an entity? Have you heard of such an entity?
Because of sevoflurane, sir.
No, with sevoflurane, there's post-op agitation that can happen in some pediatric age group patients. So read about it.
Okay.
Okay,
Yes,
you'll have
sir.
to call. Otherwise, the presentation was good.
Okay. Thank you.
All right. We can move on to the next participant.
Myself, Dr. Nikhil Kumar Kacha. The title of my study is Comparative Study of Use of Dexmedetomidine as adjuvant to bupivacaine in transabdominal plain block and lower abdominal surgeries for post-op analgesia. Study done under the guidance of Dr. Bipin Kesa, Professor of Anesthesia, GCS Medical College Hospital and Research Center. Tape block is a renal block that gives pain relief of the anterior and lateral abdominal wall in lower abdominal surgery. We deposit local anesthetic agent in transabdominal plane with at least 20 ml to get prolonged analgesia. Local anesthetic agent and adjuvant like Dexona, Dexmed, clonidine can be used. Both drugs have similar PK and plasma binding property. Dexmed is a selective alpha-adrenergic agonist with both analgesic and mild sedative properties. Aim is to evaluate and compare the analgesic efficacy of bupivacaine and bupivacaine with dexmedetomidine tape block. Objectives are duration of post-op analgesia, pain score using VAS, total number of rescue analgesia needed in 24 hours, hemodynamic stability, post-operative score. Study is prospective double-blind randomized control study. Inclusion criteria are patients aged between 18 to 65 years, either gender, ASA 1 and 2, posted for lower abdominal surgery. These are some exclusion criteria. After fulfilling exclusion criteria, pressure were divided into Group D and Group B. Informed and written well-explained consent were taken. In Group D, injection bupivacaine 0.25%, 40 ml plus 0.5 ml injection dexmed we will use, and in Group B, we will use injection bupivacaine 0.25%, 40 ml plus 0.5 ml normal saline. We need full resuscitation equipment, ECG, pulse oximeter, BP monitoring machine, antiseptic skin preparation, sterile gloves, 20 gauge dosage needle with extraction set, 20 ml syringe, local anesthetic agent, 0.25% bupivacaine and injection dexmed. We will use lumbar triangle of Petit, the landmark technique described by McDonald for tape block. The landmark technique is easily palpable and bounded by the external oblique muscle anteriorly, latissimus dorsi muscle posteriorly, and iliac crest inferiorly in the region of posterior axillary line. After giving the blow, we will monitor post-op vital, VAS score, duration of analgesia, time for post-rescue analgesic and sedation score. Statistical analysis was done by independent sample T test. 2 p-values were taken. p-value less than 0.05 were judged as statistically significant and more than 0.05 considered as low significant. This table suggesting mean duration of analgesia, which is higher in group D as compared to the group B, which is very significant. This table suggesting of number of times rescue analgesic given, injection paracetamol and injection tramadol were used in this study. This chart suggesting of mean VAS score, it suggests that the VAS score in group D is relatively less as compared to the group B. This chart suggests mean sedation score. It shows that in group D, the sedation score is relatively slight higher as compared to the group B, although both the groups have sedation score in good amount. This chart suggestive of various hemodynamic changes like mean systolic blood pressure, heart rate, diastolic blood pressure, and mean arterial pressure. Both the charts suggesting that in group D there was a minor amount of changes. So it signifies that hemodynamic stability is more in group D, where we use dexmed as adjuvant. So mean duration of analgesia, sedation score, and hemodynamic stability was more in group D as compared to group B. And total number of rescue analgesic needed for post-op first 24 hours were found in lesser amount in group D as compared to the group B. So as an emerging technique, TAP block significantly reduced the pain score and decrease the post-operative analgesic requirement, and also has a high efficacy upon maintaining the post-operative hemodynamic stability. And addition of dexmed as a adjuvant in TAP block further prolong the duration of analgesia, decrease analgesic requirement, maintain hemodynamic stability, provide good sedation, and improve the patient satisfaction score without any adverse effect as compared to the bupivacaine in TAP block. Thank you.
All right, we will move on to the next participant. Dr. Nikhil Kumar?
Yes, sir. Good morning, sir.
Good morning. So, was it you presenting the tab block thing?
Sorry, sir.
The last presentation was yours, right? The presentation on tab block was your presentation, right?
Yes.
I can't hear you. Your audio is not clear. Maybe the OT signals are weak.
Yes. Yes, sir. You are audible, sir.
No, but yeah. What I said, the last presentation was yours.
Yes, sir.
Block, was that your presentation?
Yes, sir.
Okay. So what special features did you think stood out in your study?
Sir, I use injection dexmed for as a adjuvant. So mainly, sir, mild sedation is there post-operatively, sir, as compared to the.
What about bradycardia?
Yeah. Sir, there was a bradycardia is there. So baseline pulse is we have mentioned earlier in the before the given block. After giving the block, there is a slight bradycardia, but nothing as much significant, so we can worry about.
So in how many patients did bradycardia happen?
Sorry, sir.
In how many patients did you have bradycardia?
Sir, around total number of patient I used in study is 100. So around, sir, 8 to 9 patients, sir, I am remembering there was significant bradycardia is there.
Okay. All right. Thank you.
Thank you, sir. Thank you.
We can move on to the next participant. We can move on to the next participant.
epidural surgery, a comparative study between Greetings everyone. I'm Dr. Nikisha from PJ Medical College, Ahmedabad, here to present a paper on controlled hypertension for middle ear surgery, a comparative study between IV dexmedetomidine and IV magnesium sulfate. Middle ear surgeries use operating microscope, which magnify the blood droplets and obscure the surgical field, and so controlled hypertension is used to decrease blood loss intraoperatively. Dexmedetomidine, a selective alpha adrenoreceptor agonist, has a sedative, analgesic, and anxiolytic effect and causes suppression of sympathetic nervous system. While magnesium sulfate is an NMDA receptor antagonist, which produces hypertensive effect by limiting the outflow of calcium from sarcoplasmic reticulum. Aims and objectives include to study the effects of both the drugs on reading, that is surgical field of vision, and surgeon satisfaction during the middle ear surgery, to compare the hemodynamics, the complications associated with both the drugs, to study recovery time and post-operative analgesia in patients of these surgeries. Prospective randomized observational single-blinded study was done in 60 patients of age groups 18 to 60 in Civil Hospital, Ahmedabad, and randomization was done, and patients divided into two groups of 30 each. Group D received dexmedetomidine bolus 1 microgram per kg in 100 ml NS and infusion of 0.5 microgram per kg per hour IV. Group M received magnesium sulfate 50 mg per kg in 100 ml NS and infusion of 15 milligram per kg per hour IV. Inclusion criteria included age group of 18 to 60 years, ASA grade 1 and 2, and scheduled for middle ear surgeries. Exclusion criteria included patients refusal, patients with history of cardiac, respiratory, renal, or hepatic failure, coagulation disorders, allergy to study medications, and patients with BMI of more than 35. Patients' history was taken, pre-operative evaluation done, and necessary investigations ordered. Patient taken inside OT after taking the written informed consent, monitors attached, baseline BP, heart rate, ETCO2, SpO2 recorded, IV line secure, pre-medication done, study drugs given, pre-oxygenation done, and general anesthesia administered. All surgical interventions were done by the same surgical team. Intra-op monitoring was done, and soon after bolus study and intraoperatively at regular intervals, and surgical field assessed by quality scale based on surgeon satisfaction and grading were recorded. Infusion rates were titrated to keep a mean arterial pressure between 60 to 70 mmHg, and if it increased, the sevoflurane was increased or additional dose of these drugs was given. Infusion was stopped at the time of starting skin suture. Reversal was given, extubation done. In post-op observation of the hemodynamics, visual analog score for pain complications, Ramsay sedation score, and modified Eldred score for recovery were recorded. Statistical analysis, mean of plus or minus standard deviation calculated, unpaired t-test done, and p-value calculated. The results were heart rate, fall in heart rate was significant in group D. For drop in blood pressure, mean arterial pressure was more significant in group D. No significant difference seen in ETCO2, SpO2, surgical field, surgeon satisfaction, and duration of surgery in both groups. Post-op sedation and prolonged recovery noted in 15 minutes after extubation in group D. No significant difference in visual analog score. Intra-op complications noted in group D. A few studies were done to compare same drugs. One study concluded that hemodynamic profile of dexmed was steadier than the rest drugs, and one surgery concluded that both drugs successfully induced controlled hypertension. So to conclude the study, we observed that dexmedetomidine or magnesium sulfate in middle ear surgery provided controlled hypertension and better quality of surgical field in both the groups. Stable perioperative hemodynamic responses with no significant complications in microscopic middle ear surgery. Both dexmedetomidine and magnesium sulfate provided advantage of inherent analgesic effect, attenuation of serious responses during the induction of anesthesia and extubation. Thank you. Greetings everyone. I'm Dr. Nikisha from PJ Medical.
Dr. Nikisha?
Yes, sir.
Do you know of any other way of controlled hypertension that you could have also used?
Sir, we can use
You compared two ways, namely magnesium sulfate and dexmedetomidine.
Yes, sir.
Are there other ways in which you can use for ear, nose, throat surgeries, endoscopic surgeries, the ear, nose, throat region?
We can use inhalation anesthetic agents.
Hmm.
We can also use beta blockers.
Hmm. Yeah. At times, people have used incremental propofol and fentanyl as well.
Yes, sir.
That is also, although little crude, but that is also a way to provide.
Yes.
Nikisha, could you please turn your video, please?
No.
All right. All right. That's about all. We can move on to the next participant. Study was good altogether.
Thank you.
We can move on to the next participant. How many more remaining?
Sir, just 2 or 3.
Okay. We'll just wrap it up soon.
CSA is an underutilized technology. Good morning. The title of my presentation is Comparison of Block Characteristics in Continuous Spinal Anesthesia and Continuous Epidural Anesthesia for Lower Limb Orthopedic Surgeries and Interventional Study. CSA is an underutilized technique in modern anesthesia. Continuous epidural anesthesia is a more commonly used technique in routine practice, even though it needs a higher pharmacological dose of local anesthetics as opposed to CSA and is sometimes associated with a patchy or unilateral block. Therefore, we aim to compare block characteristics of continuous spinal anesthesia and continuous epidural anesthesia in lower limb orthopedic surgeries. Our primary objective was to evaluate the grade of sensory and motor block, and the secondary objectives were to compare performance time, induction time, duration of sensory blockade and analgesia, hemodynamic variables, total dose and boluses of local anesthetic required intraoperatively, and incidence of complications. As was an interventional prospective double-blinded randomized study, using data from previous studies, we calculated our sample size to be 142, that is 71 in each group. We included patients of ASA grade 1 and 2, age 18 to 65 years, height 140 to 170 centimeter, weight 30 to 70 kg, and those who underwent lower limb orthopedic surgeries. Patients who refused to participate in our study or with duration of study more than 4 hours, with any systemic illnesses, patients with a history of allergic reaction to local anesthetics, or with any other contraindication to neuraxial anesthesia were excluded from our study. In group CSA, the block was performed using 19 gauge to high pediatric epidural set and 0.5% hyperbaric bupivacaine, whereas in group CEA, the block was performed using 18 gauge to high epidural set and 10 ml of 0.5% plain bupivacaine. We recorded sociodemographic data, a grade of sensory and motor blockade at time P4, which was the time at which T10 sensory level was achieved, different time points for deriving our secondary outcomes, hemodynamic variables, total dose and boluses of local anesthetic required intraoperatively in both the groups, fast score at 1 hour postoperatively, and incidence of complications. We found in our results that the two groups were comparable in terms of age, sex ratio, weight, height, BMI, type and duration of surgery, and level of block. The grade of sensory and motor blockade at time P4 were also comparable in the two groups. However, we found that the performance time in group CSA was significantly longer, while induction time was significantly shorter in group CSA as compared to group CEA. Duration of blockade in group CSA was significantly longer than group CEA, while duration of analgesia was comparable in the two groups. In hemodynamic variables, we observed that in group CEA, there was a significant fall in diastolic blood pressure and mean arterial pressure from the baseline intraoperatively as compared to group CSA. In group CSA, there was significantly lower requirement of total dose of local anesthetic intraoperatively and also significantly less number of boluses required intraoperatively than group CEA. In incidence of complications, the two groups were comparable, and none of the patients in either group reported any incidence of bradycardia rigors, delayed micturition, post-dural puncture headache, meningitis, or focal sensory block. Thus, we inferred that CSA is a safe technique. Compared with CEA, similar grades of blockade and duration of analgesia are attained in CSA with much lower dose of local anesthetic, which is also responsible for greater hemodynamic stability in the perioperative period. Thus, CSA may be the technique of choice for prolonged orthopedic surgeries of lower limb with the advantage of extending the analgesia in the early post-operative period. Thank you.
So it's basically a good study. So it's basically a good study. How many cases did you do observe actually?
Good morning, sir.
Good morning.
Sir, my sample size was 142, so I did like 71 patients in each group, sir.
Is that right? You did 71 patients on continuous spinal?
Yes, sir.
Okay, commendable. Very nice. So, you found the results to be satisfactory in both the groups?
Sir, we found that the grade of block that was our primary outcome. So that was comparable in both the groups, but there were some advantages that we observed in CSA, like lower dose of local anesthetic.
That's okay. But you know, how long? What was the typical average duration of surgery that you?
Sir, most of the surgeries were between 180, more than 180 minutes, so like above 3 hours.
About 3 hours, is that right?
Yes.
So good. I'll ask Dr. Pratibha more about it because I happen to know her, how she went about doing this. But overall, you know, good job. So good. All right. Good luck to you.
Thank you, sir.
So we'll move on to the next participant. We'll move on to the next participant.
Good morning. My study was done to compare the efficacy of ropivacaine versus ropivacaine with dexamethasone using ultrasound-guided erector spinae block for postoperative analgesia in percutaneous nephrolithotomy surgeries. Erector spinae plane block is a simple paraspinal facial block. It was first described in 2016, and ropivacaine was used because it is a longer-acting local anesthetic. The primary objective of the study is the duration of postoperative analgesia. The secondary objective to look for any changes in hemodynamic parameters, time for first analgesic request, and to see for any side effects, if any. Study design, it is a single-blinded randomized comparative clinical study, and the study period was for a duration of 12 months. Inclusion criteria, ASA 1 and 2 patients of either sex, patients aged between 20 to 50 years, and patients undergoing elective PCNL surgeries. Exclusion criteria, patients with known hypersensitivity to local anesthetic agents, patients with bleeding disorders, uncontrolled diabetes mellitus or hypertension, patient refusal, local site infection. The sample size was estimated based on a study conducted by Piotr et al. We selected 25 patients in each group. Informed written consent was taken from all the patients. The patients were randomly allocated into 2 groups based on an open envelope method, where the group R patients received 25 ml of 0.5% of ropivacaine along with 2 ml of normal saline, and in group RD, the patients received 25 ml of 0.5% of ropivacaine along with 8 mg of dexamethasone. On arrival of patient in the operation theatre, monitors were applied and baseline respiratory rate, pulse rate, non-invasive blood pressure, SpO2 and ECG was recorded. An erector spinae block tray was kept ready. After pre-oxygenation, general anesthesia was induced and endotracheal intubation was done. Then the patient's back was prepared and T9 transverse process was identified using the ultrasound probe, and an echogenic needle was used to identify the erector spinae muscle, and 3 ml of normal saline was injected to confirm the spread. And according to group R or RD, 25 ml of 0.5 ropivacaine or 25 ml of 0.5% ropivacaine with dexamethasone was injected as per the protocol. According to statistical analysis, both the groups were comparable with respect to age, weight, height, sex distribution, and ASA grading. The duration of surgery was also comparable among both the groups. Hemodynamic stability was attained in the patients of both the groups, but postoperative analgesia was higher in group RD, that was 980 plus or minus 96.2 minutes, and in group R it was 708 plus or minus 30.6 minutes. The rescue analgesia paracetamol requirement in grams in group RD was 0.74 plus or minus 1.12, and in group R it was 2.3 plus or minus 1.45. And the VAS score was significantly lower in group RD at the end of 12 hours, 18 hours, and 24 hours. Patients undergoing PCNL experience significant postoperative pain. The results in a study correlates to a similar study conducted by Piotr et al., where the average VAS score was less according to their observations in the group which received erector spinae block in patients undergoing PCNL surgery. Also, in another study by Ibrahim et al., they concluded that use of ultrasound-guided erector spinae block provided superior postoperative analgesia and decreased opioid consumption over 24 hours in patients undergoing PCNL surgeries. There are very few studies using dexamethasone as an adjuvant to ropivacaine for PCNL surgery. In our study, we found that dexamethasone is a very good adjuvant to 0.5% ropivacaine in providing superior postoperative analgesia for PCNL surgeries. Limitations: large sample size may have to be used to obtain clinically and statistically valid observation to prove a finding. From this study, we conclude that addition of dexamethasone to ropivacaine prolongs the duration of postoperative analgesia in patients receiving erector spinae block for percutaneous nephrolithotomy without any significant adverse effects. These are my references. Thank you.
So overall, good presentation on dexamethasone. We have had so many presentations on dexamethasone today. And Nivedita, was that you?
Yes, sir. Me, sir. Yes, sir.
Yeah, that was a good presentation. So what do you think is the underlying mechanism of action whereby dexamethasone prolongs the analgesic effect of these local anesthetics?
Dexamethasone, it inhibits the inflammatory mediator, sir. Also, the neuronal discharge, it affects the neuronal discharge, sir. So with that, it is potentiating the action of ropivacaine, sir.
Okay. All right. Good. So
thank you, sir.
This panel block was well done with ultrasound. Are you using ultrasound routinely in your OTs?
Yes, sir. We are using it for all blocks, sir. Many blocks we are performing in our institution, sir.
Where? Which institution are you from?
Sir, Rajarajeshwari Medical College in Bangalore, sir.
Good. Okay. So you're an MD student or a DNB?
Yes, MD student, sir. Final year MD student, sir.
Finally, MD student. So you could have even applied for the TN JHA. Your paper is a good paper. You could have also. Did you apply for TN JHA?
No, sir. I haven't applied, sir.
Why you could have applied for TN JHA paper? Yours was a free paper, right?
Yes, sir.
You could have also applied for some, in some category in which it could have been, compared with others as well. All right. Thank you.
Thank you, sir. Thank you.
So we'll move on to the next. There's a guy from Nashik, Dr. Shashank Nilange. His turn hasn't come. He says his name is there in the list. Hello.
Hello. Of the acceptable length of right internal jugular central venous catheters.
What's happening?
Other authors are Dr. Sunil and Dr. Shaila S. Kamath. Introduction.
What's happening?
The essential parts of the treatment provided to the adult. Good morning, everyone. Today, my e-paper is on assessment of the acceptable length of right internal jugular central venous catheters. I am Dr. R. Nivedita, postgraduate in Kasturba Medical College, Mangalore, and my other authors are Dr. Sunil and Dr. Shaila S. Kamath. Introduction. Central venous catheters were introduced into the clinical practice about 20 years ago. Now it became as one of the essential parts of the treatment provided to the adult and pediatric critically ill patients. Chest radiography have been used to determine the proper positioning of the catheter tip in the superior vena cava. Radiologically, the tip of central venous catheter should be placed at the level of the carina. Since the right tracheobronchial angle coincides with the SVC and right atrium junctions. So to avoid the insertion of the catheter into the right atrium, the tip is placed so that it can be seen on the
at the level of carina. In this study, we want to observe the depth of insertion in 10, 13, and 15 centimeter lengths for patients of height from 160 plus or minus 10 centimeter, such that their length is readjusted if needed. Methods: study setting. The study is conducted in KMC Hospitals, Mangalore. It's an observational study, and the duration of the study is from October 2019 to July 2021. Inclusion criteria: age between 18 to 80 years, and ASA physical status 1, 2, 3, and patients who are scheduled for CTVS and general surgery who require central venous catheter for perioperative management. Exclusion criteria: patient's refusal, any known carotid artery pathologies, cross pathology of the right aspect of the neck, or patients with altered coagulation parameters, arrhythmia, or pacemaker in situ. Sample size is around 145, and the sampling method used is probability sampling. The method used is the patients are randomly allocated into 3 groups. The length of the catheters 10, 13, and 15 centimeters are allocated for 3 different groups in sealed opaque envelope until opened. The attendant anesthesiologist experienced in central venous catheter placement performed central venous cannulation. Central approach is preferred. Post-procedure, chest radiograph was taken. Catheter position was not considered acceptable if it is 5 centimeter above the carina and 1 centimeter below the carina. The results of my study: the total 147 patients were studied in the final analysis, and they were divided into 3 groups, 10, 13, and 15 centimeter catheters. The distance of the tip of the catheter was measured from carina for 3 different lengths of the catheter, and 10 centimeter catheters had a less incidence of malpositioning as compared to other sizes and found to be statistically significant with a p-value of 0.025. Discussion: the improved accuracy of the catheter length were done based on the tailored fit formulas. Even when studies are done finding out the techniques to find the catheter length, enough literature is not present comparing the 3 different sizes of catheters. So our study basically points out using small length of catheters have the greater potential to eliminate intracardiac placements, which goes with the study done by Milji et al. He conducted a prospective study comparing 16 and 20 centimeters catheter and concluded 16 centimeter catheters as most favorable. The limitations of our study: first, the results of the study may not be applicable to population other than Indian heights. Our study was solely based on the Indian population with mean height of 760 plus or minus 10 centimeter. Secondly, our study did not elucidate different catheter lengths for male and female gender respectively. Conclusion: in our study, we concluded that post-procedure chest radiograph is helpful in evaluating the position of the tip of the catheter. So our study shows 10 centimeter catheters are acceptable length for patients of average Indian height, that is 160 plus or minus 10 centimeter. These are my references. Thank you.
Dr. Nivedita. Dr. Nivedita, can you hear me? Dr. Nivedita,
good morning, sir. Can you hear me, sir?
Yeah, I can hear you. So all your cannulations were right
Yes,
side
sir.
cannulations, is that right?
Yes, sir. Only right internal jugular central venous catheter, sir.
Only right. Had you gone from the left side, do you think it would have been shorter or longer?
In left side, it would have been longer, sir, because the course is longer compared to right side, sir.
Good. So this was a very good topic, a very relevant topic, very simply done, and
Yes,
and your results are also good that you found the optimal length is 10 centimeters. You found
Yes, sir.
optimal length in your study.
Yes, sir.
And I somehow tend to agree with your results because that has been my own observation as well. In Indian population, the smaller 10 centimeters is fine, but in the West, it's a little long because of their stature and all.
Stature, yes, sir. Height of the patient.
Height of the patient is there. Even they are broader.
Yes, sir.
As far as Indian anatomy is concerned, your results are fine. So it's basically a good study.
Yes, sir. Thank you, sir.
All right.
Thank you, sir.
Next participant. We'll go on to the next participant.
हेलो सर, आज का जितना इस सेशन का जितना भी था वो सारा प्रेजेंटेशन हो गया।
नहीं, अभी एक रह गया, शशांक ने लांगे।
सर शशांक निंगानिया का हमारे पास कुछ भी नहीं है, ना लिस्ट में नाम है, ना कोई वीडियो है, ना कोई प्रेजेंटेशन.
I have sent hello.
Yes.
I have sent the PO already, and I have the name of my name is on the list, sir, at the 21 number.
But I haven't received it.
Hello.
शशांक, हेलो.
Yes, sir.
सर हमें आपका वीडियो नहीं मिला.
I have sent on the.
Listen. If you want to share here, so you can share it.
Dr. Shashank, do you want to share?
Yes,
the
sir.
screen?
डॉक्टर शशांक, आप यहाँ पे शेयर कर सकते हैं, हम दिखा देंगे.
एक मिनट.
Sir, actually, he has a free paper session in all F. So I was just calling to remind him that at 11 we'll start the session. So you need to join.
Just a minute, sir.
तुझ्या मेलवरून टाकलंय ना.
हो.
मग आपण मेल स्क्रीन शेअर करू.
ठीक आहे.
डॉक्टर शशांक.
यस सर, एक मिनट
सर, आप मुझे ये बताएंगे आपका हॉल कौन सा है?
हॉल जी सर.
I'm calling from hall.
Which hall?
हॉल जी.
जी सर.
Yes.
Sir, please share it.
Yeah, please check it. If not, because your e-paper is there.
सर मी मेलवर सेंड केले आपण.
सर पीपीटी है, वीडियो है, शेयर स्क्रीन पे ये ग्रीन वाला जो आता है, पहले आपको बैकग्राउंड में वो पीपीटी और वीडियो चलाना पड़ेगा. उसके बाद शेयर स्क्रीन पे जाके उस विंडो को सिलेक्ट करके प्ले करना है. ठीक है.
डाउनलोड केलं नाही सर, डाउनलोड केलेला नव्हता, मी मेलवर सेंड केला. झालं. हां सर. नाही, तुझं कुठल्या मेलवर सेंड केलं? आपल्या ग्रुप डिपार्टमेंटच्या.
No. Do you have it saved on your laptop?
No sir.
You don't have it saved on your laptop? The PPT?
Yes sir, I have saved my PPT sir. Yes.
So you put on your PPT and just start sharing your screen.
Okay, just a second sir. एक काम कर, PPT वाच, मी तुला व्हिडिओ काढून. Can I read my PPT here sir?
You can read, you can share your screen, right?
Yes.
You need to see your slides also, right?
Yes sir.
So do that.
The slides कशात आहेत?
I think we are holding back the next session.
Next, sir.
You can ask the hosts if they permit you.
थोडं टाइम मागून देतो का? याच्यावर मेलवर सेंड करू का नेक्स्ट तुला काढून देतो, थोडं टाइम सर. 2 मिनिट सर, जस्ट अ मिनिट. त्यांना नेक्स्ट मध्ये देत, मी करून देतो. शेवटचा आहे सर, शेवटचं कशावर आहे तुझं? एक मिनिट सर. पेन ड्राईव्ह सर. हा सर, हे माझा पीपीटी आहे. हाँ सर. हाँ
डॉक्टर सुशांत प्लीज आप थोड़ा फास्ट कर सकते हैं, ये सेशन लाइव चल।
Yes, sir.
Or can you
Sir,
accommodate him in some other session later?
क्या sir? आज फक्त स्लाइड बघायचे सर, हे जरी पोहोचलं तरी.
If you're facing problems,
Just a second, sir. I will be doing 2 minutes. तुम शेअर करत असा. एक मिनिट सर, एकच मिनिट. नाही नाही. व्हॉट्सअपवर आलेले सर, पण ते
God,
Sir, can I join in another session if possible? Hello.
you will have to ask the organizers.
हेलो डॉक्टर शेषांक.
हाँ सर.
सर मैं आपको एक चैट बॉक्स में एक नंबर दे दूंगा, आप उस पे अपना पीपीटी वगैरह शेयर कर सकते हैं.
हेलो सर.
हम आपको एक नंबर दे देंगे, उस पे आप
हाँ सर. हाँ सर, I have found just a second.
ये दो बोलने वाले आए हैं मेरे पास, कह रहे हैं ऑल जी है हमारा.
Yes sir. Sir, 2 minutes. I will be doing this.
I think you can accommodate him in some other session later.
Sir, I have just attached my pen drive. Just give me 2 minutes.
डॉक्टर शीशा.
Yes sir, I have shared my screen. Just a second. It will be opening.
Please.
Yes sir. Sorry sir. Yes sir. I am sharing that presentation sir with you.
All India, it will be a session between 11 to 1. Okay, it may not.
Sorry, sir. I will call the coordinator, sir. This is, I'm not able to upload it.
I think they can accommodate you in some other session, right?
Yes, sir, because I have tried, but I'm not able to share with you that of my presentation.
All right. So with that, we come to the end of this session.
Thanks. Thank you.
Yeah. So with that, we come to the end of this, first session. I thank all the participants for attending, and as well as other august audience for their gracious participation. Thank you so much.
बैठना और तीन को एक्टिवेट कर देते हैं। एक्टिवेट करना है, मतलब वही जो हमारे ओके ओके आया देखिए ठीक है का E3 है BP का है 1.5 एमसेट में है थोड़ा काफी ज्यादा 130 आ रहे थे एक्टिव में थोड़ा और 25 प्लस रेट आ रही है सेटअप का 1 घंटे सेटअप करिए कर दो
Hello, everyone. I am Dr. Rashesh Diwan, the organizing chairperson for Isacon 2021. I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiologists and the organizing team of Isacon 2021. We all know we have passed through a very difficult phase in the life, and now gradually we are trying to overcome the situation. Many of us suffered the pandemic, and of course, many of us also worked for the pandemic, for the community, and we were praised all over the country and all over the world. It was a great learning time for all of us. However, we missed the last year completely for the academics. But now we are beginning, and we are beginning with a very mega academic fiesta under the banner of Indian Society of Anesthesiologists. This is the biggest ever hybrid conference and happening for the next 5 days. I'm sure you will enjoy the most. We have made a humble attempt to accommodate as many presentations as possible. And in view of the overwhelming response for the presentations, we extended the conference on the pre-CME day. This is the today. We are starting today at 8 o'clock, and we have plenty of e-papers accommodated for 1 day. Once again, I thank you all for the participation in Isacon 2021 and wish you good luck. Stay safe. Long live ISA. The organizing chairperson for Isacon 2021. I welcome you all.
Dr. Devanand, sir. Dr. Devanand, sir. Dr. Devanand, sir? Dr. Devanand, sir?
Yes.
Sir, we can start the session now.
Okay, okay. Okay. Let me know who is the presenting person first.
Okay, sir, I can share the screen. The first presenter.
Is it audible?
Sir, you are audible. Now I
Yeah.
can share the first presented video.
Okay.
If you want to talk, sir.
All the I am the behalf of Indian Society of Anesthesiologists, Isacon 2021. I welcome all the presenters to today's second session, and I request the first person to present his e-presentation.
Isobaric thoracic spinal and good afternoon, respected judges. Today's the topic of my presentation is to compare isobaric thoracic spinal anesthesia versus general anesthesia in laparoscopic cholecystectomy. As an anesthesiologist, we all conducted general anesthesia and regional anesthesia every day. In our routine practice, we prefer general anesthesia in laparoscopic cholecystectomy, while in unhealthy or in patient with certain comorbidity, we prefer regional anesthesia like low thoracic isobaric spinal anesthesia, because as we know, there are certain side effects and limitation of general anesthesia which can progress their disease or comorbidity and affect relevant outcome of the surgical procedure. Thus, with the background of this, we decided to conduct a study in which we gave low thoracic isobaric spinal anesthesia in a healthy individual so as to avoid the side effect and drug overuse in general anesthesia. After taking approval from IEC from our institute, we decided to conduct an open clinical trial study in 60 patients between January to September 2021. We included patients of ASA grade 1 and 2 in between ages 18 to 60 years with normal population profile, and we exclude patients of ASA grade 3 or more or any other significant like cardiac, respiratory or abdominal comorbidity. We divided the 60 patients into two equal groups. In group IS, we gave 0.5% levobupivacaine 2 to 3 ml and injection fentanyl 25 microgram in T9 to T10 or T10 to T11 space. While in general anesthesia group, we gave general anesthesia to patients which include injection glycopyrrolate, injection midazolam, injection fentanyl, injection propofol, muscle relaxant, and at the last, reversal. In parameter, we observe intraoperative and postoperative hemodynamic parameter, analgesia duration, side effects, recovery, and patient satisfaction at follow-up. We compiled data in MS Excel sheet 2019 version and found p-value less than 0.05%, and we applied ANOVA test for this. There is no significant statistical difference between two groups, that is age, gender, height, weight. There is a slight fluctuation in parameter like heart rate, blood pressure during initial hours or during the pneumoperitoneum. But in isobaric group, postoperative analgesia is better as compared to the general anesthesia. At the end, we found isobaric spinal anesthesia showed good control in intraoperative and postoperative pain control as compared to the general anesthesia. Post-operatively, only few patients show side effects like nausea and vomiting, abdominal pain, shoulder pain, and anxiety, which can be easily managed with the medication, and they can resume their oral intake on the day of surgery itself. In our study, we found that side effects were minimal, but patient satisfaction score were high. According to this table, in isobaric group, very few patients complain about side effect as compared to the general anesthesia, which can be easily managed with the medication. As compared to the earlier study, Grammatica et al. Took 20 patients with obstructive pulmonary disease and found certain side effects in few patients. NG anesthesia found cardiovascular changes and paresthesia in elderly patients. So at last, we concluded that this study provides evidence that segmental spinal anesthesia can be used in place of general anesthesia to avoid side effect and minimizes the risk of general anesthesia also in healthy individuals. Thank you. Good afternoon, respected judges. Today's the topic of my
Hello. Hello, Nivedita.
Good afternoon, sir.
Good afternoon.
Good morning, sir.
See, you have chosen the spinal anesthesia, especially segmental anesthesia for doing a laparoscopic cholecystectomy.
Yes, sir.
To what extent the level of blockade, to what extent you have done it?
Sir, in T9 to T10 space.
Which space you have chosen?
Sir, in T9 to T10 or T10 to T11 space.
Oh, okay. So what level you got a blockade? You have checked that? All the cases?
Sir, all the cases I checked in T9 to T10 space most of the time.
T1 to T10?
T9 to T10, yes, sir.
T1 to T10. During whenever you block for up to T1 to T10, you didn't find any changes in the cardiac rate and then the pressure and all these things you never anticipated?
Sir, please repeat your question. Sorry.
Because what happened, once if you block up to T1, you know, cardiac axillary fibers T1 to T4. Huh?
Yes, sir. Yes, sir.
Those things are not disturbed with that?
Yes, sir. Because it's a segmental block, so it will not be disturbed.
But once if you are allowed, you prefer spinal anesthesia for cholecystectomy or you want to go for general anesthesia?
Sir, we want to go in for spinal anesthesia because it is in order to avoid the side effect, and the post-op analgesia is also very good. So
what does usually, because if you consider spinal anesthesia versus general anesthesia, see what side effects you come across with the present available drugs in general anesthesia?
Sir, mainly the intubation during the intubation process, and in the post-op also the abdominal pain in the general anesthesia. So while giving the isobaric spinal anesthesia, we avoid that side effect in this.
So if you weigh the advantages and disadvantages, why can't you think of going for epidural and general anesthesia?
Epidural and general anesthesia. Yes, sir. It provides the better post-op analgesic effect while we are using the general anesthesia along with the epidural. But we cannot avoid the intubation process while we are facing and in
Now,
the
rule of thumb, suppose if you consider taking the consideration of number of cholecystectomies done under laparoscopy, which technique was preferred?
Sorry, please repeat your question. Sorry, sir.
In your institution, you are doing regularly with spinal anesthesia?
Yes, sir.
Huh?
Hello.
Host. Okay, let us go to the next session.
Yes, sir.
Next presentation, please.
A warm greetings to the panel members. This is Dr. Nivedita, final year resident from Osmania Medical College. My original research paper is on a prospective randomized study to evaluate the analgesic efficacy of ipsilateral intercostal nerve block and open transverse abdominal spleen block with indwelling catheter for perioperative analgesia in open renal surgeries. Perioperative pain is an unpleasant physical sensation leading to stress response and morbidity. Renal surgeries require a rib resecting, flank incision. Inadequate perioperative pain management results in morbidity and prolonged hospital stay. Regional anesthesia techniques are safe and effective means of treating perioperative pain as local anesthetics are injected at the surgical site and avoids side effects of systemic analgesics. Intercostal nerve block and open transverse abdominal spleen block are valuable technique for treating perioperative pain in open renal surgeries. In this study, we evaluated efficacy of ipsilateral intercostal nerve block and open transverse abdominal spleen block with an indwelling catheter. Our institutional ethics committee has approved the study, and the study included 30 patients scheduled for open elective renal surgeries, which included pyeloplasty, pyelorethotomy, nephrorethotomy, and nephrectomy of both genders in age group of 25 to 60 years, of ASA 1 and 2 physical status, and patients who gave consent for the open renal surgeries. And the study excluded ASA 3, 4, 5, 6, and E, and patients with a history of sensitivity to local anesthetics, coagulopathy, and pregnant women. And the patients have been selected by simple randomization, and standard general anesthesia technique was adopted. Steady patient with delta ondansetron fentanyl 1 microgram per kg, injection protocol of 2 mg per kg, and neuromuscular blockade with injection atracurium for loading and maintenance, and anesthesia maintained with oxygen nitrous of 50:50 and sevoflurane of 0.5% concentration. After positioning of the patient under aseptic precaution, marking has been done in ipsilateral 9, 10, and 11 intercostal nerve block performed in the mid-axillary line with 2.5 ml of 0.25% bupivacaine. Intraoperatively, hemodynamic response to surgical incision was recorded at every 5 minutes, 30 minutes, followed by 15 minutes till the end of the surgery. At the end of surgical procedure, 0.25% was injected, and 18 gauge epidural catheter is placed in the transverse abdominal spleen, and wound closed in layers, and patients have been extubated. Post-operatively, visual unlock scale score was monitored at 1, 2, 6, 12, 18, 24, and 48 hours. Analysis was supplemented with 20 ml of 0.125% bupivacaine on call for the next 48 hours post-operatively, and catheter has been removed after 48 hours. Duration of analgesia and concentration of inhaled anesthetic opioid use, time for first analgesic supplementation, number of rescue analgesics required, and pain scores have been recorded for statistical analysis. We found that mean heart rate has been maintained between 79.6 plus or minus 5.8 standard deviation, mean systolic blood pressure of 112.76 plus or minus to 6.3 standard deviation, mean diastolic blood pressure of 74.89 plus or minus 5.1 standard deviation, and mean arterial pressure of 81.74 plus or minus 8.5 standard deviation. Mean duration of analgesia came to about 7 hours 17 minutes 30 seconds plus or minus 44 minutes plus 13 seconds of standard deviation, and number of rescue analgesics with the mode of 2, and visual unlock scale with the mode of 2 for the first and second hour, and 1 for the 6th and 12th hour, and patients were very comfortable in the 18, 24, and 48 hours. To discuss with regional anesthesia techniques are part of multimodal approach for treating perioperative pain. Only few studies are reported for open tab block for postoperative pain management for renal surgeries. Rib resection is most painful step during the surgery, and pre-incisional ipsilateral intercostal nerve block has adequately attenuated the pain. Open tab block is an emerging technique, and local anesthetic is safely and precisely injected in the transverse abdominal spleen and is effectively attenuated post-operative pain, minimal requirement of analgesics. This is the pie chart showing percentage of patients with duration of analgesia post-surgery. To conclude, with ipsilateral intercostal nerve block or open transverse abdominal spleen block with indwelling catheter provided effective perioperative analgesia and hemodynamic stability extending into the post-operative period for 48 to 72 hours with the reduced consumption of analgesics and anesthetics. These are my references. Thank you.
Okay, next paper. Hello.
Good morning, sir.
Intercostal now, how you are blocking in your center?
Sir, after marking with the patient at the undersurface of the above rib 9, 10, and 11th intercostal ribs, we are blocking, sir.
Where exactly you are blocking?
At the mid axillary lines.
You are blindly, how do you elicit?
We pre-mark the patient by palpating by landmark technique only, sir.
How do you ensure that it is blocked?
Sir,
Are you not using ultrasound guided?
no, sir.
Or you are using a nerve stimulator?
For this, we use
No, blindly you are giving.
Yes, sir.
Blindly you are giving.
Yes, sir.
You are eliciting
After negative
paresthesia or not?
aspiration, if the for blood and air, we'll give the drugs.
See, just with the negative aspiration, you are injecting or you are eliciting paresthesia.
Eliciting, sir.
But you are not using any other better techniques. Ultrasound guided or nerve stimulator.
No, sir. For this study purpose, we didn't use as it was not.
In open, it's okay. In open, I think you are putting a catheter in the plane and then you are injecting, isn't it?
Yes, sir.
See, when you want to know the ensure the proper thing comparison, because you have to ensure that the nerve is properly blocked. In a blind technique, what happened? There will be failure rates, isn't it?
Yes,
so how can you compare? If it is a single study, of course, in open technique, if you have assessed the post-operative pain by putting a catheter, it's acceptable. When you are comparing, your technique should be 100% perfect, isn't it?
Yes, sir.
Otherwise, how do you compare? To say that a tap open block is better, isn't it? See, what happened when you choose to compare whatever the cases you have taken as in a control, isn't it? See, that should be ensured that you are given proper intercostal block.
Yes.
That is only possible with ultrasound guided and then even peripheral nerve stimulation, isn't it? Then
Yes.
only you can inject properly so that you can assess whether the block is activated or not. Or the cases which you are failed to get the analgesia post-operative, you would have eliminated those cases.
Yes.
Isn't it?
Yes.
Failure is also known to occur, isn't it?
Yes, sir.
But you have not eliminated all the cases. You are very good at intercostal block. Okay. Okay. Thank you.
Thank you, sir.
Okay, start present.
Good morning, my name is Pallavi Jagdal. Comparison between pressure volume refluxer technique and conventional parallel calibration technique in achieving the safe endotracheal tube tap pressure and its change one order of the use of nitrous oxide. Study was aimed to compare the two methods of tube tap pressure inflation, that is conventional verbal filtration technique and pulmonary pressure volume refluxer technique, to compare the volume to inflate the calf, to compare the tap pressure after before use of the nitrous oxide and post-operative complications. It was comparative disability study in Bangladesh Medical College with the medical clearance, and patient over 18 years of age with the ASA grade of 1 and 2 and 18 to 85 of the BMI was the inclusion criteria. Exclusion criteria was unwilling patients and bone positions surgery and extubation blood stain ET2 cup and cuffing and extubation and patients with the ET2 cup which was snugly fitting. It was double blinding technique and this was celebrated into groups in the method. Sample size was 37 in each group, total 72 patients. In the group of the pressure volume technique, the after passing ET2, 2 ml of the air was inflated and increment of 0.5 ml to closure of the pressure volume loop in the anesthesia machine monitor, namely when the expiratory limb reached the zero volume and made the starting point of the expiratory limb. Cuff inflation was stopped. In the second group, ET2 cuff pressure was inflated and palpation of the gross IT of the intertube cuff pressure was taken. Second investigator valid to the method of the cuff inflation was completely deflated the cuff and measured the amount of the air to use the cuff inflation technique. And then the patients was assessed for the post-operative complications, cuff-related complications like sore throat, cough, and the hoarseness on the grading system of 0, 1, 2, 3. The demographic data was not statistically significantly different, and also the mean volume of the air to inflate the cuff was lower in the pressure volume loop group. Cuff pressure at the beginning was lower in the pressure volume loop group, and cuff pressure at 1 hour after the use of nitrous oxide was lower in the pressure volume loop group. But diagram showing the volume required to inflate the cuff was higher in the palpation group. The cuff pressure was higher in the palpation group, and also the cuff pressure 1 hour after use of nitrous oxide was higher in the palpation group. Throat and cough and the hoarseness of the voice after 2 hours and 24 hours of the post extubation was higher in the palpation group. C. Goblin first assessed the tracheal mucosal blood flow in the patients with the cuff inflation, different cuff inflation patient. It was found that the safe pressure was up to 22 millimeter of the mercury in our study. In pressure volume glucose, it was on the therapeutic range of the cuff pressure, that is 16.77 millimeter of mercury. Fernandez tested the finger perfusion technique. It was found that only 58% of the cases it was in the normal range. If user at all experienced the perfusion technique was totally on the experience of the anesthesiologist. You will also find that pilot vision perfusion technique was a very good method to find out higher cuff pressure. And Amaki used the comparison between Jackson and the pressure volume loop pressure technique. It was found that the lower pressure was found in the pressure volume loop technique. Pressure Kumar General also found that the pressure volume loop technique was having lower pressure than the audible lead technique. And also, endotracheal conclusion is endotracheal cuff pressure was within therapeutic range when pressure volume loop technique was used, and the loop palpation technique, and also postoperative complications was laser and nitrous oxide use have a very little effect in case of the pressure volume loop technique. These are my references. Thank you.
Hello. 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 Hello.
Sir, can we go to the next presentation? Sir, can we go to the next presentation? Dr. Devanand, sir?
Yes, we'll go to the next session.
Sure, sir, sure.
Good evening. I am Dr. Pallavi Jain from Sri Aurobindo Institute of Medical Sciences, Indore. The topic of my study is to compare the effect of opioid and opiate-free anesthesia technique in post-bariatric surgery patients undergoing upper GI endoscopy. Upper GI bariatric surgery, as we all know, is a very safe and effective long-term treatment for the morbidly obese patients. And we also know that the morbidly obese patients pose a great challenge to us anesthesiologists because of the perioperative mortality and morbidities that pose a very great risk for their health. The rationale of the study was to compare the effect of opioid and opiate-free anesthesia technique in post-bariatric surgery patients, as there are very few studies that have been conducted in the morbidly obese patients undergoing sedation for daycare procedures. Our main objectives were to study the effect of IV fentanyl and propofol and IV ketamine and propofol on gag reflex, fall and saturation, emergence, delirium, and the sedation score using the Ramsay sedation score and any side effects that were there in the study. In this study, we included patients who were more than 18 years old, who had a BMI of more than 35 kg per meter square, who fell under the ASA grading of 1 to 2, and who gave the consent to be part of the study. 100 patients were selected, which were randomly divided into two groups, Group A and Group B. The patients in Group A received IV ketamine at a dose of 0.15 mg per kg and IV propofol 30 to 50 mg, and the patients in Group B received IV fentanyl 0.5 micrograms per kg and IV propofol 30 to 50 mg at the time of induction. Both the group patients in the group were pre-medicated with glycopyrrolate, and they were administered xylocaine mouth gargles and spray for local anesthesia. Then for the parameters that we studied were gag reflex, emergence delirium, fall in saturation, any recall of the procedure, and sedation score, that is for which you use Ramsey sedation score. In the result, we can see that the patients in Group B, that is the patients who receive opioid or fentanyl, 12% of the patients showed gag reflex, and also 6% of the patients showed fall in saturation rather than the patients receiving ketamine. For emergence delirium, 8% of the population receiving ketamine showed emergence delirium, and 4% of the population showed recall of the events. 4% of the population receiving opioid showed this. In the discussion, in the Tendon et al. Study, which was conducted in 2009, we had a comparable result, as they also comprehended a subanesthetic dose of ketamine to decrease gag reflex, which was very similar to ours. In the Rab et al. Study, they showed a result of episodes of hypoxemia, that is SpO2 less than 90% in pediatric population. They were not associated with any serious complication, and so is the result in our study. And so, to summarize our study, we can say that all the 5 parameters are proportionally comparable in both the groups. And emergence delirium, even though this is statistically non-significant in Group A, that is the patients receiving propofol and ketamine, it is clinically significant. No patients required any bag and mask ventilation or showed any side effects during the procedure. And a sedation with low dose ketamine and fentanyl is extremely safe in extremes of age. In the extremes of ages. We can conclude by saying that both propofol and ketamine and propofol and fentanyl provide adequate amnesia and sedation for upper GI endoscopy in morbidly obese patients without any side effects, and can be used at the extremes of ages. Thank you.
Hello.
Good morning, sir.
Morning. See, which one you prefer? Usually the obese patient, as you compare, when you're given a choice, which one you prefer?
So ketamine is better any day in an obese patient because of its bronchodilatory effects, and it has minimal side effects on the respiratory system as compared to fentanyl, which has a respiratory depressing effect. And as it is in the obese patient, the respiratory system is compromised in a lot of them. So I would prefer ketamine over fentanyl.
But why you choose ketamine? Do you know what are the adverse effects of ketamine in a morbidly obese patient?
Yes, sir.
Because you are looking after, from your point of view as an anesthesiologist,
yes,
that ketamine usually it causes, but surgeon point of us, what are the problems usually we anticipate with the ketamine?
So with ketamine, the patient usually experiences post-op nausea, vomiting, and we cannot use it in a patient with raised ICT or any CNS
important
adverse.
thing, as you know, that ketamine, it increases the muscle contraction, is it? Sometimes what happens, this muscular spasm and all, sometimes
yes,
even they try to bite, because, is it not?
Yes, sir.
And emergence phenomena, which sometimes
yes, sir. Emergence delirium was seen with
phenomena
ketamine.
varies from patient to patient, is it not?
Yes, sir.
If that is the case, propofol and then fentanyl combination, why you think it is not good?
Sir, fentanyl is good for all other things, like post-operative pain and everything, but only because in patients having OSA, fentanyl should false
Okay. Let us move to the next session.
Good morning, all. Myself, Dr. Panjrisha from Baroda Medical College. My topic is ultrasound guided supraclavicular block comparison between single point and double point injection technique, a prospective randomized double-blind study. Introduction: supraclavicular block is the most commonly performed brachial plexus block to provide anesthesia for upper limb surgeries. Potential advantages of ultrasound guidance include direct visualization of the anatomical structure, needle tip, and drug spread. There are different techniques for depositing local anesthetic drug around the brachial plexus, such as single point, double point, multiple point injection technique. Multiple point has higher incidence of nerve injury. The single point usually fails to block the lower trunk as it is situated at middle and inferior aspect. Double point injection technique involves deposition of drug in corner pocket, resulting in less occurrence of ulnar nerve sparing. My primary objective was to compare rate of successful block in terms of blocking of all four nerves. Secondary objectives were to compare procedure time, sensory and motor block characteristic, hemodynamic parameters, and complications. Material and methods: type of study, prospective randomized double-blind clinical study. Sample size estimation was done and shown. Inclusion criteria: patients between age group of 20 to 60 years of either gender, BMI less than or equal to 30 kg per meter square, ASA physical status 1 or 2, posted for elective forearm surgery, able to give written informed consent. Excluded criteria: not willing for procedure, history of coagulopathy, pre-existing neuropathy, nerve injury, local site infection, hypersensitivity, significant history of drug alcohol abuse, psychiatric illness, pregnant or lactating mother. Grouping and randomization: patients were randomly allocated into two groups, group SP and group DP, using sealed envelope method. Ethical clearance and CTRA registration were obtained. Methodology: pre-anesthetic evaluation of patient was done and written informed consent was taken. All baseline parameters were observed and recorded before the procedure. Pre-medication: all the patients were pre-medicated with injection ondansetron, glycopyrrolate, and midazolam 5 minutes before induction. For ensuring blinding, randomization was done using sealed envelope method, which were numbered and were opened by the designated consultant of the work area just before the administration of anesthesia. All the study parameters were assessed by a colleague who was blinded to the group allocations. For the procedure, patient was positioned supine, head turned to contralateral side. Under roll aseptic antiseptic precaution, the transducer was positioned in the transverse plane immediately proximal to the clavicle, and the subclavian artery and brachial plexus were identified. Then a 23 gauge spinal needle was inserted using in-plane technique from lateral to medial direction. In single point injection technique, as the needle reaches the plexus, 11 o'clock position as shown in the image, 30 cc of injection liver bupivacaine 0.5% was injected. Double point injection technique, as the needle reaches at corner pocket 7 o'clock position, 15 cc of drug was injected and remaining 15 cc was injected in superlateral aspect. The time from USC positioning to completion of local anesthetic injection was considered as procedure time. Adequacy of the block was ensured by assessing the dermatomal distribution of ulnar, radial, median, and musculocutaneous nerve. Sensory effect was checked by pinprick method and graded accordingly. The motor effect was checked by modified Probe scale and graded accordingly. Onset time, time to achieve complete block, duration of sensory and motor block were noted. Evaluation of block success was based on the effects achieved and categorized into complete, incomplete, and failed block. Interoperatively, all the patients were monitored continuously at regular intervals. Postoperatively, patients were monitored for vital parameters and complications for 24 hours. The statistical analysis was done using Medcalcy's statistical software. This is my result. Time to take and perform the block was 10.7 minutes in group SP, and 28 patients in group DP had successful block. The onset was significantly faster and duration of block was significantly prolonged in group DP. Discussion: double point injection technique had higher rate of success in terms of blocking of all four nerves compared to single point injection technique of USG guided brachial plexus block. Other than expertise of the operator, there are certain anatomical factors like presence of septate barrier around the plexus that prevent the uniform spread of drug and may also result in an incomplete block. Ulnar nerve sparing was the most common observed finding. The procedure time was significantly longer in double point injection technique due to more needle manipulation, redirection, and hydrodissection. The onset of sensory and motor block was significantly faster, and the duration of block was significantly prolonged. There was no complication in either of the two groups. Conclusion: the success rate in terms of blocking of all four nerves, onset and duration of sensory and motor block was significantly high in double point injection technique with integration of corner pocket technique of USG guided supraclavicular block as compared to single point injection technique at the cost of longer procedural time. These are my references. Thank you.
Hello.
Hello. Good morning, sir.
Morning. What premedication you are given?
Sir, injection ondansetron, glycopyrrolate, and midazolam, according to the weight.
Okay. What made you to think of giving glycopyrrolate to this patient? There should be rationale. No? For example, you are given a ondansetron and then the midazolam and all these things, it's okay. Yeah, is it not? Yeah?
Yes, sir.
Why?
If in case my sir, actually on the basis of the effects, my block were categorized into 3 groups: complete block, incomplete block, and failed block. If
Yeah.
in case 2 or more than 2 nerves get spared, that I had to at that time I had to provide general anesthesia to the patient.
That time you can give, no? Why unnecessarily to give glycopyrrolate to all the patients? Vagalitis. Is it right? It's not advisable. What would have given other than that for all the patients? Routinely.
Ondansetron just and midazolam, sir.
Other than that, what would have been given in your centers for all the regular patients? Today, the basic concept of giving
Dexmedetomidine, sir.
not dexmedetomidine. H2 blockers you are not giving?
In our institute, we do not give actually, sir. H2
You don't give
blockers
to all the
routinely.
patients?
Not in all patients, sir.
No. Which patients you give?
We give in pregnant ladies.
Which one?
For CS, planned for CS, sir.
No, antacids you don't give for any patients.
Regularly, we don't give in every patient. We just give H2 blockers in CS patients, sir, in our institute.
Elective cases you don't give.
No, sir. We don't.
So you prefer to give antacids or glycopyrrolate? Which one is ideal? Okay. Thank you.
Thank you.
Next session.
Greetings everyone. My topic is comparison between 25 with 13-point spinal anneal and 25 with pencil-point spinal anneal in terms of complications in patients undergoing lower limb surgery under subarachnoid block. Is a prospective randomized single-band study. Introduction. The subarachnoid block is a widely used mode of regional anesthesia for various lower limb surgery, where complications like PDPH and PDPB are complications which studies both that can be reduced by using higher gauge spinal needles and by using different needle tip designs. So we decided to compare these two needles for comparing complications. Aims and objectives. The aim of this study was to compare complications of subarachnoid block in patients undergoing lower limb surgeries under subarachnoid block with respect to these two needles. Primary objective was to compare incidence of PDPH and PDPB, while secondary objective was to compare incidence of hypertension, nausea, and vomiting. After IRB approval and informed consent, the study was carried out in Department of Anesthesiology, University Hospital, Bhavnagar, and also in Orthopedics Operation Theatre, with a population of patients undergoing elective or emergency lower limb surgeries under subarachnoid block during the duration of 11 months. And the sample size was 70 patients, where the patient was selected by simple random sampling by computer-generated random numbers after thorough assessment and preoperative fitness. The patients were included according to following criteria of age of 18 to 6 years of either gender, scheduled for elective or emergency lower limb surgeries under subarachnoid block with ASA physical status of 1 and 2, and with no history of previous back and a preoperative blood pressure of more than or equal to 100 by 70 millimeter of mercury. The patients are excluded according to following criteria for patient refusal, unwillingness to participate in the study, pre-existing neurological deficit, history of allergy to anesthetic agents, patients having altered coagulation profile, local site infections or spine deformity, and with history of migraine or recurrent headache. On the day of surgery, baseline parameters were recorded preoperatively, and the patients received subarachnoid block according to the following groups. Group C received 20 subarachnoid block with injection bupivacaine 0.5% heavy, 3.2 ml plus tramadol 0.5 ml with cutting point spinal needle, while Group B received the same drug with pencil point spinal needle. The subarachnoid block was performed in sitting position at L3, L4 intervertebral space after local infiltration. At the end of injection of both the groups was taken as time 0. Immediately after the block, hemodynamic variables were assessed at 60 minutes till 60 minutes. All the patients will be given headlock position for 24 hours and then followed up 6 hourly till end of 72 hours for occurrence of PDPH and PDPB. The PDPH was graded on the basis of grade 1, 2, and 3 as mild, moderate, and severe, and the PDPB was graded on basis of numerical rating scale. Hypertension was defined as the fall in blood pressure less than or equal to 65 mmHg of mean arterial pressure. Observation and result. The patient characteristics in terms of age, weight, and height were comparable between both the groups. Patient characteristics in terms of incidence of different grades of PTPH were comparable between both the groups. The patient characteristics in terms of backache were also comparable between both the groups. Patient characteristics in terms of changes in hemodynamic variables where heart rate, respiratory rate, SpO2 and fall in mean arterial pressure were recorded were comparable between both the groups. So discussion of this study is that in our study, the incidence of PTPH in group C was 5.71%, while in group P it was 2.8%, which was statistically not significant but a clinically relevant finding, which was consistent with other studies. The studies were also the results of this study were contradictory to a meta-analysis involving 25 RCTs, where pencil points finally were superior according to their study. The incidence of PTPH were comparable maybe due to the use of Panadol in our study was of 25 Hz, maintenance of adequate hydration intraoperatively and postoperatively, and also due to the fact that subretinal block was given in sitting position with dual orientation kept parallel to dural fibers and head low position for 18 to 24 hours. The incidence of cross-dural puncture backache was 2.8%, which was equal in both the groups, which shows that there is no difference. There is no role of needle tip designs or incidence of PDPP. Both the groups are comparable with respect to changes in hemodynamic variables, and there is no incidence of nausea and vomiting. So we recommend using proper technique while performing the subretinal block and proper intraoperative and postoperative care, and using higher gauge spinal needles to reduce incidence of PDPH and PDPP. Also, more studies are required to establish superiority of one needle over the other. Thank you.
Hello.
Good morning, sir.
Okay.
Good morning, sir.
In a post-dural puncture headache, what important thing you supposed to practice to prevent this?
Post-operatively, sir, we have to give head position up to 18 to 24 hours.
Huh? No.
I actually didn't get the question. Can you repeat that, please?
What important thing? Because what happened? You compare with a pencil and then cutting edge, is it not? So what important thing as an anesthesiologist you should practice mainly, because your main aim is to prevent the post-spinal headache, is it not? Post-dural puncture headache, is it not? So what important thing you supposed to do this?
Maintain proper techniques, sir. Post-operatively and take proper precautions by administering.
With regard to the puncture, you know that post-dural puncture headache mainly causing the trauma to the dura, is it not? See this, how best you can prevent. One is using the small needle. Important thing is technique is concerned. You have to think of something. What?
While like 20 point needle, we have to use the hub of the needle should be parallel to the dural fiber actually to create minimal trauma.
Important thing which you are not mentioned, because most of the times when you are doing a study for taking up this post-dural puncture headache, important thing is the individual, when you want to puncture the dura, you should always ensure that you are separating the fibers. The bevel has to be looked at all the time. Whether you do it with a cutting needle or with a pencil edge. That is very important thing. Second thing is the number of pricks you use, because that you are not mentioned anyway. For example, with the same pencil needle, if you are punctured 4 or 5 times, because such things you would have eliminated, that you would have mentioned. Because what happened, the number of pricks, that's the reason the individual person, when you want to compare the study, individual person and the number of pricks you try to use when you take into consideration of post-dural puncture headache has to be considered. Another thing is, with regard to the exclusion criteria, the patient have a pre-existing headaches, migraine, and then dehydrated patients. All these patients would have been eliminated. That you would have mentioned.
They are in the exclusion criteria.
Okay. Okay.
Thank you.
Thank you.
Good morning to all. Myself, Dr. Paras Kumar. My title for e-paper presentation is Origin of Levobupivacaine versus Levobupivacaine in subcutaneous infiltration for post-operative analgesia in lower segmental cesarean section. Introduction. Post-operative pain is one of the major concerns after cesarean section. Local anesthetic wound infiltration is employed as a part of multimodal analgesia to reduce post-operative pain. My aim of study is compare analgesic efficacy of the subcutaneous wound infiltration of levobupivacaine alone and levobupivacaine plus ketamine for post-operative pain after C-section. Method: randomized double-blind study is conducted at Janana Hospital. 60 participants of ASA grade 2nd undergoing elective cesarean delivery with age group 18 to 35 years, single-tone pregnancy, not in labor, and gestational period is 37 weeks or more than 37 weeks. They are divided into two groups. 30 each group. Group A received surgical wound infiltration with 0.5% levobupivacaine, 1 mg per kg body weight dilated up to 30 ml using NS. Group B received infiltration of 0.5% levobupivacaine plus ketamine, 1 mg per kg body weight dilated with NS. Through pre-anesthetic checkup was done and investigation is checked. After shifting the participants to operation theater prior to subarachnoid block, the vitals are checked according to ASA grade. The patient is cannulated and ringer-lactate solution is preloaded. Subarachnoid block is given using 2 ml 0.5% hyperbaric bupivacaine with help of 25 gauge Quincke needle. Surgery was allowed to proceed after sensory block and motor effect is confirmed. At the end of surgery, participants received subcutaneous skin infiltration of the study drug as per random group location in blinded manner by the surgeon prior to the skin closure. Post-operative pain score and first analgesic rescue requirement was recorded. Any patient with VAS score more than or equal to 4 at or any time of patient complaining of pain was administered with 50 mg intravenous injection of tramadol. If patient is complaining after 1 hour, then again repeated the same dose. Statistically analysis. All the parameters were analyzed using ANOVA t-test with p-value were considered statistically significant. Result: mean time to first rescue analgesia of the group A was 149 minutes, while the group B was 228 minutes with difference is statistically significant. Mean heart rate and VAS score was higher in group A compared to group B, statistically insignificant. Subcutaneous wound infiltration with local anesthetic is effective, safe, inexpensive, without the need of experiment. We observed that patient group in group B experienced more post-operative pain-free period than the group A. This portrays that local wound infiltration provided adequate analgesia and addition of ketamine to levobupivacaine significantly contributed in the prolongation of pain-free periods. Conclusion: addition of ketamine to levobupivacaine for subcutaneous surgical wound infiltration prolonged the analgesia duration, increasing the time to first rescue analgesia, hemodynamically stably improve the patient satisfaction compared to the levobupivacaine alone. My reference is thank you.
Hello.
Hello. Yes, sir. Good afternoon, sir.
No, very good afternoon. See, you compared, after giving a subarachnoid blow, you have compared the post-operative analgesia by local infiltration, is it not?
Yes, sir.
Okay. In your study, what are the pre-medications you are given to the patient?
Pre-medication, sir, pregnant ladies for LSCS, you are giving Rentec, metoclopramide. Generally, we are giving. And
But
we
you
have
have not mentioned in your study what pre-medication standardized. Whether you have taken up cesarean section, all emergencies or elective only?
Sir, elective.
Only elective.
Yes, sir.
But then elective means, as per the standard protocol, you're supposed to give the basic pre-medications. You know that in a pregnant patient.
Yes, sir. Yes, sir.
Huh?
Yes, sir.
That you are not mentioned. And another important thing is, when you're given a block, subarachnoid block, for one group, the duration of action assessed, how long?
Sir, first group in which we are only giving levobuprofen diluted up to 30 ml. The duration after the spinal, completion before the suturing of the surgeon, we giving the local wound infiltration and then we count the effect. In first group, we are around 150 minutes, 2.5 hours. And in group B, in which we are using levobuprofen with ketamine, 1 mg per kg accordingly. So in this group, sir, this is around.
But sometimes what happens, how do you differentiate? For example, whether you are given for all the subarachnoid block patient, how do you say that whether the block was extended for the period or with the combination of this?
Sir, we are only giving 2 ml hyperbaric bupropion in spinal subarachnoid block, and then I will check the visual score according to this for study, and I am checked that from pinpricks.
So if you are given a choice, which one you prefer ideally?
Ideally, sir, after we can give ketamine with levobuprofen infiltration.
You practice this or you have any alternative best techniques?
Sir, alternative best technique may be given post-operative painkillers, diclofenac, tramadol.
Other than that?
Sir,
you think
other than
tramadol is ideal?
Generally, sir, tramadol is ideal.
Is it ideal?
Tramadol we can give, or we can give fentanyl opioids.
Want to think of spinal and then epidural combinations?
So the spinal epidural is good, but
because the infiltration see, after infiltration you will be extending only the time.
Yes, sir.
Again the patient required pain, because pain you should know that it will persist at least for 24 to 48 hours. So you cannot ask the surgeon to infiltrate once again.
Yes, sir. We can not. Then we are giving IV tramadol, and this is for early pain relief. After effect is
if you are given an option, which one you like?
Sir, epidural is best, na?
Okay, thank you.
Okay, thank you, sir.
Okay, we'll go for our next session.
Good evening, everyone. Myself, Dr. Pavitra from Tirunelveli Medical College. My topic is role of perfusion index as a predictor of hypotension during spinal anesthesia for cesarean section. So, spinal anesthesia leads to hypotension during cesarean delivery due to decreased vascular resistance and the pooling of blood. It is an observational study done to evaluate that perfusion index can be used for predicting hypotension during spinal anesthesia. The study was conducted in Obstetrics and Gynecology Theatre, Department of Anesthesiology, between October 2020 to June 2021. The study was done in 120 patients who underwent the elective lower segment cesarean section. Ethical committee approval and informed written consent from patients are obtained. Inclusion criteria is parturients between 20 years and 35 years of age posted for elective cesarean section. The patients with placenta previa, cardiovascular and cerebrovascular disease, preeclampsia, BMI more than 40, gestational diabetes mellitus, gestational age less than 36 weeks or more than 41 weeks, contraindication to regional anesthesia, and those requiring emergency LSCs are excluded. So it is a prospective double-blinded observational study. Based on the baseline perfusion index, parturients are divided as two groups. Parturients with a perfusion index of less than 3.5 under group A. Parturients with perfusion index more than 3.5 under group B. Pre-operative assessment will be done. Standard monitoring as per ASIC guidelines was performed for baseline values and intraoperative monitoring. Perfusion index was measured in supine position using a specific pulse oximeter in left index finger. IVSS established and preloaded with 500 ml ringer lactate over 20 minutes and the baseline values recorded. Spinal anesthesia performed by anesthesiologist who was blinded to baseline PA values by using 25 gauge pinky needle at L2, L3 or L3, L4 phase. The parturian was returned to supine position with a left lateral tilt of 15 degrees. After 20 minutes, maximum cephalic spread was checked. All values recorded at 2 minutes interval up to 20 minutes and then every 5 minutes till the end of surgery. If mean arterial pressure was less than 65 millimeters of mercury, considered as hypotension and treated with injection ephedrine. The first 60 minutes followed by subarachnoid block was considered for spinal-induced hypotension. Parturients requiring extra oxytocin or any additional surgical interventions are excluded from the study. So this is a fluid requirement in both groups, and there was a significant difference in the fluid requirement of both groups. The fluid requirement in group A is 1000 ml, while the fluid requirement in group B is 1150 ml. This difference was statistically significant. Hypertension in each group. So the incidence of hypertension in group A is 18.4% and group B is 65%. This difference was statistically significant with a p-value less than 0.001. And this is a correlation between perfusion index and ephedrine dose. When perfusion index increases, the dose of ephedrine also increases. So discussion, hypotension is very common after giving spinal anesthesia for cesarean section, and there is no definitive monitoring system which may help to predict development of hypertension following subarachnoid block. In our study, the incidence severity of hypotension, vasopressor requirement were found to be higher in parturients with a baseline perfusion index more than 3.5. So conclusion is, we conclude from this study that the perfusion index can be used for predicting hypotension in parturients undergoing elective lower thickness cesarean section under spinal anesthesia. Our results found out that parturients with a baseline perfusion index more than 3.5 are at risk of developing hypotension following subarachnoid block when compared to those with Good evening, everyone. Myself, Dr. Pavitra from Tirunelveli Medical College.
Hello. Hello.
Sir, I think Dr. Devika is not logged in.
Hello.
Hello, sir. Dr. Devika is not logged in, so we can move on to the next presentation, sir.
Hello.
It was during the morning. So then I will cancel your call.
Hello.
We did not have that.
Hello, Dr. Devanand, sir.
Maybe that is why that is not being called. Okay.
Sir, Dr. Devika is not logged in, so we can move on to the next presentation.
Okay, maybe that maybe next maybe 6 or 2.
Hello, do you hear me, Dr. Devanand, sir?
Yeah, I'm just audible.
So we can move on to the next presentation, sir.
Okay.
Because Dr. Devika is not logged in.
That's what. Okay, we'll go to the next.
Yes, sir. She's come. She's come. You can ask any.
Sir, actually, I'm Pavitra SK, sir. This is my presentation. This was not mine, sir.
Hello? Procedure and observation. My paper is on the topic a comparison of ultrasound guided ankle block versus popliteal fossa block as primary anesthesia for 4-foot operative procedure, an observational study. The authors include myself and Dr. Shaila S. Kamath. Introduction. Regional anesthesia can be the sole anesthesia method and also for additional postoperative analgesia following 4-foot surgeries. Regional anesthesia reduces the postoperative pain and thereby decreases the use of opioids, antiemetics, and also reduces the hospital stay of the patient. Ultrasound technique, when compared with the landmark technique for ankle block, increases efficacy and decreases the need for rescue analgesia and postoperative opioid doses. In this study, we compared the ultrasound-guided popliteal fossa block to ankle block as a sole anesthesia in 4-foot surgeries. The aim was to compare the efficacy of the two blocks. The objective included to compare the intraoperative hemodynamics between the two groups and to compare the duration of pain relief postoperatively between the two groups. The study setting was done in KMC Hospitals, Mangalore. The design used was comparative observational study, and the participant included adult patients who will be scheduled to undergo elective 4-foot surgeries. Inclusion criteria includes age between 18 and 80 years, ASA physical status 1 and 2, posted for elective 4-foot surgery. Exclusion criteria includes patient's refusal, history of allergy to local anesthetics, coagulopathy or bleeding diathesis, history of peripheral neuropathy, and local skin infection. Duration was from October 2019 till June 2021. Convenient sampling technique was used. Total sample size was 112. Primary outcome variables includes VAS score and rescue analgesia. Secondary outcome variables includes hemodynamics. Depending upon the group in which the patient have been allocated to, block was given half an hour before the procedure under ultrasound guidance. The patient was assigned into two groups, includes a group popliteal fossa block and group ankle block. Each of the patient were given 20 ml of 0.5% bupivacaine and 10 ml of 2% lignocaine, total of 30 ml. So once the VAS score was 0, the patient was permitted to undergo elective 4-foot surgeries. Intraoperatively, patient hemodynamics were monitored and the number of patients requiring general anesthesia or sedation was also recorded. After the procedure, the VAS score was monitored immediately up to a period of 24 hours. If the VAS score was greater than or equal to 3, rescue analgesia, which is injection tramadol 1 mg per kg slow IV was given, and postoperative time of first analgesic request was also recorded. The results, the VAS score of ankle block was greater than that of the popliteal fossa block, which was statistically significant. And the first analgesic request time was popliteal fossa block group was greater than that of the ankle block group. So the period of analgesia given by the popliteal block was more than that by the ankle block. So our study demonstrates that the postoperative analgesia was better with the popliteal fossa block group when compared to the ankle block. And although studies were done on popliteal fossa block and ankle block for 4-foot surgeries, enough literature is not present using ultrasound assistance. In our study, none of the patients required general anesthesia or sedation and no complication related to the nerve block was seen. This indicates the accuracy of nerve block technique using ultrasound guidance, and thus the incidence of failed blocks can be minimized. David et al. Demonstrated the effectiveness of popliteal fossa block for 4-foot surgery and concluded the advantages offered by this regional technique over general anesthesia or local anesthesia with IV sedation. We would like to conclude that both ultrasound-guided ankle block and popliteal fossa block provide sufficient anesthesia for 4-foot surgeries. Our popliteal fossa block is preferred over ankle block for 4-foot surgery as it offers a longer duration of postoperative analgesia. The limitations include we did not follow up the patient post 24 hours to look for any neurological symptoms, and we did not include the total analgesic requirement of the patient in the initial 24 hours. So these are my references. Thank you.
Hello.
Yes, sir. Good afternoon, sir.
Very good afternoon. Because in your study, you said that you want to study the hemodynamic stability. You have mentioned.
Yes, sir. One of the secondary criteria was to see the hemodynamic stability also, sir.
So how hemodynamic stability will vary with the block?
Sir, it depends upon the VAS score was 0 and then the patient was included in the study, sir. Not much significance was present, sir, but the heart rate and BP was higher with the popliteal fossa block group when compared to the ankle block, sir.
Why?
It depends upon the kind of surgery also, sir, what they're undergoing.
That's what you are giving block
Depends
mainly
upon
to
the
the foot surgeries, no?
for foot surgeries.
Yeah. If that is the case, this popliteal block and then ankle block, how it will disturb the hemodynamic system?
It won't disturb much, sir, but as a criteria, we included that. That is not the primary criteria, so that is one of the secondary criteria.
No, why you wouldn't include it?
Yes.
Yourself, because most of the times you
Yes,
are not disturbing the sympathetic system at all, isn't it?
Yes, sir. Yes, sir. Yes, sir.
So that criteria cannot be any one to be considered, is it?
Okay, sir. Yes, sir. That will, yes, sir.
So pre-medication, what you have given and all these things you have not mentioned.
I have mentioned the pre-medication midazolam 0.02 milligram per kg was given, so half an hour before the block.
Okay. For both the patients.
For both the patients.
Okay. Okay, thank you.
Thank you, sir.
Okay, next session.
My topic is observational study to compare the effect of time interval between the spinal anesthesia placement to delivery in cesarean section on unlikely record pH and Apgar score. After spinal anesthesia placement, the fetus awaiting cesarean delivery is vulnerable to the influence of spinal-induced maternal hypertension and supine positioning without surgeon awareness of fetal status. The duration of fetal exposure to the intrauterine environment is influenced by summation of steps that include administration of adequate anesthesia, preoperative preparation, and assessing the uterus. Newborn can be assessed clinically using the Apgar score test to quickly and summarily assess the health of the newborn physical condition immediately after delivery and to determine any immediate need for extra medical or emergency care. After the Institutional Ethical Committee approval, cross-sectional observational study was performed. Participants were single in gestation. After the using non-assisted cesarean section between 37 week to 41 week was taken. Pre-delivery checkup, pre-anesthetic checkup was done. Informed written consent was taken. Patient NQ status check. Routine non-invasive monitoring test. Peripheral vascular access obtained. IV preloading was done. Under early septic precaution, a spinal anesthesia was given with 25 gauge spinal needle in L3, L4 intervertebral space. Intrathecal injection of 12.5 milligram hyperbaric bupivacaine was given. Anesthesia level up to T for dermatome will be confirmed. And blood pressure was checked immediately after delivery of the baby. Umbilical arterial cord pH is collected in pre-sterilized vial and sent for arterial blood gas analysis. Assessment of the Apgar score of baby at 1 minute and 5 minutes was done. Calculate time interval between the spinal anesthesia placement, the skin anesthesia, uterine anesthesia, and delivery. Umbilical arterial pH interval of less than 7, 7.01 to 7.10, 7.11 to 7.20, 7.21 to 7.30, and greater than 7.30, and subsequently group A, B, C, D, E are formed. Data collected were the demographics, maternal blood pressure, pre-delivery time interval, delivery outcomes. Primary outcomes were the umbilical arterial cord pH and Apgar score. Observation result: 183 participants, mean arterial pH 7.280, mean BMI 19.80 kg per meter square. These are the different tables and result and graphs that are showing the spinal injection to skin incision time interval and skin incision to uterine incision time interval, umbilical arterial cord pH and Apgar score. After observation result, we can say that decreasing arterial pH is associated with increased BMI, increased hypertensive episodes, increase in pre-delivery time interval, and Apgar score that are significant with p-value of less than 0.001. Our study demonstrated that spinal start to delivery time greater than 21 minutes was associated with umbilical arterial pH less than 7.1 and Apgar score less than 7, and interval greater than 23 minutes was associated with umbilical arterial pH less than 7 and Apgar score less than 6. The spinal anesthesia is frequently used for cesarean section for rapid onset, tense neural block, minimum transfer of the drug to the fetus, but the spinal anesthesia related maternal hypertension and maternal obesity is detrimental for both the mother and the fetus. Mean BMI among the 5 groups was found significant with p-value of less than 0.001. Mark Powell, Grison, and Edward found the similar results. Mean arterial pressure was found significant in group A and B, then group C, D, E. Similar results were found by Jessica Cantu and Varicella. Umbilical arterial cord pH, incidence of neonatal acidemia was higher among group A, B, than group C, D, E with significant p-value of less than 0.001. Rebecca R. Remza in 2019 evaluated neonatal umbilical arterial pH according to the pre-delivery time interval at cesarean and found similar results. Neonatal outcome was found statistically significant with p-value of less than 0.001. Similar results was found by Cantu J, White CR, and Gauci et al. We conclude that obese women are more likely to undergo cesarean section. Obesity and time from spinal to delivery was independent risk factor for low molecular arterial pH. Unanticipated neonatal acidemia frequency might be reduced by minimizing the pre-delivery time interval following spinal placement. These are the references. Thank you very much.
In your center, what will be the minimum time between incision and delivery time after spinal anesthesia?
Sir?
Incision and delivery time in your center, what will be the time taken for all the patients?
Okay, sir. When we gave spinal anesthesia, time noted was 0, and after then part preparation and was done, and BP was recorded every 3 minutes, sir. And when the first incision was given on the skin, the time was noted. And again, sir, when the surgeon reaches up to the uterus and the uterine incision was marked, then the time again noted, sir. And after the delivery of the baby, at which time after uterine incision, at which time baby was delivered,
as you rightly said, anything
yes, sir,
which exceeds more than 21 minutes, there will be
yes, sir,
variation in the pH, is it not? See,
yes, sir.
My
yes, sir,
question
yes, sir.
is, in your center,
Yes.
what is the
Yes,
time
sir.
taken between the spinal and then delivery of the child? And what is the time taken from incision to delivery?
Okay, sir. From spinal to delivery time is usually, sir, within 20 minutes. But what happens sometimes due to the surgeon, it may be prolonged up to 25 minutes or 30 minutes also, sir.
That's what, because most of the times what is happening, incision delivery time,
yes,
most
sir,
of the times it happens within
yes,
10
sir,
minutes, is it not? See, only
yes, sir,
thing
yes,
is,
sir.
see, going beyond 21 minutes doesn't arise most of the cases, unless until some problem.
Yes, sir.
Okay.
Yes, sir.
Okay.
Yes, sir. Yes. Please.
Thank you.
Thank you, sir.
Next. Okay, next session, please.
Good morning, everyone. My topic for paper presentation is comparison of McGrath-Mac video laryngoscope and Macintosh laryngoscope for orotracheal intubation. The endotracheal intubation is commonly practiced in patients undergoing major surgery to secure and maintain the airway for inhalational anesthetic agent delivery during maintenance of anesthesia. It is also important in COVID era, and it is a skilled procedure for anesthesiologists. Hence, this study was designed to compare the McGrath-Mac video laryngoscope and Macintosh laryngoscope for orotracheal intubation. The primary aim of the study was to evaluate and compare the orotracheal intubation by McGrath-Mac video laryngoscope and conventional Macintosh laryngoscope. Primary objective was tracheal time to intubation, number of intubation attempt, Cormack-Lehane grading at laryngoscopy. Secondary objective were requirement of ELM, hemodynamic alteration, injuries due to laryngoscopy, Pogo score, adjunctal to laryngoscopy, and estimation of volume saturation. Prospective observational study was a prospective observational study, location IGGMC Nagpur, patients posted for elective surgery under general anesthesia after IEC approval. Sample size estimation using following formula. It is calculated as 40 in each group, total sample size of 80. It is divided into two groups. Group M, intubation was performed using Macintosh laryngoscope, and group MCG, intubation was performed using McGrath-Mac video laryngoscope. Detailed pre-anesthetic evaluation done and following variables were noted. These are the parameters studied. Statistical analysis was done using EP Info software version 7.2. Test applied were student unpaired and paired test. Results and discussion. Demographic characteristic according to the age, weight, and height was not significant in both the groups. Preoperative airway assessment parameters, interincisor distance, MPG, hyomental distance, paromental distance, and sternomental distance was not significant in both the groups. Distribution according to the Pogo score, it is highly significant that McGrath-Mac video laryngoscope provide better Pogo score with the mean of 90.87 plus minus 9.46. Then distribution according to the Cormack-Lehane grade, it was not that significant. Time to intubation was divided into 3 steps. That is mouth opening to the glottic view. It was and mouth opening to the placement of tracheal tube and mouth opening to confirmation of ATCO2 waveform. All 3 were highly significant, with McGrath provide early intubation time, that is 38.92 plus minus 11.07. Distribution of study population according to the total time intubation was highly significant, with earlier in McGrath group. Distribution of population according to the number of attempts, it was highly significant. According to the adjuvant airway device requirement, it was also significant. Then according to the ease of intubation, McGrath provides excellent view intubation. And then according to the number of optimization maneuver, McGrath required the least optimization requirement with p-value of less than 0.02. Incidence of complication, McGrath has no complication rate, and Macintosh have 10% of 10% complication rate, which was not that significant. Conclusion: based on the result, we conclude that use of McGrath video laryngoscope is found to be superior than Macintosh direct laryngoscope, as it provides better, earlier airway securance with superior glottic view, less time to intubation, less intubation attempts, and overall study objectives. Thank you.
Hello. Hello.
Hello. Good afternoon, sir.
Okay, nice. You are compared with the 2 laryngoscopes. But important thing is, while taking up, you have standardized the airway assessment for all the groups, is it not? Both the groups similar you are taken, is it not?
Yes, sir.
Because that is the important criteria, is it not?
Yes, sir. Yes, sir.
Another important thing is, what is important in laryngoscopy?
Sir, in terms of preoperative airway assessment.
No, aim. See, while performing a laryngoscopy, you should have
Yes,
aim.
sir.
No, what is your aim?
Aim of my study is the comparison of both laryngoscope, Macintosh and McGrath, and primary objectives were time to intubate, then number of attempts, and Cormack-Lehane grade were the primary objective, and secondary objective were hemodynamic alteration, then complications.
But hemodynamic parameters you are not mentioning.
Yes, sir. Actually, because of time limit, I have skipped it. But in my study, it is there is a hemodynamic alteration in Macintosh group with in first 5 minutes after the intubation, which is significant.
Because that is very important. In Macintosh,
Yes,
most
sir.
of the times there will be there will be changes in the rate as well as in the pressure, is it not?
Yes, sir. Because in Macintosh, it requires the alignment of the axis, 3 axes, and in video laryngoscope, we don't need to align that axis, because in front of camera, we can see it on the screen only.
Okay, thank you. Next session.
I, Dr. Pinal Masai, third year resident in Chirmayas Medical College and Hospital, Solar Civil, Ahmedabad. I present a paper on the comparative study between the small light of decision for reduced hypertension and functional endoscopic sinus surgery. Phase is the most exciting recent surgical development for treatment of the patient with nasal pathology. Usually too, because it is for potential for the establishment of the nasal mucosal release mechanism, drainage of the sinuses while maintaining the normal anatomy as much as possible. This is become more popular because of minimal invasive nature and preservation of mucosa. Bleeding is one of the major problems during the surgery. This reduces the effectiveness of the surgery, increase the chance of the complication. If enough injection in the nasal mucosa, patient head elevation and control hypertension can be used to minimize the bleeding. bleeding, improve the surgical field, and prevent the complication. This can be done by using the hypertensive drugs such as beta blocker, caseinone blocker, vasodilator, and anesthetic propofol opioids in the inhalation agents. This study was designed to provide the control hypertension using nitroglycerin esmolol in the patient undergoing the phase under the general anesthesia. Aims to compare the esmolol and nitroglycerin in the term of effectiveness in the control hypertension during the phase surgery. The objective is to compare the both in terms of the change in heart rate, systolic blood pressure, diastolic blood pressure, mean arterial blood pressure, risk of surgery, and operative visibility assessment by the surgeon using the level basic category visible scale. This is inclusive criteria, this is the exclusion criteria. And such a technique, patient was either sex divided into the group, randomly divided between the two group antigen, group B was received the esmolol. A little pre-evaluation was done, carried out in patient. Appropriate laboratory investigation carried out accordingly, and the patient was visited the bypass surgery to explain the detailed procedure, consent of written and informed consent taken. Patient kept NBM 6 to 8 hours before the surgery, and the Tentec and alprazolam given before the before the day of the surgery. On the day of surgery, 2 ibuprofen taken, 1 for the drugs and 1 for the exclusive for the inhalation agent. Hypertensive drugs infusion. Monitor attached patient premedicated with the understanding glycopyrrolate, midazolam, fentanyl. Patient peroxide with the 3 minutes before the surgery, and injection was done with propofol and the succinylcholine. Patient intubated with appropriate size cuff, fixation after hospitalization, it was fixed, and the dose of etaquitum given. Patient anesthesia was maintained with the sevoflurane, N2O2, and etaquitum infusion. Group 1 was received the nitroglycerin 5 to 10 mg per kg per minute IV, and group A was received the esmolol 100 to 300 mg per kg per minute for the infusion pump. Surgery was begun after target base was around 60 millimeter mercury. The rate of infusion was determined by the heart rate, blood pressure, oxygen SpO2, and ATCO2. The infusion was stopped, and residual paralysis was reversed with the neostigmine, 0.0 neostigmine and glycopyrrolate. The patient was extubated on the operation theater. Surgeon's opinion was out throughout and the end of the surgery. Following parameter to be observed during the study. Observation results. There is a group-wide distribution of the patients. There is a demographic comparison between the two. There is no significant data comparison difference found between the blue group. There is a comparison of heart rate between the two group found that there is a more decrease in heart rate with the ACM group compared to the NTC group because of in the tachycardia was found. There is no refractory ACM group. There is a comparison of systolic blood pressure, diastolic blood pressure, mean arterial pressure found that more reduced with the NTC compared to the nitro. So compared to the smaller group. And there is a comparison of bleeding score between the two groups found that there is a both hypertensive plus provide good result, but the ASM group give better result the NTC group with identified to no tachycardia. We conclude that the ESMO is a reference of my study. Thank you.
Hello. Hello.
Hello.
Hello.
Hello. Hello.
Hello.
Hello.
Is it audible?
Yes, sir.
Hello.
Hello.
Hello, Payal.
Hello. Not able to start my video, sir.
Hello.
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 Hello. Hello. Is it audible?
Yes, sir. Hello.
Okay. We see in our center FES is done under GA all the cases?
Yes, sir.
All GA?
Yes, sir.
They don't do it under local?
No, sir.
Okay. What actually the ENT surgeon does by
Sir,
taking up?
ENT surgeon mostly asks for the lower side of blood pressure to reduce the blood loss during the dry surgical phase.
No, what happened locally, even though you are giving a general anesthesia, most of the times ENT surgeons, they try to infiltrate and then they later they take. but they have not mentioned, because what infiltration you have standardized, whether they use what drug they are given, whether they are given along with the vasoconstrictors for both, that you have not mentioned.
Yes, sir.
In your study.
Yes, sir. Yes.
How much is it not?
Yes, yes.
Those things which matter to when you want to compare with esmolol and nitroglycerin, mainly to look at the hemodynamic stability. You have to look at other parameters also, is it not?
Yes, sir.
Is it not? Adequacy of analgesia. All these things you would have mentioned what volume they are taken, whether they are taken along with the vasoconstrictor. Most of the times they usually use vasoconstrictor. Yeah. So that will usually disturb the hemodynamic system, is it not?
Yes.
How do you compare?
Sir,
for example, if they use adrenaline, they should have standardized.
Yes, sir.
For all the patients, same volume, same concentration of adrenaline. All these things would have been done. That you are supposed to mention, is it not?
Okay, sir.
Okay. Okay. Thank you. Next. Next session, please.
Rajasthan. Here I am. Good morning, everyone. I am Dr. Poonam Gupta from SMS Medical College, Jaipur, Rajasthan. Here I am presenting my presentation on topic comparison of anesthetic effect of dexmedetomidine as an adjuvant to 0.5% ropivacaine in supraclavicular brachial plexus block for upper limb surgeries. In regional anesthesia, USG guided supraclavicular brachial plexus block is a safe and popular technique nowadays for upper limb surgeries because use of USG reduces various complications like intravascular injection, pneumothorax, and hematoma, etc. Here we are using dexmedetomidine as an adjuvant to ropivacaine. Aim of our study is to compare the anesthetic effect of dexmedetomidine as an adjuvant 0.5% ropivacaine in supraclavicular brachial plexus block for upper limb surgery. So primary objective is to determine the difference in mean onset time and duration of sensory and motor block in both groups. Secondary is to determine the difference in mean duration of analgesia in both groups and to determine the difference in percentage of cases who developed side effects in both groups. This study is being conducted in SMS Medical College in Department of Anesthesia. In this study, 60 patients are selected randomly by using sealed envelope method divided in two groups, each having 30 patients. It is a randomized double-blind controlled interventional study in which neither patients nor anesthetist who would give anesthesia and record data is aware about the drugs to be given. In this study, we are considering the patient between 18 to 60 years age group. After taking their written and informed consent, patient can be either sex, body weight should be 40 to 70 kg, belonging to ASA class 1 and seconds are also included. Patients who are uncooperative and having major health issues like bleeding disorders and contralateral diaphragmatic paralysis, etc., are excluded from this study. This is a study flow where patient is satisfying inclusion criteria are selected. After confirming their identity and doing PSC, patients are taken in the OT and routine monitoring is done. IV lines are secured, RL started. After giving appropriate position under all aseptic precautions, group A patient received 20 ml of 0.5% ropivacaine plus 5 ml normal saline. And B received 20 ml of 0.5% ropivacaine plus 0.5 ml 50 microgram dexmedetomidine plus 4.5 ml normal saline as USG guided supraclavicular brachial plexus block. After that, onset time of sensory and motor block are to be noted by cold test and modified bromase grade respectively. Hemodynamic parameters are also monitored intraoperatively. Post-operatively, we are noting duration of sensory and motor block and duration of analgesia inside and side effects, if any. Statistical analysis is a continuous data would be summarized in the form of mean and standard deviation. Difference in mean of two groups would be analyzed using students' t-test. Count data would be expressed in the form of proportion. Difference in proportion would be analyzed using chi-square test. The level of significance would be kept 95% for all statistical analysis. According to the results, we have found that there is no significant difference between two groups for demographic variables, but group B has a shorter onset time and a longer duration of sensory and motor block and duration of analgesia as compared to group A. There are not any major side effects are recorded. These are the graphical results of onset of sensory and motor block, duration of sensory and motor block, and duration of analgesia. Most of our results are almost comparable with previous studies. So addition of dexmedetomidine 2.5% ropivacaine in supraclavicular brachial plexus block has in the onset time and prolongs the duration of sensory and motor block and also prolonged the duration of post-op analgesia. Thank you. Good morning, everyone. I am Dr.
Tell me. Okay, continue. Continue.
कैसे फिर Good morning, sir.
Continue. Hello.
Good morning, sir.
Very good morning. Yeah. In all the two groups, we have used ultrasound guided.
Yes, sir.
Huh?
Yes, sir.
Okay. Is there any alternative best drug you can use to prolong the supraclavicular block?
There is bupivacaine and levobupivacaine, alternative to ropivacaine.
No, instead of dexmed, do you have any other
Dexmed,
drug?
sir, there is a clonidine and dexamethasone and magnesium sulfate and opioids, etc. Sir.
Which one you prefer?
Sir, dexmed.
What are the problems with the dexmed?
Yes, sir.
What are the complications you anticipated with the combination?
Sir, dexmed is a sympatholytic drug. So, sir, alpha it acts on alpha-2 receptor, alpha-2 adrenergic receptor on sympathetic preganglionic neurons. So, it decreases the release of norepinephrine. So, sir, it causes
what side effects you come across?
Sir, it causes hypotension and maybe hypotension, sedation, and bradycardia.
Then you want to say that it's safe?
Sir, I am using less, sir, 50 microgram, less concentration. So, it is maybe safe.
Not anticipated any complication?
No, sir, there is not much complication, sir.
Suppose inadvertently, for example, you know that you are using a ultrasonic guided block. By chance, in spite of that, suppose if this combination enters into the vascular system, what are the complications?
Hello, sir.
If this same combination accidentally, if enters into the vascular system, what are the complications?
Vascular system, sir, decreases, it causes hypotension or bradycardia, sir, if intravascular injection is given, or systemic local anesthetic toxicity. There is local anesthetic toxicity, sir.
Okay. Okay, thank you.
Thank you.
Next.
Hello, myself Dr. Purnima. My topic is prediction of postspinal hypertension on the basis of baseline heart rate. Introduction. Spinal anesthesia is the most preferred method of anesthesia for the cesarean section, and it has its own adverse effects like hypertension. Hypertension due to any cause may have serious effects on mother and unit. Preoperative determination of autonomic tone is useful. One of the convenient methods is analysis of the heart rate. Primary objective to predict postspinal hypertension on the basis of baseline heart rate and other independent factors during elective lower segment cesarean section under spinal anesthesia. Secondary objectives to find out the mean dose of injection methamphetamine required to correct hypertension, to assess and describe the change in the hemodynamic parameters. Method study conducted in SMS Medical College, Jaipur with sample size of 100 cases posted for elective cesarean section. Inclusion criteria: elective lower segment cesarean section under spinal anesthesia, patients belonging to ASA status 1 and 2, aged 20 to 35 years. Exclusion criteria: patient refusing regional anesthesia, allergy to the study drug, emergency surgery, patients with significant cardiovascular, renal, hepatic and thyroid diseases. Contraindication to spinal anesthesia. Methodology: patients satisfying inclusion criteria were underwent lower segment cesarean section under spinal anesthesia. Hemodynamic parameters were recorded as per the performer. Results: a logistic regression analysis was done to predict postspinal hypertension on the basis of baseline heart rate and other independent factors during lower segment cesarean section under spinal anesthesia in 100 subjects using age, gravidas status, weight, baseline heart rate, baseline systolic blood pressure, diastolic blood pressure, and mean arterial pressure. Prediction success overall was 70%. The Wald criterion demonstrated that only baseline heart rate made a significant contribution to the prediction. Baseline heart rate is raised by 1 unit. The odds ratio is 1.064 times as large, and therefore chances of postspinal hypertension are 1.064 times more likely. Out of 100 patients, 57 patients required methamphetamine to treat hypertension. Mean amount of methamphetamine required to treat hypertension was 9.47, plus or minus 4.8 mg. Out of the variables in the table, heart rate is the predictor of postspinal hypertension by logistic regression analysis with p-value of 0.001, which is highly significant. Spinal anesthesia is the preferred method in pregnant females for cesarean section. Hypertension is common complication, so prediction of postspinal hypertension is important. In our study, we used baseline heart rate, age, gravida, weight, baseline systolic blood pressure, baseline diastolic blood pressure, mean arterial pressure as the predictors. Similar studies have been conducted, and our results are also similar with the results of study conducted by Doshi MC et al., in which they found significant association between preoperative heart rate and postspinal hypertension in parturients undergoing cesarean section. Conclusion: baseline heart rate can be used as a predictor for postspinal hypertension in obstetric patients undergoing elective cesarean section under spinal anesthesia. Thank you.
Hello.
Hello, good morning, sir.
Hello.
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 Purnima.
Good morning, sir. Good morning, sir.
Very good morning. Because as you taken baseline heart rate is one of the predictor.
Yes, sir.
In cesarean section after giving a subarachnoid block, isn't it? See, as you know
Yes,
that
sir.
you have taken a one parameter with the rate, isn't it? See, the
Yes,
rate
sir.
in a pregnancy patients varies with so many issues,
Yes,
isn't
sir.
it? So how
Yes,
do
sir.
you taken standardize this?
Sir, in inclusion criteria, actually in exclusion criteria, sir, heart rate may be is a risk factor. It is modifiable and non-modifiable, sir. Like in a non-modifiable risk factors are included. Basically, the patient will have the increased heart rate preoperatively, and in over anxious patients will have increased heart rate, and age more than 35 years, the patients are more prone to have heart rate more. And when the patient is obese, having BMI more than 25, they have more prone for increased heart rate. So we have excluded these patients. Hello.
Hello.
Yes, sir.
No, that's true. But only thing is, how do you standardize? Because which patient, when you are chosen only the patients with the heart rate of 100 you are taken, or?
Sir, hello.
The baseline heart rate selection criteria.
Sir, we have randomly we have taken 100 patients, sir.
Okay.
So 100 patients, it is for posted for elective lower segment cesarean section, sir.
So
we have taken 100 random patients, and we have noted the preoperative heart rate, and we have seen how many patients will develop hypotension. And we have correlated with the heart rate, sir. According to a study, patients who are having tachycardia, like more than 100 or more than 90 beats per minute, they are more prone for the hypotension compared to the patients who are having less than 100 or less than 90 beats per, they are less prone. And the requirement of vasopressor is more in case the patient is having tachycardia preoperatively.
But what pre-medications you are given to all the patients?
So we have avoided pre-medication, sir, because anticholinergics may increase the heart rate. So we have avoided, sir. I have mentioned it in the methodology.
Okay. Thank you.
Thank you, sir.
Next session.
Good morning, myself Dr. Pratna. My title is Comparative Study of Effectiveness of Humoral Nerve Block versus Intravenous Nalbuphine in Positioning of Patients of Intertrochanteric Fractures for Spinal Anesthesia. Femoral fractures being more frequent in elderly subjects need surgical fixation at the earliest in order to avoid life-threatening complications. Its incidence is around 1 case for 10,000 population per year. Correct positioning during spinal anesthesia is a prerequisite. Extreme pain and limb immobility are deterrents to an ideal position for performing the spinal anesthesia. Various modalities like the use of intravenous opioids, peripheral nerve blocks have been advocated preoperatively to reduce the pain during positioning for anesthesia. There are very few literatures available regarding superiority of one technique over the other, so we conducted this study to compare the effectiveness of humoral nerve block versus intravenous nalbuphine in positioning of patients of intertrochanteric fractures for spinal anesthesia. This is also a main aim of the study. Our primary objective is to see for the ease of positioning by assessing of pain carried out by visual analog scale score, and also the quality of patient position as assessed by anesthetic satisfaction score. Secondary objectives were to see for the time taken to perform spinal anesthesia and patient satisfaction by positioning. This had been a randomized study. Sample size was 70. Patients, after fulfilling the inclusion criteria, were divided into two groups. Group A patients received intravenous nalbuphine in a dose of 0.5 mg per kg, and Group B patients received ultrasound-guided femoral nerve block with 20 ml of 0.2% ropivacaine. Either of the procedures were performed 15 minutes prior to positioning. Thereafter, spinal anesthesia was given at L23 or 34, depending upon the anesthetist decision, and vital parameters were monitored throughout the procedure. Statistical analysis was done using IBM SPSS software version 23. P-value less than 0.05 was considered as statistically significant. Our results showed a significant difference with VAS score between both the groups of patients, was significantly lesser in FNB group of patients during positioning. Remaining parameters did not show any statistically significant difference. So, as there was no statistically significant difference with respect to age, we concluded that elderly age group of patients have an increased vulnerability to history of fall resulting in intertrochanteric fractures. Femoral nerve block provided better analgesia for patient positioning. So, utility of this block administered 15 minutes prior to positioning is well proved in terms of its analgesic efficacy. Quality of patient position. was not statistically significant, which implies that both the techniques provide similar quality of patient positioning. Also, these results do not correlate with the studies conducted by Jardin et al. The optimal position achieved in our study in both the groups is due to quicker onset of action of the drugs, which provided adequate analgesia after a similar time interval. The difference in patient satisfaction was also statistically insignificant. These results are dissimilar to the studies conducted by Purohit et al., where better patient satisfaction score was achieved in femoral nerve block. Also, the time taken for positioning and time taken to perform subarachnoid block was not statistically significant. This indicates that both the techniques reduce the time taken for administering subarachnoid block equally. With respect to hemodynamic parameters, we did not find any statistically significant difference. However, mean arterial pressure was found to be significantly lower after 15 minutes of study intervention in both the groups. This similarity can be explained by the fact that adequate pain relief measures provided well-controlled hemodynamics. We did not follow up the patients for post-operative pain relief, so the total consumption of analgesics for pain relief could not be assessed. Time interval between the occurrence of trauma and execution of surgery was not uniform among all the patients. Double blinding could not be done, which could have led to an observer bias. So, the study comparing both the techniques may help in formulating an approach to make patient positioning comfortable and pain-free during administration of central neuraxial block. Hence, we recommend that either of the techniques can be adopted for providing better care of such patients in a tertiary healthcare center, although femoral block may have an edge over IV analgesia. These were my references. Thank you.
Hello.
Good afternoon, sir.
Sure. See, what made you to compare?
Hello, sir.
Why? What made you to compare with this?
Sir, we had compared femoral nerve block versus intravenous opioid, sir.
That's what. Why? Why you compare? You know that intravenous opioid may not help much, isn't it?
Yes, sir. But actually, sir, there had been studies showing like a similar efficacy between femoral nerve block and using of intravenous fentanyl also. So we decided to take another opioid like nalbuphine, which is readily available in our institution, and to compare it to the regional anesthetic techniques.
So you feel that giving a femoral nerve block and going for subarachnoid block is better?
Yes, sir. In terms of VAS score, sir, we got a significant difference, sir. But in terms of other parameters like time taken to perform the block and patient satisfaction and anesthetic satisfaction, both the techniques had proven to be equal, sir.
Oh, early you are giving femoral block before
Sir, 15 minutes before positioning for spinal, sir.
15 minutes in femoral block. Within 15 minutes, block will act.
Yes, sir. We are using ropivacaine. Its onset of action is.
How do you ensure that the block is acted?
Sir, actually, ensuring as such is not done, sir. We had given a time interval of 15 minutes for both the procedures, sir.
But once if it is not acted, such criteria are not taken, such patients.
No, sir, no. We didn't give any additional analysis.
How you blocked the femoral nerve?
So we're using ultrasound guided, sir. We had identified the femoral artery and the lateral to the femoral artery. According to the anatomy, it is with the triangular glistening structure of the femoral nerve. And we had given the block lateral to the femoral nerve.
Okay, thank you.
Thank you, sir.
Next session. Next session.
Hello, Dr. Devanand, sir. Hello, Dr. Devanand, sir.
Yes.
Dr. Devanand, sir.
Yeah.
सर इस सेशन के सारे प्रेजेंटेशन हो चुके हैं, आप अपना वीडियो ऑन करके वाइंड अप कर सकते हैं सेशन को।
हेलो
सर इस सेशन के सारे प्रेजेंटेशन प्ले हो चुके हैं।
ओके
सर आप वीडियो ऑन करके अपना वाइंड अप कर सकते हैं लास्ट वर्ड के।
Okay, let us close there.
यस सर आप कह सकते हैं लास्ट वर्ड।
Okay, thank you.
Recording in progress.
Hello, everyone. I am Dr. Rashesh Diwan, the organizing chairperson for Isacon 2021. I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiologists and the organizing team of Isacon 2021. We all know we have passed through a very difficult phase in the life, and now gradually we are trying to overcome the situation. Many of us suffered the pandemic, and of course, many of us also worked for the pandemic for the community, and we were praised all over the country and all over the world. It was a great learning time for all of us. However, we missed the last year completely for the academics. But now we are beginning, and we are beginning with a very mega academic fiesta under the banner of Indian Society of Anesthesiologists. This is the biggest ever hybrid conference and happening for the next 5 days. I am sure you will enjoy the most. We have made a humble attempt to accommodate as many presentations as possible. And in view of the overwhelming response for the presentations, we extended the conference on the pre-CME day. This is the today. We are starting today at 8 o'clock, and we have plenty of e-papers accommodated for one day. Once again, I thank you all for the participation in Isacon 2021 and wish you good luck. Stay safe. Long live ISA.
Good morning, sir.
Hello, sir. Dr. Sudhi. Do you hear me, sir? So we can go to the first presentation. Sir, unmute yourself.
Good morning, respected teachers. My topic for e-paper is comparison of post-operative analgesic effect of nalbuphine versus fentanyl as an adjuvant to intrathecal 0.5% hyperbaric bupivacaine in total abdominal hysterectomy, a randomized double-blind interventional study conducted at SMS Medical College, Jaipur, with the objectives to determine the difference in duration for need of first rescue analgesia and number of doses of rescue analgesia required in 24 hours and percentage of cases who developed side effects up to 24 hours post-operatively. In our study, total 72 participants were divided into two equal groups using opaque sealed envelope method. Group A received 3 ml bupivacaine 0.5% plus 0.8 ml nalbuphine plus 0.2 ml NS, and Group B received 3 ml bupivacaine 0.5% plus 0.5 ml fentanyl plus 0.5 ml NS intrathecally. With inclusion criteria, including patients aged 30 to 65 years, ASA grade 1 and 2, undergoing total abdominal hysterectomy, weighing 40 to 80 kg, and height of more than 145 centimeter, and exclusion criteria including patient's refusal, history of chronic diseases like hypertension, diabetes, respiratory disease, renal disease, epilepsy and cardiac disease, and coagulation disorders, chronic history of headache and backache, and spinal deformity or infection at the local site, and known history of allergic reactions to bupivacaine, nalbuphine, and fentanyl. In our study, we observed that in Group A, the mean duration of rescue analgesia was significantly higher, and the doses of rescue analgesia and number of cases who developed side effects were significantly lower than Group B, as shown in tables. Post-operatively, VAS score was seen at 1 hour, 2 hour, 6 hours, 12 hours, 18 and 24 hours. The mean VAS score was significantly lower in nalbuphine as compared to fentanyl, and the modified Ramsay sedation score was recorded at 30 minutes interval from the subarachnoid injection till 24 hours. It was significantly higher in fentanyl group as compared to nalbuphine. So we conclude that that both nalbuphine and fentanyl increase the duration of sensory block as well as post-op analgesia. However, intrathecal nalbuphine prolongs post-operative analgesia maximally and may be used as an alternative to intrathecal fentanyl in total abdominal hysterectomy. Thank you.
Hello. Hello, sir. You can ask the question if you want.
Am I audible?
Yes, sir. Good afternoon, sir.
Yeah. My one question is that what are the incidences of pruritus in both the groups?
Sir, incidence of pruritus were very few. My sample size of total 72 patients, 36 in each, and I did not notice pruritus in any of the patient.
Okay. Any other side effects in both the groups?
Sir, fentanyl causes more sedation as compared to nalbuphine, and a little bit of respiratory depression also. So the patients, 1/3 of the patients with fentanyl received oxygen therapy mandatorily, and nalbuphine there were no such adverse effect.
Okay. So how it termed that the respiratory depression is there? What are the parameters you counted for the respiratory depression is there?
Sir, for respiratory depression, actually the breathing pattern of the patient was shallow, and pulse oximetry showed saturation going down from 98% to 96.7 up to 94% actually.
Okay. And how long you
Basically, it was,
supplemented oxygen?
Yes, sir.
For how long you supplemented the oxygen?
Sir, for about 30 minutes, 30 to 45 minutes, then it was okay.
Okay. Thank you.
Thank you, sir.
Good morning, everybody. My name is Dr. Pranita Kale. My topic for today's paper presentation is to study the efficacy of 2-chlorprocaine by addition of fentanyl for intrathecal use in surgeries below umbilicus. Introduction. Spinal anesthesia is safe and reliable technique for below umbilicus surgical procedure. Preservative-free 2-chlorprocaine is an effective alternative for the same. The use of single dose of 30 mg 2-chlorprocaine may provide good anesthesia with lesser side effects, but its duration may last only up to 40 minutes. We can overcome this by addition of an opioid like fentanyl to 2-chlorprocaine that will prolong its action. Need for study is by studying the effects of addition of fentanyl, we can get a new adjuvant drug for 2-chlorprocaine, which not only has a good and prolonged operative analgesic duration, but also reduces the need of prolonged post-operative admission of patients after surgical procedure due to its faster reversal of action. Aim comparison of conventional dose of 2-chlorprocaine with 2-chlorprocaine along with fentanyl and spinal anesthesia for patients undergoing below umbilical surgeries. Objective: to determine and compare the onset and level of anesthesia in both the groups, to determine and compare the duration of sensory and motor blockade in both the groups, to determine and compare the degree of sensory motor blockade in both the groups, to determine if there is any side effects of the addition of fentanyl. Materials and method inclusion criteria: patients between the age groups of 18 to 60 years, patients undergoing elective surgeries below umbilicus under spinal anesthesia, all patients of ASA grade 1 and 2, estimated surgical procedure time not exceeding more than 45 minutes, patient given consent and ready to undergo the study. Exclusion criteria includes patient with ASA grade 3 and 4, patients with known allergy to local anesthetic, obese patients, estimated surgical procedure time extending more than 45 minutes, patients age less than 18 years and more than 60 years, patient not giving consent to undergo the study. Study design: it was a prospective single-blinded randomized control study conducted from September of 2019 to October 2021 in Tertiary Care Center of D.Y. Patil Hospital, Kolhapur. Study population: patients undergoing elective surgeries below umbilicus under spinal anesthesia for short surgical procedure was a study population. Methodology: after approval of ethical committee, study has been started in September 2019. Data collection was done till August 2021. Written informed consent was taken from every study participant. Patients were evaluated and educated about the merits and demerits of the study. Patients were prospectively randomized to 2 groups with 30 patients in each group using method of computerized generated randomization schedule. Group A patients were administered with 30 mg of 2-chlorprocaine intrathecally. Group B patients were administered with 30 mg of 2-chlorprocaine with 25 mg of fentanyl intrathecally. Results: in a study, we have found that the onset of sensory block with 2-chlorprocaine and fentanyl faster with 2-chlorprocaine alone and statistically significant. The duration of analgesia was found to be more with addition of fentanyl with 2-chlorprocaine. The duration of motor block with 2-chlorprocaine and fentanyl was prolonged than 2-chlorprocaine alone, and it was statistically significant. The incidence of pruritus was more among the group with fentanyl. Discussion: with the discovery of specific opioid receptor by Perth and Schneider in 1973 and subsequent identification of these receptors in the substantia gelatinosa of spinal cord, a new enthusiasm was created for the clinical application of opioid to the subarachnoid space. The patients undergoing below umbilical surgical procedure, combination of intrathecal use of the isoparic 2-chlorprocaine 30 mg with 25 mg fentanyl was found to be reliable in maintaining the quality of block. In an evaluation of efficacy of intrathecal fentanyl with 2-chlorprocaine on the characteristic of subarachnoid block in patients has concluded that the addition of fentanyl significantly improved the onset and quality of the block while prolonging the duration of analgesia without any major side effects. Conclusion: in a study among the 2 groups, with one receiving 2-chlorprocaine 30 mg alone and other receiving 2-chlorprocaine 30 mg with fentanyl, we have found that the group receiving fentanyl showed faster onset of sensory and motor blockade with longer duration of action. Also, in group receiving 2-chlorprocaine plus fentanyl, there was prolongation of time required for rescue analgesia. Further, it was observed that the group receiving fentanyl with 2-chlorprocaine, time required to void was increased, and the incidence of pruritus was more among the group receiving fentanyl. There was no statistically significant difference between 2 groups with respect to hemodynamic parameters during intraoperative as well as postoperative period. Here are my references for the following. Thanking you.
Hello.
Hello. Hello. Hello. Am I audible?
Hello, doctor.
Hello.
Hello, Dr. Sudhir sir, do you hear me?
Yeah, I'm audible, but am I audible to you?
Yes, sir. Can we go to the next presentation, sir?
Yes, sure.
Okay, sir.
Good evening, everyone. My name is Dr. Pranjali Verma, and I'm presenting a paper of comparative evaluation of your dexmedetomidine or propofol along with scalp block on hemodynamic and postoperative recovery for chronic subdural hematoma evacuation under monitored anesthesia care. Introduction. Chronic subdural hematoma is a common neurological problem. Treatment includes evacuation of hematoma by burr hole drainage. It is commonly done local anesthesia or recently with monitor anesthesia care. Commonly used sedative agents are midazolam, propofol, opioid, and dexmedetomidine. Dexmedetomidine are highly selective alpha-2 adrenoreceptor agonists, possesses hypnotic, sedative, anxiolytic, symptomatic, and analgesic property without producing respiratory depression. Propofol has been utilized because of its quick out property and producing a clear head, faster recovery. Material methods: a total of 64 patients, 20 to 65 years of age, undergoing burr hole and evacuation or CSDH under MAC, were included in the body. Patients were divided into two groups of 32 each. Group D received dexmedetomidine 1 microgram per kg over 10 minutes as a loading dose, followed by 0.2 to 0.7 microgram per kg per hour. Group B received propofol 1 mg per kg over 10 minutes as a loading dose, followed by 1 to 3 mg per kg per hour. Before starting infusion of study drug, scalp block was given with 2% lignocaine with adrenaline. Monitoring was done. During the procedure, sedation was maintained with the study drug infusion to achieve a target BIS between 60 to 80. Requirement of more than 3 attempts of patients restrained BIS more than 80 or surgeon dissatisfaction was managed with addition of bolus of propofol and dexmedetomidine. It's a structure of BIS. This is the scalp block. The diagram showing how the nerves, supratrochlear nerves, supraorbital nerves, zygomatotemporal nerve, auriculotemporal nerve, lesser occipital nerve, and greater occipital nerve are blocked by scalp block. Statistical analysis shows patient characteristic data were analyzed with student TE test of continuous variable and chi-square test of the categorical variable. Satisfaction score was analyzed by the Mann-Whitney test.
Results were shown that there were no significant difference in demographic profile. A significant decrease in heart rate compared to pre-operative value was seen in group D compared to group T. Blood pressure values were satisfactorily significantly lower in both the study group compared to preoperative values during the whole procedure and after surgery, that is p-value is less than 0.05. Surgeon satisfaction was significantly more in group D compared to group B, but patient satisfaction was similar in both the group. This is the line diagram showing the changes in heart rate at various time interval in group 2 group, in which in group D the heart rate dip was more. This is the changes in line diagram showing changes in blood pressure at various time interval in 2 groups. Discussion: intraoperative patient movement, coughing, and airway related problem during MEC may interfere with surgery and is a manifestation of inadequate sedation. Drug that maintain more sustained desired level of sedation, hemodynamic stability, and less interference with respiration and prefer. In our study, BI has guided the infusion rate of dexmedetomidine and propofol to maintain desired level of sedation, decrease the dose of sedative, frequent dose adjustment, and drug-related side effect. Sympathetic stimulation and movement of an anxious patient cause hypertension, tachycardia, increased bleeding, and disturb the fine microscopic nature of the surgery. In the present study, both the study group drugs have better hemodynamic stability with minimum fluctuation during whole intraoperative period. The major problem with dexmedetomidine, it is a hemodynamic effect, as the drug often causes hypertension and bradycardia. In our study, there were no significant difference between the group in terms of the satisfaction of the patient because of the titration of sedation agent guided by the BIs. However, the surgeon satisfaction was higher in dexmedetomidine group than in propofol group because dexmedetomidine group patient had less coughing movement and bleeding during surgery. So the conclusion were dexmedetomidine along with scalp block provided better operative conditions, stable hemodynamic, and a greater surgeon's satisfaction compared to propofol. Use of dexmedetomidine based sedation protocol for procedure under MEC are suitable and should be incorporated as first line of anesthetic technique for such patients. These were the references. Thank you.
Sir, can we go to the next session, Dr. Sudhir? Hello, Dr. Sudhir. Sir, can we go to the next presentation? Hello. Can we go to the next presentation, sir? Dr. Sudhir.
Thank you. Yeah, please present next. क्या मैं नहीं समझा जो श्री राम ने मैंने बना के दिया था हाँ
Hello, Dr.
Hello.
Sudhir, sir.
Yeah, audible, please.
Sir, can we go to the next presentation?
Yeah, sure. We can go.
I'm Pratna Amraj. My e-paper is on comparison between etomidate and propofol for induction of general anesthesia in elderly. Introduction. Induction of anesthesia is a vital part of general anesthesia wherein there is a transition from an awake state to an unconscious state by administration of combination of drugs. Aging results in a gradual loss of functional reserve in all organ system. While compensatory mechanism for age-related changes are adequate, the physiological reserve is depleted during periods of stress such as perioperative period. Therefore, to find an appropriate induction agent, comparison of etomidate and propofol with respect to hemodynamic stability in the elderly was conducted. Primary objective was to compare systolic, diastolic, and mean arterial pressure and heart rate following induction of anesthesia in elderly with respect to propofol and etomidate up to 10 minutes post-intubation to find a better induction agent with respect to hemodynamic stability and to determine proportion of undesirable effects of propofol and etomidate perioperatively, such as pain on injection and myoclonus. Coming to methods. It was a cross-sectional observational study conducted in Justice K.S. Hegle Charitable Hospital. The sample size was calculated based on Pater return with the above mentioned formula. Each group requiring 39 people with power of 90%. A total of 80 participants were included. Inclusion criteria included individuals aged 60 years and above undergoing elective non-cardiac surgery requiring general anesthesia with orotracheal intubation belonging to ACA physical status 1, 2, and 3, and all these other people were excluded. After obtaining approval from IEC and after written informed consent, 80 participants were allocated into two groups by the guide. Group A received propofol and Group B received etomidate. All were kept NPO and standard pre-medications were given as per institutional protocol. After shifting to OT, standard monitors were attached and baseline hemodynamic parameters were noted. Intravenous access was secured, pre-oxygenated with 100% oxygen. Injection fentanyl 2 microgram IV per kg IV was given as analgesic. Participants belonging to both the groups were administered with respective drugs at the rate of 2 ml every 10 seconds until there was no response to mild prodding or shaking. Group A received propofol at concentration 10 mg per ml and Group B received etomidate at concentration of 2 mg per ml. Myoclonic activity, pain on injection was noted. Vecuronium was given and patient was intubated, and laryngoscopy intubation response was graded based on Staines modification of Helbon-Hansen score. Parameters were recorded, that is heart rate, systolic, diastolic, mean arterial pressure at baseline, after and before laryngoscopy and intubation, and up to 1, 2, 3, and 5, 10 minutes up to post-intubation. Pain during injection was noted based on 4-point graded scale and myoclonic activity based on 3-point graded scale. Statistical analysis was done. Totally 80 participants belonging to 14 each group. Both the groups were demographically comparable. Baseline hemodynamic parameters of both the groups were comparable. Percentage change in mean systolic, diastolic, and mean arterial pressure showed statistically significant fall in blood pressure at induction and increase in pressure response following in laryngoscopy intubation propofol compared to etomidate group, which returned to baseline after 10 minutes. The mean dose requirement of propofol was just 0.9 mg per kg and mean etomidate was 0.15 mg per kg. Incidence of pain on injection was 30% in propofol and 10% in etomidate, and myoclonus was 3% in propofol and 20% in etomidate. Patients who received etomidate had a lesser hemodynamic fluctuations post-induction and after laryngoscopy and up to 10 minutes. Propofol exhibited significant decrease in blood pressure at induction followed by a greater pressure response. Pain on injection was higher in propofol compared to etomidate, and occurrence of myoclonic movements were more in etomidate compared to propofol. Dose required for induction was significantly lesser, maybe because elderly population are more sensitive to induction agents. Scope for future work, a larger sample size with long-term follow-up with use of BIS and entropy for appropriate dosing and measurement of reduction of cortisol levels and newer formulation of propofol and etomidate is required. We conclude that etomidate as an induction agent provides superior hemodynamic stability than propofol with a lesser rate of pain on injection. These are my references. Thank you. I'm Pratna Amraj. My
One question.
Yes, sir.
Apart from this side effect, pain in injection and the myoclonus, what others you noticed during induction? Any respiratory depression, any other? Have you compared it?
Respiratory depression, yes, sir. Saturation was maintained 100% throughout, sir. Both the groups during induction. And even laryngoscopy and intubation was graded, sir, based on Staines-Helm modification of laryngoscopy and intubation score. Both showed clinically acceptable intubation score, that is between 6 to 10, sir.
Okay, okay. So as a conclusion of this study, would you recommend that intermediate should be the priority agent for induction as compared to propofol in most of the cases?
In elderly, yes, sir, we could try. Because we included even ASA 1, 2, and 3, all the three classes of ASA physical status who were posted for non-cardiac surgery, sir. As it showed better hemodynamic response, and as I've not measured cortisol level, for induction dose, it doesn't reduce that much, sir, as previously proven also. So I recommend that we can use etomidate for induction agent in elderly, sir.
Thank you. Thank you, Dr. Pratna. Thank you.
Thank you, sir.
Sir, can we go to the next presentation?
Yeah, please, please.
Thank
Go
you.
ahead.
Hello everyone, I am discussing about a prospective study on comparing the efficacy of varying doses of intravenous dexamethasone on potentiating the pain relief of a single shot ultrasound guided supraclavicular brachial plexus block. Introduction: the supraclavicular block is indicated for primary regional anesthesia or postoperative pain control for upper limb surgery. Local anesthetic alone provide analgesia around 4 to 8 hours, but with additive, it improves onset and duration of the blockade. Various studies have proved intravenous or perineural dexamethasone prolongs the postoperative analgesia. Our aim was to find out the effect of IV dexamethasone on potentiating the pain relief after surgery and to find out the effect of nausea or vomiting and blood glucose level after the surgery. We conducted a randomized prospective control study after approval from ethical committee till April 2020 for a study duration of 1 to 3 hours. We randomized 60 ASA 1 to 3 patient into 4 groups, 15 patient each. Inclusion criteria: ASA 1 to 3 patient, age above 18 years, scheduled for upper limb surgery. Exclusion criteria: ASA 4 and above, coagulopathy, allergy, infection, or patient with diabetes mellitus. Methodology: after approval from ethical committee, informed consent taken, pre-anesthetic evaluation and optimization done. All patients receive standard monitoring, pre-operative blood glucose level before shifting to OT. All patients received UST guided supraclavicular brachial plexus block with 20 ml 0.5% levobutirac. Group 1 patient received 8 mg IV dexamethasone, group 2 4 mg, group 3 2 mg, and group 4 as control. All patients received general anesthesia under standard guideline following the block. After adequate pre-oxygenation and pre-medication, induction with propofol, fentanyl, and atracurium, maintenance with oxygen, nitrous oxide, and sevoflurane, intraoperative blood glucose after 1 hour after IV dexamethasone. At the end of surgery, patient extubated and shifted to PACU. Blood glucose level after immediate post-operative period and 6 hours after entry to PACU. VAS scores at immediate post-operative period at interval 1, 2, 6, 12, and 24 hours after the surgery. If VAS score is more than or equal to 4, paracetamol or tramadol is given as rescue analgesic. The following parameters were recorded and compared: total duration of post-op analgesia, post-operative blood glucose level, and post-operative nausea and vomiting. But as soon as first dose of rescue analgesic given, the study ended. Sample size calculated 15 per group as studied by Sankita Dankar et al. The collected data were analyzed by mean, standard deviation, frequency, proportion, chi-square test, ANOVA test using SPSS 20 software. There was significant difference in VAS distribution at 6 hours and 12 hours between the 4 groups, and mean time of rescue analgesic in group 1 was around 835 minutes, group 2 around 658 minutes, group 3 around 547 minutes, and group 4 around 427 minutes. Mean glucose was significantly lower in group 4 compared to all other groups, and in group 1 there was increase in mean blood glucose level at intra-op, immediate post-op, and 6 hours after the surgery. In this study, group 3 had a post-op nausea vomiting 46.67%, group 4 around 66.67%. Discussion: a study by Paveen et al. Concluded IV dexamethasone will prolong the duration of analgesic significantly, and Dangar et al. Concluded low dose of IV dexamethasone significantly prolonged the duration but without producing any significant side effects. In our study, group 1 got maximum mean time of rescue analgesic and group 4 got minimum mean time of rescue analgesic. And in our study, higher the dose of IV dexamethasone, higher was the increase in blood sugar level and vice versa. And higher the dose of IV dexamethasone, lesser was the incidence of postoperative nausea and vomiting. As conclusion, low doses of intravenous dexamethasone like 2 mg and 4 mg significantly prolongs the duration of postoperative analgesia and reduces the incidence of postoperative nausea and vomiting without producing any significant side effect. These are the reference. Thank you.
So my question is that,
yes, sir.
what is the maximum duration of analgesia? Any one of the patient, what is the maximum duration of analgesia you got it?
Sir, around 14 hours we got, sir.
14 hours. So this is the usually, there are the two ways to combine this. Either some anesthesiologists, they combine this local anesthetic with the dexamethasone. Another, as you have mentioned in your study, the IV supplementation of the dexamethasone. So both are good, but you have to mention or counsel the patients regarding the prolonged effect of our analgesic combination. Okay. And secondly, what happens in post-operative period? Most common thing after the upper limb surgery is the nerve injury, the detection of nerve injury. So that is my biggest concern. You delay that nerve injury detection if you significantly prolong the duration of analgesia. Thank you very much. We can go for proceed for a next presentation.
Thank you, sir.
Thank you.
Thank you, sir.
Affecting short-term outcome in cerebral revascularization surgery. I'm Dr. Pratyusha, Junior Resident from the Department of Anesthesia from NIMS, Hyderabad. Today, my topic of presentation is perioperative factors affecting short-term outcome in cerebral revascularization surgeries in Moyamoya disease, a single-center retrospective study. Introduction: Moyamoya disease is a rare progressive cerebrovascular disorder characterized by stenosis or occlusion of the intracranial vessels. The clinical presentation varies from ischemic stroke, intracranial hemorrhage to headache, seizures, and transient ischemia attack in children as well as in adults. Revascularization surgery procedures have shown to improve, provide symptomatic benefit by augmenting collateral cerebral blood flow, thereby decreasing further ischemic insult and neurological deterioration. The short-term outcome of patients undergoing revascularization surgery can be affected by various perioperative factors, and the literature pertaining to it is lacking in India due to lesser prevalence of the disease in other countries. The primary aim is to evaluate the effect of perioperative factors on duration of post-operative hospital stay in patients undergoing revascularization surgeries. In this retrospective study, medical records of 20 patients who underwent revascularization surgeries from January 2014 to December 2020 were analyzed. The following preoperative, intraoperative, and postoperative data were collected: age, sex, weight, associated congenital anomalies, clinical features, radiological findings, medication, surgical procedure, first or redo surgery, type of anesthesia, induction and maintenance agent, intraoperative hemodynamics, ETCO2, temperature, fluid requirement, blood loss, urine output, emergence, duration of surgery, duration of anesthesia, postoperative recovery, postoperative complications, sepsis, and duration of hospital stay were recorded. The data was analyzed and the primary outcome was a duration of postoperative hospital stay that was characterized as short stay as less than 7 days and prolonged stay as greater than 7 days. Results. The mean age of the patients was 12.1 years and mean weight was 24.8 kg with 9 male and 11 female patients. Our patients were predominantly pediatric population. 6 patients underwent STA MCA bypass, 10 patients underwent right-sided EDAMS, and 4 patients underwent left-sided EDAMS, and 3 patients combination of MCA bypass and EDAMS, and in 1 patient bilateral EDAMS was done under general anesthesia. Blood loss requiring transfusion was recorded in 5 patients, and all patients had adequate intraoperative urine output. Out of 5 patients, 4 patients had prolonged hospital stay. P-value was 0.026, which was statistically significant. 6 patients had intraoperative hypertension, which was treated with inotrope and blood transfusion. Out of 6, 5 patients had prolonged hospital stay. P-value was 0.026, which is statistically significant. Post-operatively, 2 patients had massive infarct, for which decompressive craniotomy was done. 2 patients had hemiparesis. 1 patient with delayed awakening who had massive extradural hematoma, which was evacuated, and subsequently patient was extubated. 1 patient had prolonged mechanical ventilation due to poor oxygenation due to sepsis or ARDS. For post-operative complication, P-value was 0.0001, which was statistically significant. The mean duration of anesthesia was 3.42 hours, and mean duration of hospital stay was 6.94 days. Gender, clinical features, preoperative drugs, type of surgery, type of induction and maintenance agent used for anesthesia were not statistically significant. P-value was greater than 0.05. The patients having intraoperative hemodynamic fluctuation like hypotension and blood transfusion had a high incidence of post-operative complication and was associated with prolonged hospital stay, and P-value was less than 0.05. The outcome of the patients undergoing neurosurgery for myomyositis depends on various perioperative factors. Intraoperative maintenance of cerebral perfusion pressure is crucial for good postoperative neurological recovery. This is influenced by the type of anesthetic used, hemodynamics, fluid resuscitation, blood loss and hematocrit, ETCO2, temperature regulation, urine output, and type of procedure done. We observe that maintaining adequate depth of anesthesia, especially during airway manipulation and at the time of revascularization, may be more important than the type of anesthetic agent used. We analyze that despite maintenance of adequate depth of anesthesia and fluid resuscitation, patients having hemodynamic fluctuations during intraoperative period had a higher requirement of blood transfusion and fluid for maintenance of cerebral perfusion pressure, and subsequently degree of neurological injury leading to longer duration of hospital stay. Surprisingly, we did not find any association between duration of surgery and anesthesia with the length of the hospital stay. Limitations, as it is a rare basis, small number of people were involved. We have not taken Glasgow outcome score in this study.
Can we proceed for next presentation?
Hello, Dr. Sudhi, sir.
Yeah.
Can we go to the next presentation?
Next, please.
Good evening. I am Dr. Preeti, postgraduate resident from the Department of Anesthesiology of Sri Devarajas Medical College, Thamaka, Kolar. Will be presenting on novel coronavirus vaccines, the perspectives of a healthcare worker. Introduction. With the outbreak of novel coronavirus disease in December 2019 at Wuhan City, China, WHO declared it as a pandemic in March 11. The spectrum of disease ranged from being asymptomatic, mild, severe, and even fatal. Vaccines play a pivotal role in improving the health outcomes during past similar epidemics and pandemics like smallpox, polio, and plague. With the increase in morbidity and mortality associated with COVID-19 disease, the development of a safe and effective COVID-19 vaccine is a critical step to halt the pandemic. Although vaccination against COVID-19 has started, misinformation and conspiracy theories surrounding COVID-19 vaccines can highly influence vaccine uptake. Such theories can lead to vaccine hesitancy. SAGE Working Group of Vaccine Hesitancy defined the term vaccine as delay in acceptance or refusal of vaccination despite the availability of vaccination services. Vaccine hesitancy for COVID-19 vaccine can result in drastic effect on the measures to stop the spread of SARS-CoV-2 infection. Aim of the study. The present study was done to assess the COVID-19 vaccine knowledge, acceptance, and determinants like post-vaccination symptoms and signs among the healthcare workers of Sri Devarajas Medical College, Thamaka, Kolar. Materials and methods. This was a cross-sectional descriptive study. The study population were healthcare workers like physicians, residents, nurses, and technicians. The study was done for a period of 3 months from June 2021 to August 2021. The study subjects included were above the age of 30 years of both genders, and the vaccine contraindicated individuals as per the available guidelines were excluded from the study. The sample size was calculated to 189. A validated self-administered electronic questionnaire were used to collect the data, and informed consent was obtained, and ethical committee approval was also obtained before conducting the study. Statistical analysis was done through SPSS version 23. My results. Profile of the study's participants based on the believing in safety of the vaccine, the effectiveness, and the vaccine preventing complications, and attitude towards the vaccine. Discussion. Efficacy and availability of COVID-19 vaccine are important to control the pandemic successfully. Health authorities and policy makers must ensure trust and acceptance from both the healthcare workers and community, as delay and hesitation may lead to vaccination refusal. This could result in drastic effects on the public health and hamper the healthcare system's ability to accommodate the challenges faced during the pandemic. Our study provided an overview of perspectives of COVID-19 vaccine by the healthcare workers. Various other studies done by others proved that the vaccination is safe and effective prospectively. And in this study showed that around 78% of the patients have taken both the vaccines, and among 33 healthcare workers and 18 were willing to take the second dose as well. Another study concluded that around 76% of the healthcare workers were willing to receive the vaccination. A systemic overview of recent literature done on 33 countries showed that vaccination acceptance varied based on income levels and geographical locations. Acceptance was low in countries like Jordan, Kuwait, and other countries like Russia and Poland and Italy. In contrast, the vaccination was higher in countries like China, Indonesia, and Malaysia. The study also shows the vaccine acceptance should be increased and encouraged to achieve population based on geography, immunity, and needed to control the vaccination according to pandemic situation. My conclusion, addressing the conspiracy theories, public concerns, increasing the vaccine awareness regarding COVID-19 vaccination as an epidemic control method, and decreasing the vaccination hesitancy, and raising the efforts to provide vaccines to countries with limited resources to provide and to prevent additional deterioration of general public health as a result of COVID-19 is imperative. Thank you. My references.
Thank you, doctor. We can move to the next presentation, please.
Is comparison of intubating conditions between cuff inflation technique and Megal's forceps technique in wheelscopy guided nasotracheal intubation. Introduction. Nasotracheal intubation is a common procedure in dental and ENT surgeries. During nasotracheal intubation, the tip of the ET tube lies along the posterior pharyngeal wall, making it difficult for intubation. With the use of cuff inflation technique, the tip of the ET tube is directed anteriorly towards the glottis without the need of Megal's forceps. Aims and objectives. The study is done to determine the usefulness of cuff inflation method for VL scopy-guided nasotracheal intubation. The primary objective is to compare the time required for intubation, and the secondary objective is to compare the hemodynamic responses to intubation. Inclusion criteria is ASA 1 and 2, age between 18 to 65 years, and MPC 1 and 2 with adequate mouth opening of more than 3 centimeters. Exclusion criteria are patient's refusal, patient with contraindications for nasotracheal intubation, mouth opening of less than 3 centimeters, and uncontrolled systemic disease. Methods. It is a prospective randomized controlled study done at MGMG Trichy. The study was conducted in about 40 patients who are undergoing orofacial and maxillary surgeries. The patients were randomly divided into two groups, Group A and Group B. Group A were intubated with cuff inflation technique and Group B using Megal's forceps technique. Methodology. The patients were randomly divided into Group A and B. The preoperative room, the nostrils were decongested with nasal pack using 2% lignocaine and xylometazoline 10 minutes prior to induction. In both groups, patients were pre-oxygenation with 100% O2 for 3 to 5 minutes and pre-medicated with glycopyrrolate and midazolam. Induced with propofol till the loss of verbal response and neuromuscular blockade with induction vecuronium of 0.1 mg per kg IV. After adequate neuromuscular relaxation, appropriate size of ET tube were introduced via the nostril in head neutral position. Once the ET tube reaches the oropharynx, the time is now noted as T1, that is the time from ET tube introduction into nostril until it reaches the oropharynx. Now video laryngoscopy is performed with CMAC laryngoscope. The patients in Group A were intubated with cuff inflation method, that is the cuff was inflated with 15 ml of air and advanced into the glottis. If it could not be done, additional 5 ml of air was inflated. When the tube tip reached the glottis, the cuff was deflated and advanced into the glottis till the cuff was inside the cords, and the time is now noted as T2, that is time from laryngoscopy to confirmation of the tube position. The patient in Group B were intubated with Megal's forceps, and time T2 is noted in this group after confirmation of the ET2 position. The hemodynamic parameters like heart rate, SBP, DBP, MAP were noted at baseline induction and 1, 3, 5, and 10 minutes after intubation. The failure to intubate using cuff inflation and those require Megal's or other methods in Group A were excluded from the study. The statistical analysis were performed using SPSS software. If p-value was less than 0.05, it was considered statistically significant. The graphical charts here show the demographic distribution and the CL grading between Group A and Group B. The graphs below shows the hemodynamic responses like heart rate and MAP variation following intubation in Group A and Group B, which was significantly higher in Group B following intubation. In this graph, it shows the time T2 and the total time needed for intubation was significantly lesser in Group A compared to Group B. Results. It is noted that time T2 and total time for nasotracheal intubation was shorter in Group A compared to Group B. And the hemodynamic parameters at 1 minute and 3 minutes following intubation were significantly higher in Group B than Group A. The malalignment between the tip of the ET tube and glottic opening poses a challenge during nasotracheal intubation. The use of Megel forceps may cause trauma and lead to significant hemodynamic response. The cuff inflation technique obviates the use of other manipulation and aids in intubation, avoiding associated complications. Conclusion. The use of cuff inflation technique in VL scopy-guided nasotracheal intubation was more successful, required less time, and had minimal hemodynamic responses. My references. Good morning. My topic for presentation is comparison of intubating conditions between cuff and
Doctor, my question is, in how many patients there is a failure to intubate by using this cuff inflation technique?
So, yes, sir. So, the total population was about 40 patients, and 4 cases we weren't able to intubate using the cuff inflation method, and those were excluded from the study. So.
Yeah, only 4 patients.
Yeah, yes, sir.
Okay. Thank you very much. Thank you very much.
You,
we proceed for next presentation.
My study is comparison of changes in femoral vascular Doppler measurements and vasopressor requirements with and without leg wrapping in elective LSCS. It is a randomized control trial. Spinal anesthesia is mostly associated with hypotension in 80% of the parturients. We would like to already pharmacological and non-pharmacological methods were found to be effective. Out of the non-pharmacological, leg wrapping is found to be effective. However, the vascular response to leg wrapping is not known. In our study, we would like to assess compare the changes in femoral vascular measurements and using ultrasound and blood flow characteristics, ultrasound cross-section area and blood flow characteristics using ultrasound without leg wrapping pre and post spinal anesthesia and the vasopressor requirements. Objective is to compare the changes in the femoral vascular characteristics and with the in the pre and the post spinal anesthesia within the leg wrapping and the non leg wrapping group and to find the incidence of hypertension. Inclusion criteria ASA2 patients, normotensive, BMI more than 30, exclusion contraindication spinal, and when the spinal log level doesn't reach T12. 60 patients were parturients enrolled by sequential sampling, randomization by online random number generator. Anesthesiologist not involved in the study will open the envelope and allocate the group. Leg group group C is control group and LW is leg wrapping group. The femoral vascular measurements will be done prior to spinal anesthesia and followed spinal anesthesia when the level is reached till T6. Bolus vascular requirements will be calculated. Rescue measures, hypotension will be treated by mefentramin and bradycardia by atropine. SBB will be recorded every 2 and 5 minutes after delivery and ultrasound measurements will be noted. Rescue bolus recommendation will be also be noted. Upgoes will be noted in the baby. Sample size is calculated using a sample size calculator app. The hypothesis of the study is leg wrapping may reduce a femoral venous blood flow and reduce bolus vasopressor requirements. Alpha error of 0.05, sampling size calculated as 28. Considering our dropouts, we calculated 30 as a sample size in each group. That is a total of 260. Statistics were done using graph-pad prism variation. Students' t-test is used for the ultrasound measurements. Demographic variables were not significant. Femoral vein diameter was significant post-spinal anesthesia in the leg wrapping group. Artery diameter was significant post-spinal anesthesia in the leg wrapping group. Peak systolic velocity of the femoral artery is significant pre-spinal anesthesia in the leg wrapping group, and femoral artery end diastolic velocity is significant in both the group. In the leg wrapping group, both pre and post spinal anesthesia, and the arteries, femoral arteries mean velocity is significant post spinal anesthesia in the leg wrapping group. Pulsatile index is not significant. Resistance index of the femoral artery is significant post spinal anesthesia in the leg wrapping group. Mefentramin requirement is 86% in the non-leg wrapping, and leg wrapping group it is only 6%. Discussion according to a study done by Singh et al. And Beagle et al. Post spinal anesthesia, the incidence of hypotension is higher in the control group than the leg wrapping group. Sifo et al. Observed that the transverse diameter of the right common femoral artery is more than 12. Then the occurrence of post-spinal hypotension is high. In our study also, the common femoral vein diameter is 13.1 when the incidence of hypotension is significantly high in the control group compared to the leg wrapping group. And a study did by Moore et al. Increase the femoral vein blood flow and velocity in post-spinal ventricular position. In our study, post-spinal femoral vein diameter increased significantly in the control group compared to the leg wrapping group. Conclusion: leg wrapping reduces the degree of femoral venous dilatation, thereby increasing the preload and resistance index, and to prevent the fall in systemic vascularization, they will be reducing the incidence of hypotension in patients undergoing LSCS.
Thank you very much. Nice presentation. And we move to the next topic.
Okay, sir. Sir? Sir?
Yeah, please proceed.
Sir, I'm Prem Jepina, last presentation.
Sir, if you want to ask her something, she's here.
No, please. Proceed to the next one.
Questions? Hello?
Hello. Sir, actually, I missed my presentation. Hello.
Okay.
Any technical problem?
एक्चुअली सर वो जो नेक्स्ट प्रेजेंटेशन की जो वीडियो है उसमें जो है वॉइस प्री रिकॉर्डिंग नहीं आया है, तो मैं उसको प्ले करूं, सिर्फ स्लाइड्स दिखेंगी।
उनको सबसे आखिरी में कर देना, सबसे आखिरी में।
ओके सर,
ठीक है। और एक और है, हाँ, वो काले, उनका प्रणीता काले, उनको भी आखिरी में कर देना।
ओके सर,
ठीक है। हाँ।
Greetings to all. My name is Dr. Priya Yenilkar. I am here to present on the topic study of knowledge, attitude, and awareness of using mobile phones among rural tertiary healthcare workers during COVID-19 pandemic at Pravra Rural Hospital. As we all know, COVID-19 is an acute respiratory disease caused by coronavirus, which was first detected in December 2019 in Wuhan, China. It was declared as a global pandemic by WHO. Human coronavirus could persist on inanimate surfaces such as metal, glass up to 9 days, but they may be efficiently inactivated by surface disinfection procedures. However, mobile phone surfaces are a high-risk surface which can directly come in contact with the face or mouth while talking over the phone. Hence, the following study was conducted. Aims and objectives of the studies were to study the knowledge, attitude, and awareness of using mobile phones among rural tertiary healthcare workers during COVID-19 pandemic in a rural hospital. It was an observational cross-sectional study, including healthcare workers in Pravra Rural Hospital in a study duration of 6 months. Inclusion criteria included nursing staff and medical personnel working in critical care unit and giving consent. Sample size was faculties, postgraduate students, and nursing staff. And ethical committee clearance was taken before the study. Consent was taken. Questionnaire consisted of 2 parts, demographic data and questionnaires related to the study, consisting of knowledge, attitude, and awareness questions, which I'll give you a brief review of. Attitude consisted of questions regarding mobile phone usage and sanitization options. Awareness consisted of questions regarding the transmission of the disease. Now moving on to the statistical analysis and results. Number of samples were of 32. These are the demographic data. Moving on to the knowledge part. 93.9% felt that they were facing COVID-19 pandemic currently. 48.5% felt that spread through usage of mobile phones was happening. 89.4% felt that sanitization reduced the COVID-19 transmission. In attitude, before COVID-19, 98.5% used the mobile phones. During COVID-19, 96.2% used a single phone. Only 6.1% had an additional phone. Mobile phone used in the house and hospital were the same in 94.7% people. Only 74% sanitized their mobile phones, amongst which application of hand sanitizer to the mobile phones and alcohol are also the commonest techniques. Awareness, 30.3% felt that there is complete stoppage of using mobile phones can decrease the risk of transmission completely. 50% felt that landline is more safer option. Discussion, COVID-19 is an emerging, rapidly changing disease. Mobile phones have become a daily necessity of life and an important means of communication. The mobile surface is touched multiple times in a day, and the same hand is used on face, nose, and mouth. In our study, we are assessing the knowledge, attitude, and awareness using mobile phones and COVID-19 pandemic. In our study, 132 participants, out of which 93.9% were having sufficient knowledge regarding it, which was scored much higher than the Song et al. Study done on the Chinese general population. This might be because the Chinese assessed symptoms using only one direct question, and we chose multiple options. A similar study conducted by Bhagwa Thula AS et al. Among 529 participants concluded poor knowledge among 61% of the healthcare workers, where however, in our study, 6.1% had poor knowledge regarding COVID-19. A study conducted by Hatil had 98% respondents aware of transmission of COVID through contaminated surface. In our study, it was much less, it was 30.3%. In a study by Kumar et al., 66 healthcare workers took participation. Mobile disinfection procedures were done only by 13.6%. In our study, 74.2% people sanitize their mobile phones. Not many scientific studies have conducted to examine the survivability of COVID-19 virus on various surfaces and seasons. Some studies reported that it can survive on metal and glass surface as long as 9 days. Hence, necessary precautions in sanitization should be practiced meticulously. Both cleaning and disinfection can reduce the risk of fomites transmission. No reported studies have investigated the efficacy of surface cleaning for reducing concentrations of SARS-CoV-2 on non-porous surfaces. In our study, healthcare workers' attitude towards understanding of spread of disease through mobile phones surface safety measures and precautions like using different sanitation techniques were assessed. Only 50% felt that telecommunication through landline is safer than the mobile phones. There is a need to be aware of the spread of the virus and determine the factors affecting the incidence of infection and severity of the disease and its prevention. It's therefore paramount importance healthcare workers across the world have adequate knowledge regarding it. Limitations of our studies that we included only healthcare workers working in critical care unit. We should have included other healthcare persons as well. Mobile phones are convenient and most commonly used method of communication, hence that surface could be a potential source of spreading many infections, including COVID-19. So separate communication devices could be kept in COVID-19 wards, which cannot be taken outside the premises of the COVID center to avoid unnecessary contagion to the disease. Awareness should be developed regarding the spread of the infection and disinfection practices like UV light, especially for mobile phones, which are day-to-day used. These are my references. Thank you.
My question is, what other methods instead of this mobile phones you recommended?
Sorry, sir, can you repeat the question?
What other gadgets apart from this mobile phone? These mobile phones, they are really very mobile and they are transferred from hand to hand. Any other technology can be used in this COVID pandemic to communicate?
So rather than using the mobile phones, we could use the landline techniques, because landlines, we cannot take it anywhere and it can be inside the ward, it can be disinfected. Like mobile phones we are using it so much, and most of us only carry a single mobile phone. Not everyone has the liberty to use two. So we take the same mobile phones at home. We are infecting and putting at risk our people, our hostel mates, our families. Everyone will be at more risk. In spite of we can use landlines so that it's easy to communicate, and we all have monitors inside the wards, so that if any reports or chest x-rays or anything, we can just email it to the person, and the computer, we can just use it like that, so that mobile things we can avoid basic transmission of this.
Up to a mark we can avoid, but definitely mobile has more advantages. So the most of the sharing and the patient management, most of the centers they are doing through this mobile. Anyway, very nice presentation. Thank you very much.
Thank you, sir.
Thank you. We move on to the next presentation.
Hello everyone, I am Dr. Priya. postgraduate in the Department of Anesthesiology, Navodaya Medical College, Raichur. My topic for paper presentation is magnesium sulfate as an adjuvant to 0.25% bupivacaine in ultrasound-guided transverse abdominal spleen block for post-op analgesia in patients undergoing lower abdominal surgeries under subarachnoid block. It's a comparative study. Under the guidance of Dr. Mohan Sir, Assistant Professor in the Department of Anesthesiology, Navodaya Medical College, Raichur. Coming to the introduction part, major proportion of pain developed by patients undergoing abdominal surgeries is attributed mainly to somatic pain signals derived from the abdominal wall. Components of anterior abdominal wall, which include skin, muscles, and parietal peritoneum, are supplied by sensory neurons derived from anterior rami of spinal nerves T6 to L1, which includes intercostal nerves, subcostal nerves, ilioinguinal, iliohypogastric nerves. These neurons pass through a neurofacial plane between the internal oblique and transverse abdominis muscle. The objective of tab block is to deposit local anesthetics within the plane between the internal oblique and transverse abdominis muscles. Coming to the aims and objectives of the study. Aim is to compare the efficacy of injection 0.25% bupivacaine alone and injection bupivacaine 0.25% with magnesium sulfate of 150 mg in ultrasound-guided transverse abdominal spleen block for lower abdominal surgeries performed under subarachnoid blockade. Objectives are to measure quality of analgesia by assessing time to peak analgesia and duration of post-op analgesia. Need for rescue analgesic and total dose of the rescue analgesia required in first 24 hours post-operatively. Coming to the material and methods, it's a prospective randomized comparative study carried out in a hospital for a period of 22 years. After obtaining approval from ethical committee and consent, 80 patients were considered, and the inclusion criteria are age between 18 to 55 years of either sex, patients belonging to ASA1 and ASA2 category, and patients undergoing lower abdominal surgeries. Exclusion criteria are patients with significant coagulopathies and contraindications to regional anesthesia, any allergy to study drugs, and infection at the site where block needle has to be inserted, and patient's refusal or the exclusion criteria. And after detailed pre-anesthetic checkup, the standard monitoring including ECG, non-invasive blood pressure, arterial oxygen saturation were applied, IV access was secured, IV fluids started. All patients received spinal anesthesia with 3.5 ml of hyperbaric bupivacaine 0.5% without any additive in left lateral position without any table tilt. Level of anesthesia achieved, and after completion of the surgery, when level of sensory blockade has regressed to T10, tab lock was performed under USG guidance using 22 gauge 10 centimeter length Stibnuplex needle. Patients were randomly allocated to receive tab block with 18 ml of bupivacaine 0.25% with 2 ml of normal saline group A, and group B received 18 ml of bupivacaine 0.25% with 1.5 ml of magnesium sulfate 150 mg along with 0.5 ml of normal saline group B. These patients were monitored in the post-op. And coming to the results, the demographic factors like age, gender, and weight did not show much significance in both group A and group B. And the hemodynamic factors also not much significance was noted. The significance where we noted was in the time of onset of peak of analgesia, duration of analgesia, total tramadol consumption. In group A and group B, when it started, we considered time of onset of peak analgesia. It was much faster in group B, which is found to be significant. And duration of analgesia was prolonged in group B. And total tramadol, the rescue analgesia was, the consumption was less in group B. So P value was found to be significant in these three parameters. So coming to the discussion part, our study significantly says that using magnesium sulfate as an adjuvant to bupivacaine in tab block, it reduces time onset of peak analgesia and prolongs duration of action and reduces the usage of rescue analgesia. And these are the following studies which supports our study. And coming to the conclusion, magnesium sulfate can be considered as a good adjuvant to improve quality and duration of tab block. These are the references.
One question is that how much volume of the magnesium sulfate you are using?
So I used 1.5 ml, sir, which came up to 150 mg, sir. That much of magnesium sulfate I used in my study, sir.
Is there any effect of volume were the spread of this analgesic effect in a TAP block?
Yeah, sir. It depends upon the concentration, the volume of, and the site where we inject the drug. That depends upon the duration of analgesia, sir. The volume also matters for the studies, sir.
Any other significant side effects you noticed during your studies?
So in my study, not much significant side effects were noticed, sir. As it's it's a tab block, we didn't see much. As we used ultrasound guided block, we didn't see much of side effects, sir.
Any irritation at the site of injection, or itching, or inflammation kind of things?
No. As such, much side effects were not noticed, sir.
Okay.
Because prior to this thing, we had given a test dose of the local anesthetic, sir. So as of our study, no side effects were noticed, sir.
My concern is with the magnesium sulfate. What happens if you deposit in this TAP block region?
Pardon me, sir?
Yeah, magnesium sulfate. Magnesium sulfate you are depositing along with dopamine in the magnesium sulfate itself is causing some side effects or not side effects. So you didn't find any one of them?
No, sir. In my study, much side effects were not noticed, sir.
Okay, thank you.
Thank you, sir.
Next paper, please.
Good morning, everyone. Myself, Dr. Priyanka, presenting an e-paper titled Role of Perfusion Index as a Predictor of Hypertension Following Subarachnoid Block in Elderly, a cross-sectional observational study. Coming to the introduction, hypertension, as we know, is the most common side effect of subarachnoid block. It is more detrimental in the elderly as they are at increased risk of developing long-term complications because they have a reduced physiological reserve and increased incidence of systemic disease. Continuous and real-time feedback of the circulatory status of patients will help make a more informed decision regarding patient management. Perfusion index is a simple, non-invasive, and a much less expensive technique of monitoring hemodynamic status together with conventional parameters. Establishing a correlation between baseline perfusion index and hypertension after spinal anesthesia will help anticipate the dramatic fall of blood pressure and its management. We aim to assess the predictive value of subarachnoid block-induced hypertension using perfusion index in the elderly. Our objective was to record the perfusion index prior to the subarachnoid block, to measure the incidence and magnitude of hypertension after the block, and to find a relationship between perfusion index and subarachnoid block-induced hypertension. It was a cross-sectional observational study which was done at Justice K. Segre Charitable Hospital, Mangaluru. A sample size of 110 was calculated using the above-mentioned formula. We included patients who were posted for elective surgery below the level of umbilicus requiring subarachnoid block, patients below 60 years and above, and belonging to ASA physical status 1 and 2. We excluded patients who had any contraindications for subarachnoid block, patients with valvular heart diseases, inadequate block, technical failure, and conversion into general anesthesia. Methodology. After approval from the Institutional Ethics Committee, the participants underwent a thorough pre-anesthetic evaluation. After written informed consent, those participants satisfying the inclusion criteria were enrolled in the study. As per the standard guidelines, patients were kept nil per oral and were pre-medicated according to institutional protocol. On the day of surgery, after confirming the identity, consent, and NPO status, participants were shifted to the operation theatre. Participants underwent monitoring with standard ASA monitors. Intravenous access was secured with an 18-gauge cannula. Perfusion index was recorded by placing the pulse oximeter on the left index finger. All participants were preloaded with 10 ml per kg bolus of lactated ringer solution, followed by a maintenance of 100 ml per hour. We performed a subarachnoid block with the participants in sitting position with the 25-gauge twin K Babcock needles. We gave a drug of 10 mg of 0.5% hyperbaric bupivacaine with 25 micrograms of fentanyl was injected. Adequacy of the block was checked. Heart rate, systolic, diastolic, and mean arterial pressure was monitored every 2 minutes for the first 10 minutes and then every 5 minutes up to 1 hour. Hypertension was defined as a fall in blood pressure of more than 25% of the baseline blood pressure or mean arterial pressure of less than 60 mmHg, which was treated immediately by rapid infusions of lactated ringers at 8 ml per kg or ephedrine 6 mg boluses. Our results in our study, we included 110 participants above the age of 60 years belonging to ASA 1 and 2. For better analysis, we divided the patients into two groups, patients with hypertension and without hypertension, and compared their age, weight, height, BMI, height of the block in both the groups who underwent various surgical procedures. We analyzed the data collected and compared with each parameter and interpreted the clinical and statistical significance of each parameter. On comparison, PI was found to be higher with the group of patients with hypertension who had a value of 5.21 when compared to those who did not have hypertension with a perfusion index mean of 2.47. A receiver operating characteristic curve was constructed to derive a cutoff for perfusion index. A baseline perfusion index of 3.9 predicted any incidence of intraoperative hypertension after subarachnoid block with a sensitivity of 80% and a specificity of 93%. The test and the gold standard, which is perfusion index and hypertension, agree on 97 out of 110, having a diagnostic accuracy of 88%. Our discussion, we hypothesized that a baseline PI might be beneficial in predicting hypertension following subarachnoid block in the elderly age group. Our findings back up this theory as there appears to be a link between PI and the occurrence of hypertension. Demographically, both the groups were comparable and there was no substantial difference in their distribution. All participants have received a specified dose of local anesthetic to maintain homogeneity. Conclusion, elderly patients with a baseline PA of more than equal to 3.9 are more likely to develop hypertension after subarachnoid block than those with a baseline PA of less than 3.9. These are my references. Thank you. Good morning, everyone. Myself, Dr. Priyanka.
Yeah, Priyanka. Why you included only 60 years and more duration age? What is the why not younger age?
Yes, sir. Elderly patients. So hypertension is more common in the elderly age group, sir, because of the reduced physiological reserve. So
yeah.
Yes, sir. So we thought it would be more helpful in patients who are more than 60 in the elderly age group to predict hypertension, sir.
But most of the patients, they are hypertensive in this age group actually. So this is not a totally conclusive study. You must have taken the 20 to 40 or 20 to 50 years age group. That would have been excluded. Most of the physiological derangements and as well as the drug effects. Most of the patients, they receive any sort of there's a low salt diet or diet modification or any other less activity. So this is a major limitation of this study. Okay, so far as the conclusion or results is concerned. Another point is that when you are achieving this perfusion index, you said you have treated the hypertension with the ephedrine and bolus of the ringer lactate.
Yes.
Is this treatment was sufficient, or sometimes you have to go for the vasopressors in higher doses?
In my study, we did not use any. We didn't use any any inotropes or anything. So only boluses of ephedrine and with fluid resuscitation, BP was maintained. So.
Okay. Thank you very much.
Thank you, sir.
Now we are moving to the next paper.
% hyperbaric bupivacaine in spinal anesthesia for patients undergoing elective cesarean section. Background: spinal anesthesia with bupivacaine is routinely used to provide. My topic is comparison of fractionated dose versus bolus dose injection of 0.5% hyperbaric bupivacaine in spinal anesthesia for patients undergoing elective cesarean section. Background: spinal anesthesia with bupivacaine is routinely used to provide anesthesia for both elective and emergency cesarean section. It has a rapid onset, but it precipitates hypotension. Aim is to compare fractionated dose with bolus dose of hyperbaric bupivacaine in spinal anesthesia for hemodynamic stability and duration of analgesia in patients undergoing elective lower segment cesarean section. Methodology: it is a prospective randomized control study. Sample size 60. Inclusion criteria: ASI class 1 and 2, age 18 to 40 years, weight 50 to 110 kg, height 140 to 180 cm, singleton pregnancies and elective cesarean section. Exclusion criteria: patients with pre-existing diseases like pregnancy-induced hypertension, cardiovascular disease, cerebrovascular disease, and other contraindications to spinal anesthesia. Conduct of anesthesia. After shifting patients to operation theatre, standard multipara monitors are connected. IV access was secured with 18 gauge Venflon. All patients were pre-medicated with injection ranitidine 1 mg per kilogram IV and injection ondansetron 0.1 mg per kilogram IV. All patients are preloaded with ringer lactate solution 10 to 15 ml per kg over 10 minutes with a wedge under the right hip. The dose of bupivacaine is taken as 0.07 mg per centimeter height of the patient. Patients who were selected as per the inclusion criteria were randomly divided into two groups. Group B patients received single bolus spinal anesthesia with hyperbaric bupivacaine. Group F patients received fractionated dose with 2/3 of the total dose given initially, followed by 1/3 dose after 90 seconds. Patients were positioned in right lateral position under strict aseptic precaution. Subarachnoid block was performed with 25 gauge pinky needle at L3 L4 interspace after skin infiltration with 2 ml of injection lignocaine 2%. On clear tap of CSF, drug is injected after reconfirmation of CSF aspiration. Patients were turned into supine position with a wedge under the right hip in both the groups. Oxygen supplementation with nasal cannula at 4 liters per minute is given. Time at which injection is completed is considered 0, and all the measurements were recorded from this point. Pain was assessed by loss of pinprick sensation. Motor block was assessed by modified Bromwich score. These tests were performed every minute till the achievement of sensory block up to T6 and motor block with modified Bromwich scale 3. Hemodynamic variables were recorded during the procedure and post-operatively. The number of hypotensive episodes and epidural used were recorded for each patient. Pain was assessed with the linear visual analog scale hourly up to 8 hours or till VAS score is more than or equal to 4. It was considered as the duration of analgesia. Statistical analysis was done using the statistical package for social sciences software. To find association between two categorical variables, Pearson chi-square test was used. P-value of less than 0.05 is considered as statistically significant. Results. The following table represents a distribution of demographic variables between the two groups. There is no much significant difference. Hence, they are comparable in terms of age, height, weight of the patient, and duration of surgery. Distribution and association of vasopressor requirement among two study groups are represented below. In group B, 40% of patients require vasopressor, whereas in group F, only 17% require vasopressor with a significant p-value. The following graph represents the distribution of various blood pressure between the two groups. Regarding motor block, the onset is earlier in group F with a significant p-value. The duration of motor block is longer in group F with a significant p-value. There is no difference in the onset of sensory block between the two groups. The duration of analgesia is longer in group F with a significant p-value. Conclusion. Fractionated dose of bupivacaine in spinal anesthesia provides better hemodynamic stability and prolonged duration of analgesia compared to bolus dose. Hence, fractionated dose of 0.5% hyperbaric bupivacaine can be used as a better alternative to routine bolus dose in spinal anesthesia for patients undergoing lower segment cesarean section. These are my references. Thank you.
Bhuvaneshwari, one question is, what is the logic behind this difference in effect of both the drugs, fractional doses as well as the bolus doses? What is the logic behind that? At the molecular level, what is happening?
Sir, good afternoon, sir.
Good afternoon.
Sir, in fractionated dose, there will be more denser blockade in the lower segment, sir. So it will take more duration for the clearance of the drug, leading to prolonged analgesia and motor blockade, sir, compared to bolus dose.
So this is you are injecting after the 90 seconds.
Yes, sir.
Fractional dose, you are injecting after the 90 seconds. What is the logic again behind this 90 seconds? Is any criteria laid down by some studies like 90 seconds? Why not is it 60 seconds? Why not is it 120 seconds? What is the logic?
Previous reference studies, they have taken it as 90 seconds, sir. Not lesser than that. That's why I have followed 90 seconds, sir.
And you have taken from that references.
Yes, sir.
Okay. Thank you. Thank you.
Thank you, sir.
Next presentation, please.
PDPH is a common complication after lumbar puncture. Typically presents with headache in frontal occipital region, which is postural in nature, worse on standing and better while lying down. Appears 6 to 72 hours after the procedure and usually resolves spontaneously. The prevalence is much higher in pregnant women. The headache is thought to be due to loss of CSF causing downward reaction on the meninges with parasympathetically mediated reflex vasodilation of the meningeal vessel. Therapeutic epidural blood patch is currently the gold standard treatment for PDPH, but epidural blood patch can itself cause accidental dural puncture and has a slower onset of action than the block. Hence, this block has been proposed as a non-invasive intervention. Transnasal approach is the easiest and least invasive approach, which can be done at the bedside without using imaging. Aim is to analyze the incidence of PDPH and evaluate the efficacy of block for its management in patients undergoing elective cesarean section under spinal anesthesia. Objectives are to evaluate the efficacy of block, to analyze the incidence, onset, and presentation of PDPH, as well as the severity of symptom. Inclusion criteria includes age between 20 to 40 years, ASA physical status 1, 2, and 3, singleton pregnancy with a minimum gestation of 37 weeks, elective cesarean section under spinal anesthesia, and consent for the study. The patient was made to lie in supine position with a head in stiffened position. 3 long cotton-tipped applicators soaked in 2% lignocaine for 30 seconds were inserted into each nostril at an angle perpendicular to the face and advanced till the back of nasopharynx until resistance was met. The cotton-tipped applicators were left in place for 10 minutes and then removed, and the patient evaluated for severity of pain both in supine and sitting position for up to 48 hours at various predetermined intervals. In a study, a total of 404 patients were recruited who underwent elective cesarean section using a 25 watts Quincke needle and were then followed up from 6 hours post administration of block till 3 days after surgery. A total of 16 patients developed PDPH. The incidence of PDPH in OBS patients came out to be 3.9%. Onset. In our study, most of the patients develop PDPH on 3rd and 2nd post-op day, followed by 1st post-operative day. The possible explanation could be the rate of CSF leakage, because in our setup, the patient is allowed to emit it only 24 hours after the surgery. Presentation, frontal was the main most common presentation, followed by both frontal and occipital. The least common was that of frontal and temporal. There were no associated symptoms in majority of the patients, but when present, dizziness was the most commonly associated symptom. Age, PDPH is more commonly found in young adults between 20 to 40 years of age with lower incidence in extremes of age. Out of the 20 to 40 years age group taken in a study, majority of the patients who developed PDPH were between 21 to 30 years of age, and just one patient was above 30 years of age. Experience of the attempting person and number of spinal pricks. Thus, patients who received spinal anesthesia and 3rd attempt were more likely to develop PDPH, followed by patients with 2 attempts and those with single attempt. Severity of headache, adequate pain relief was seen with transnasal sphenopalatine ganglion block, as a mean VAS score was less than or equal to 4 post administration of block throughout the study period. The longer duration of effectiveness of the block in our study would be due to the use of 3 long cotton-tipped applicators soaked in local anesthetic for each nostril, instead of 1 applicator for each nostril, thus allowing a greater number of fibers of the ganglion to be blocked. Limitation of a study was that our hospital was declared as a COVID hospital, so the data collected was not adequate, as a number of cases were restricted to 404 elective cesarean sections, and being declared as a COVID hospital, the patients could not be followed up thoroughly in the post-op period, which may have led to comparatively lesser incidence of PDPH seen in our study. Conclusion from our study, we conclude that the time taken by sphenopalatine ganglion block using transnasal approach to obtain the clinical effects was very fast in onset, as proved by substantial decrease in VAS scores immediately after the block and with sustained pain relief for up to 48 hours. Hence, patients presenting with PDPH should be considered for block.
My question is, in your patient, you simultaneously used all the other measures to counter this PDPH, like IV fluids, steroids, and along with that, you have given the sphenopalatine block?
Sir, fluids were given in the post-operative period by the surgeons only. Otherwise, I didn't compare it, the block, with any other modality of treatment.
Okay, so symptomatically, your patients were all right. They were not feeling any pain. That is
post-block.
Post-block, of course, post-block.
Yes, sir. Post-block, the VAS score was less than 4 in all the patients. The 16 patients we covered, so it was less than 4 post-block.
Okay. Thank you very much. Next, please. Next. paper.
Hello everyone, I am Dr. Rajeshwar Zala from Gitanjali Medical College and Hospital, Udaipur. I am presenting my paper on effects of IV dexmedetomidine on post-operative serum procalcitonin levels following cardiopulmonary bypass, a single valve replacement surgery. It is a prospective randomized controlled double-blinded trial. Introduction. In cardiac surgery under CPB, systemic inflammatory response syndrome occurs with clinical and biological changes due to various stimuli. PCT is an early sensitive and specific indicator of infection and inflammatory process. Dexmedetomidine is a selective alpha-2 adrenergic agonist, and nowadays its anti-inflammatory effects have been known and explored. Aims and objective. Aim is to compare the effects of IV Dexim on serum procalcitonin levels in single valve replacement surgery under CPB with the control group. Primary objective is to compare the effects of IV Dexim on serum procalcitonin levels versus control group in single valve replacement surgery done on cardiopulmonary bypass. Secondary objective is to evaluate effects of IV Dexim on hemodynamic variables, body temperature, complete blood count, and to see the adverse effects like nausea, vomiting, drowsiness, hypotension, bradycardia, respiratory depression, and pruritus. Methods. After approval from Institutional Research Review Board and informed consent, this study was undertaken in 2020, January to June 2021. Study design is a prospective randomized controlled double-blinded study. Power analysis showed sample size of 30 in each group. I used chi-square test and student t-test for statistical analysis, and p-value less than 0.5 was taken statistically significant. Inclusion criteria have age 18 to 70 years, ASA grade 1, 2, 3, BMI less than or equal 28 kg per meter square, patients with surgical indication for single valve replacement surgery, and ejection fraction of 60% or more. Exclusion criteria have include a history of fever in last 2 weeks, ALC more than 11,000 NSAIDs and perioperative steroids before 2 weeks of surgery, neurological, psychiatric, hepatic, renal, respiratory diseases, and allergy to surgery drugs. Methods. Sample size of 60 patients was taken and divided into two groups, 30 each, X and Y. Group X was given Dexim 1 microgram per kg at the time of induction, followed by post-operative IV infusion of 0.15 microgram per kg per hour. Same volume of normal saline was given to the patients in Y group at the same rate. Serum procalcitonin level were measured preoperatively and postoperatively at 15 minutes, 24, 48, and 72 hours. Changes in HB, TLC, platelet count, C-reactive protein, hemodynamic variables, and adverse effects were measured at the same time intervals in both the groups. Results. This graph shows comparison of serum PCT levels at various time intervals between DEX group and NS group, showing maximal effect at post of 24-hour duration. P-value statistically significant. Discussion. Amin and Dian study shows two groups on pump and off pump, in which serum PCT levels were more during the on pump cardiac surgery compared to off pump. Ukai et al. Study shows DEX decreases HMB, B1 inflammatory marker, and IL-6 levels decreased compared to control group. Lee B et al. Study shows that Dexim decreases the IL-6, TNF alpha, and IL-8 inflammatory markers levels compared to the control group. Conclusion. Administration of intravenous injection dexmedetomidine at induction and continuous post-operative infusion for 48 hours showed decreased serum PCT levels with maximal effect at 24-hour post-op duration after CPB for single valve replacement surgery, suggesting anti-inflammatory effects of Dexim. However, more adverse effects were seen like vomiting, sleepiness, hypotension, bradycardia in the Dex group compared to control group. These all are my references. Thank you very much.
Rajeshwar, my question is, if you weigh the
Yes, sir.
disadvantages like more sleepiness, more drowsiness, and as compared to this decrease in the SIRS, systemic inflammatory response, okay, what is your conclusion regarding we should use the dexamethasone routinely?
Sir, to prevent the complications due to inflammation, according to my references and different studies, I have noticed that by giving Dexim in the induction and in infusion in post-operative period, we can decrease the inflammatory side effects, which will increase the chances of reinfection, decrease the chances of reinfection or side effects of inflammation. So Dexim will be helpful.
So you routinely recommending that Dexim should be used?
Yes, sir, because Dexim will also have the analgesic effect and will decrease the inflammation due to CPB.
Okay. Thank you very much. Next presentation, please.
Thank you, sir.
Thank you.
Study the efficacy of 2-chlorprocaine by addition of fentanyl for intrathecal use in surgeries below umbilicus. Good morning, everybody. My name is Dr. Pranitha Kale. My topic for today's paper presentation is to study the efficacy of 2-chlorprocaine by addition of fentanyl for intrathecal use in surgeries below umbilicus. Introduction. Spinal anesthesia is safe and reliable technique for below umbilical surgical procedure. Preservative-free 2-chlorprocaine is an effective alternative for the same. The use of single dose of 30 mg 2-chlorprocaine may provide good anesthesia with lesser side effects, but its duration may last only up to 40 minutes. We can overcome this by addition of an opioid like fentanyl to 2-chlorprocaine that will prolong its action. Need for study is by studying the effects of addition of fentanyl, we can get a new adjuvant drug for 2-chlorprocaine, which not only has a good and prolonged operative analgesic duration, but also reduces the need of prolonged post-operative admission of patients after surgical procedure due to its faster reversal of action. Aim comparison of conventional dose of 2-chlorprocaine with 2-chlorprocaine along with fentanyl and spinal anesthesia for patients undergoing below umbilical surgeries. Objective: to determine and compare the onset and level of anesthesia in both the groups, to determine and compare the duration of sensory and motor blockade in both the groups, to determine and compare the degree of sensory motor blockade in both the groups, to determine if there is any side effects with addition of fentanyl. Materials and method. Inclusion criteria: patients between the age groups of 18 to 60 years, patients undergoing elective surgeries below umbilicus under spinal anesthesia, all patients of ASA grade 1 and 2, estimated surgical procedure time not exceeding more than 45 minutes, patient given consent and ready to undergo the study. Exclusion criteria includes patient with ASA grade 3 and 4, patients with known allergy to local anesthetic, obese patients, estimated surgical procedure time extending more than 45 minutes, patients age less than 18 years and more than 60 years, patient not giving consent to undergo the study. Study design: it was a prospective single-blinded randomized control study conducted from September of 2019 to October 2021 in Tertiary Care Center of D.Y. Patil Hospital, Kolhapur. Study population: patients undergoing elective surgeries below umbilicus under spinal anesthesia for short surgical procedure was a study population. Methodology: after approval of ethical committee, study has been started in September 2019. Data collection was done till August 2021. Written informed consent was taken from every study participant. Patients were evaluated and educated about the merits and demerits of the study. Patients were prospectively randomized into 2 groups with 30 patients in each group using method of computerized generated randomization schedule. Group A patients were administered with 30 mg of 2-chlorprocaine intrathecally. Group B patients were administered with 30 mg of 2-chlorprocaine with 25 mcg of fentanyl intrathecally. Results: in a study, we have found that the onset of sensory block with 2-chlorprocaine and fentanyl faster with 2-chlorprocaine alone and statistically significant. The duration of analgesia was found to be more with addition of fentanyl with 2-chlorprocaine. The duration of motor block with 2-chlorprocaine and fentanyl was prolonged than 2-chlorprocaine alone, and it was statistically significant. The incidence of pruritus was more among the group with fentanyl. discussion with the discovery of specific opioid receptor by Perth and Schneider in 1973 and subsequent identification of these receptors in the substantia gelatinosa of spinal cord, a new enthusiasm was created for the clinical application of opioid to the subarachnoid space. The patients undergoing below umbilical surgical procedure, combination of intrathecal use of the isobaric 2-chloroprocaine 30 mg with 25 mg fentanyl was found to be reliable in maintaining the quality of block. In an evaluation of efficacy of intrathecal fentanyl with 2-chloroprocaine on the characteristic of subarachnoid block in patients has concluded that the addition of fentanyl significantly improved the onset and quality of the block while prolonging the duration of analgesia without any major side effects. Conclusion: in a study among the two groups, with one receiving 2-chloroprocaine 30 mg alone and other receiving 2-chloroprocaine 30 mg with fentanyl, we have found that the group receiving fentanyl showed faster onset of sensory and motor blockade with longer duration of action. Also, in group receiving 2-chloroprocaine plus fentanyl, there was prolongation of time required for rescue analgesia. Further, it was observed that the group receiving fentanyl with 2-chloroprocaine, time required to void was increased, and the incidence of pruritus was more among the group receiving fentanyl. There was no statistically significant difference between two groups with respect to hemodynamic parameters during intraoperative as well as postoperative period. Here are my references for the following. Thanking you.
Thank you, Priyanka. As you already mentioned in your paper, that pruritus is a very common side effect. And my question is how you are treating this pruritus in patients who are developing this?
Actually, sir, only 1 or 2 cases were encountered with pruritus. Hello?
Yeah. Please.
Hello?
Yeah. Only 2 cases you detected this type of side effects like pruritus.
Yeah,
okay.
Yes, sir.
So what treatment you are given for that?
Sir, AVIL was given, sir.
And was it effective?
Injection.
Yeah. Was
Yes,
it
sir.
effective?
Yes, sir. It was quite effective.
Because this is the most of the time the fentanyl is not used in this, because whenever this happens, it produces intense pruritus and near about intense vomiting. So to counteract, most of the time we have to give steroids too. Okay, you are lucky enough that your patient has treated well with the AVIL, but these are the common side effects.
Yes, sir.
Your paper was nice. Okay, thank you.
Thank you, sir. Thank you, sir.
Next presentation.
Hello, sir. Dr.
Yeah.
Suji, sir.
Yeah.
Sir, all the presentation has been done.
Done?
Yes.
Okay. Should I leave the meeting? Thank you very much.
Okay, sir. Thank you so much, sir.
Okay.